Guyana. The Honorable Dr. Frank Ashley, Minister of Health, Guyana. The Honorable Dr. Terence Drew, Prime Minister in Kitts and Nevis. Dr. Carla Barnett, CARICOM Secretary General. Dr. Lisa Indar, Executive Director, CARPHA, and other senior managers. Dr. Rhonda C. Thomas, Assistant Director, PAHO, WHO. Mr. Marshall Seychelles, Deputy Director General, European Union. Ministers of Health, Permanent Secretaries, and Chief Medical Officers of CARPHA member states. Members of the Diplomatic Corps, members of the Research Advisory Committee, sponsors, exhibitors, specially invited guests, conference delegates, media, ladies and gentlemen, good morning. I am Minerva Singh, Chair of the Research Advisory Committee for CARPHA, and it is my honor to be the chairperson this morning. We have watched this conference grow over time, and this conference, I predict, will be no different in terms of its impact that it will have. Ladies and gentlemen, without much ado, I will ask Dr. Lisa Indar, our Executive Director of CARPHA, for her opening remarks.
His Excellency Dr. Mohammed Zulfan Ali, President of the Corporate Republic of Guyana, the Honorable Dr. Terence Drew, Prime Minister of St. Kitts and Nevis, the Honorable Dr. Frank Anthony, Minister of Health Guyana, Dr. Carla Barnett, CARICOM Secretary General, Dr. Rhonda C. Thomas, Assistant Director, PAHO WHO, Mr. Martin Seychelles, Deputy General of the European Union, Regional Ministers of Health, the Honorable Kevin Hilda, Minister of Health Belize, the Honorable Cassani Lavi, Minister of Health Dominica, the Honorable Philip Telesford, Minister of Health Grenada, the Honorable Lakram Wood, Minister of Health Trinidad and Tobago, Permanent Secretaries and Chief Medical Officers of CARPHA member states, members of the Diplomatic Corps, His Excellency Dr. Leslie Ambassador of the Corporate Republic of Guyana, to the Swiss Confederation and Permanent Representative to the United Nations and other organizations in Geneva, Switzerland, Her Excellency Spiegel Terrier, Ambassador to the United States Embassy, Guyana, and other representatives of the U.S. State Department of State, Her Excellency Ms. Cristina Perez, non-resident ambassador of the Embassy of the Kingdom of Spain, Her Excellency Mary Velasco, non-resident ambassador of the Embassy of Sweden, Ambassador Luca Perry-Martoni, delegation of the European Union to Guyana, Suriname, and CARICOM, as well as other representatives of the EU delegation, international donor partners, the delegation of the European Union, the Pandemic Fund, World Bank, PAHO, UK, HSA, IB, other partners, CARICOM Secretariat, RSS, NIH, Health Economics Unit UE, Ross University, St. George's University, King's College, U.S. Department of State, scientific secretaries, and members of the Research Advisory Committee, their wardens, Professor Elsie LaFranc and Dr. Moti from above, featured speakers, platinum sponsors, Nobel Health Council and China Sanford, Barnett and Mount Sinai International, silver and bronze sponsors, exhibitors, specially invited guests, conference delegates, members of the media, ladies and gentlemen. Good morning. It's both an honor and a profound privilege to welcome you to the 70th Annual Health Conference of the Caribbean Public Health Agency, CARPHA, here in this beautiful Georgetown at the renowned Arthur Chung Conference Center. Today, we gathered in proud collaboration with the government and Ministerial of Health Guyana, and I extend my sincere appreciation for their steadfast support, partnership, and warm hospitality in hosting this landmark event. This year's conference holds special significance as CARPHA's longest-running flagship event
It stands as the premier scientific forum in the English-speaking Caribbean. And today, we celebrate not just another conference, but a legacy, a platinum jubilee. 70 years, 7 decades of Caribbean-led scientific excellence. Seven decades of evidence shaping policy, strengthening systems, and saving lives. 7 decades of unwavering commitment to advancing public health in our region. This is more than a conference. It's a testament to the power of Caribbean operational research, collaboration, and our regional solidarity. And it is especially fitting that we celebrate this milestone along Guyana's 60th independence anniversary, its diamond jubilee under the theme Homecoming. There could be no more meaningful backup for this gathering of Caribbean minds, united in purpose, returning to what matters most, the health and well-being of the people. We all know the health of the Caribbean is the wealth of the Caribbean. This year's theme, Innovations in Health, could not be more timely, and at a more fitting host country that is pioneering health innovations. Today, in a world of shifting, new and emerging infections, reeling from the devastating global impact of COVID-19 pandemic that showed us gaps in our health systems and the need for coordinated multi-sectoral real-time detection and response for transboundary spread of infectious diseases. Today, in the world of rapid digital transformation, reducing funding landscapes, geopolitical shifts, and rising infidelity, we now stand at a threshold of a new era, one where health innovation is not optional, but essential. We are now in a world where technology, digital solutions, scientific breakthroughs, and local ingenuity are critical for transforming how we prevent disease, deliver health care, protect populations, and save lives and livelihoods. Innovations is redefining health, from AI-powered systems that can detect outbreaks before they spread, to rapid genomic sequencing that helps us understand and respond to emerging threats, to telemedicine and mobile clinics that bring care to the most undeserved, underreached communities. Public health innovation is not just improving lives, it's reshaping them. It is helping us detect pandemics faster, respond smarter, and recover stronger. It is reducing disparities, increasing access, and strengthening resilience. It is empowering individuals, communities, and nations. And here in the Caribbean, we are not merely adopting innovation, we are creating it. At CARPHA, we are proud to be advancing a suite of cross-cutting Caribbean-tailored innovations, purpose-built for the realities of our region, from regional integrated real-time digital surveillance system, social listening early warning tools, and early warning response tools. CARPHA's fictitious island teamwork simulation exercise and timeliness metrics to strengthen laboratory networks and forward-looking workforce development programs. These innovations are designed not just for our region, but by our region. They respond to the unique geographical, social, and economic context of the Caribbean, our small island developing states, our interconnected borders, our economies, our tourism dependency, our limited capacities, and our vulnerability to climate-related threats, and our reliance on resilient health systems. These innovations are enabling earlier detection, faster response, smarter decision-making, and stronger coordination across boundaries. They are helping us move from reactive to proactive public health, anticipating risks before they escalate, and protecting our population with greater precision, confidence, and coordination. Over the next 3 days, this conference will showcase the very best
of health and innovation, with 12 globally acclaimed feature speakers from leading institutions, including Pandemic Fund, UKHSA, Midway Immunology and Research Center, BPG Bio, and world-renowned universities such as Oxford, Harvard, McMaster's, Imperial College London, University College of London, and the University of the West Indies, and CARPHA, bringing global expertise to regional priorities. This 70th edition is truly historic, not only because of the legacy it represents, because of what we have achieved together. Quite simply, we have outdone ourselves. We have pushed beyond ourselves, pushed beyond expectations. We have exceeded what we once thought impossible. And in doing so, we have elevated this conference to new heights. Distinguished representatives from the highest level of government and Guyana are in attendance here today, along with key regional and international partners, reflecting the strength of collaboration that underpins the conference. For the first time, we will be convening a high-level ministerial panel with ministers of health from across the Caribbean, underscoring the critical link between research, innovation, and policy shaping resilient systems. And what we are witnessing this year is nothing short of phenomenal. An unprecedented gathering of minds, bringing together almost 500 participants, the highest in our history. A vibrant and dynamic network of 35 exhibitors and partners showcasing innovations in action. A truly global exchange with representatives from over 20 countries, including the UK, Guyana, Canada, Barbados, Jamaica, Cayman Islands, Martinique, Trinidad and Tobago, Suriname, Grenada, USA, St. Lucia, Belize, Antigua, Curacao, Italy, and CARPHA. An overwhelming scientific response. 211 people submitted, with 196 accepted, a record-breaking achievement that speaks volumes of the strength, relevance, and momentum of health research in our region. We will experience cutting-edge research presentations and posters addressing the most pressing issues of our time, ranging from innovation in health to women's health, HIV, mental health, climate health, nutrition, and more. Our dynamic exhibition hall offers opportunity to engage with emerging technologies, surveillance information, and ground-shaping innovations that shapes the future of health. This is the space to connect, to share, to learn, and to be inspired. As we look ahead, we are reminded that innovation is not just about technology. It is about us, the people. It is about the researchers who push boundaries, the policymakers who translate evidence into action, the healthcare workers who bring innovation to life, and the communities who trust us to deliver better health outcomes. Together in this room, we represent the region's leading minds in health research and public health practice. We are not just participants in this conference, we are the architects of the Caribbean's health future. This conference will accumulate in a fitting finale, our award ceremony, where we will honor excellence in Caribbean health research. We will celebrate stalwarts such as Dr. Elsie Lefranc and Dr. Moti Ramgopal, whose contributions have shaped our region, and we will recognize the next generation of researchers who will carry this legacy forward. As we celebrate 70 years, we also look at the future. I am pleased to announce that the 71st Annual Health Conference will be hosted by the Ministerial Health Grenada in collaboration and convened at the St. George's University. As we move forward over the next few days, let me take a moment to express sincere appreciation to the government and Ministry of Health Guyana, the visionary Dr. Frank Anthony from the Minister of Health Guyana. Thank you for your leadership, your partnership, your gracious hosting of this milestone conference. Your commitment to advancing health in our region is deeply valued. To the right, Ministry of Health and CARPHA teams across every unit, every function, every day, thank you. To our partners and our sponsors, thank you. This conference is a reflection of your dedication, your excellence, and your belief in what we can achieve together. It is no small feat to deliver an event of this magnitude, and you have done so with distinction. And to everyone who is here, who is seated here today, thank you for being here at the 70th conference and innovation by itself. Thank you for your commitment in advancing health in the Caribbean, and thank you for being part of this remarkable journey. Let us make the next 3 days count. Let us challenge ideas, speak innovation, strengthen partnerships, and shape a healthier, more resilient Caribbean for generations to come. Thank you very much.
Thank you very much, Dr. Indar. Can I now invite Dr. Rhonda Steely Thomas, Assistant Director, PAHO, WHO.
Thank you, Madam Chair. His Excellency, Dr. Mohammed Ikram Ali, President of the Cooperative Republic of Guyana, Honorable Dr. Frank Anthony, Minister of Health and Wellness of Guyana, Dr. Carla Barnett, Secretary General of the Caribbean Community of CARICOM, Dr. Lisa Indar, my dear friend, Executive Director of the Caribbean Public Health Agency, Mr. Martin Zisha, Deputy Director of the European Union, Ministers, members of the Diplomatic Corps, Chief Medical Officers, colleagues, good morning. On behalf of Dr. Jarvis Barbosa, Director of the Pan-American Health Organization, PAHO, I extend congratulations to the Caribbean Public Health Agency for its steadfast commitment to advancing health research in the region. Scientific research saves lives, improves the health and well-being of our populations, and strengthens our economies. In today's rapidly evolving health landscape, health research is the engine that drives innovation, transforming lives into practical solutions that improve prevention, diagnosis, treatment, and health systems performance. Through research, we generate the evidence that enables innovation, from digital health tools and artificial intelligence that strengthens surveillance and early warning systems to advances in genomics, point-of-care diagnostics, and climate-resilient health solutions. The Pan-American Health Organization is committed to advancing research as an essential public health function, one that drives the discovery of cures for diseases and the development of safe and effective diagnostic tests, vaccines, and public health innovations. For this reason, at PAHO, we recently launched our Clinical Trial Accelerator to strengthen research across the Americas. The Clinical Trial Accelerator is PAHO's umbrella initiative to enhance the quality, scale, and impact of clinical research across the Americas. Through this effort, we envision large-scale collaborative multicultural trials that are led by researchers from our region and focused on developing innovative solutions to our specific health needs. This accelerator is grounded in 3 interrelated pillars. Firstly, international ethical and regulatory standards. Secondly, efficiency. And thirdly, collaboration. Our research achieves greater impact when we work together, pooling expertise and resources to conduct large studies capable of generating meaningful results. At the same time, collaboration requires a shared set of rules. The internationally recognized ethical and regulatory standards that underpin quality and impact. Without strong ethical standards, people may be unwilling to participate in research, and studies may not be completed. This is one of the leading reasons that trials failed to reach completion in our region. And without regulatory standards, national regulatory authorities cannot reliably assess the safety and efficacy of the products under study. The 70th annual CARPHA Research Conference marks an important milestone. It offers a valuable opportunity to celebrate sub-regional achievements and contributions, including the numerous studies that will be presented during this conference. It is also an occasion to reflect on how we can increase the production of health research in the Caribbean and maximize the impact of research efforts across Caribbean countries and territories. If we are to significantly increase the impact of health research in the Caribbean, the question we face today is this: how do we establish a system that sets ethical and regulatory standards for research across the Caribbean, one that is both efficient and capable of catalyzing research collaboration? I invite you, as part of this 70th CARPHA Health Research Conference, to take a moment to reflect on this question. Your response has the potential to not only empower Caribbean researchers, but also to shape the next 70 years of health research innovation in the Caribbean. In closing, permit me to attempt to convey my emotions at this time. I started to attend the CARPHA Research Conference as a medical student. That progressed to the when I was a medical doctor, and then as the Chief Medical Officer of the Antigua and Barbuda. And now, as the Assistant Director of the oldest public health agency in the world, I have the honor to address you today. Words cannot truly describe, at this moment, the honor and the privilege it is for me to be here at this historic event. Thank you so much.
Thank you very much, Dr. Phoebe Thomas. I'll now ask Mr. Martin Seychelles, Deputy Director General, European Union, to bring his remarks.
Thank you, Madam Chair. Your Excellency, Mr. President, Excellencies, Honorable Ministers, distinguished participants, ladies and gentlemen, good morning. First of all, I'd like to express my deep appreciation for your kind invitation to allow me to address you today here in beautiful, vibrant Guyana. We are living at a time when health threats increasingly cross borders, whether they are climate-related risks, antimicrobial resistance, or disruptions in access to medicines. In all these situations and many others, regional cooperation has become essential. Regional cooperation transforms shared vulnerability into collective strength by pooling expertise, building trust, and creating common solutions. Health security is and must be built long before crises emerge, through preparedness, through standards, and through institutions that connect countries rather than isolate them. And this is why CARPHA matters. It builds regional health security. Through surveillance, laboratory cooperation, preparedness, data sharing, and coordinated public health action, it can help to protect citizens across the entire region. The European Union is proud to work alongside CARPHA in strengthening that collective resilience. Through our Global Gateway strategy, we invest not only in infrastructure, but we also aim to improve systems, institutions, and partnerships that make health systems strong. A key example of this is PharmaNext, our flagship Team Europe initiative supporting the Caribbean across the full pharmaceutical and health value chain, helping strengthen regulatory systems, improving access to safe medicines, supporting healthcare workforce development, reinforcing health service delivery, and fostering innovation in life sciences. The messages I would wish to convey today are simple. Health systems are strongest when regulation, skills, innovation, and regional trust advance together. and health security is built long before crises emerge through preparing standards and institutions that connect countries. The challenge ahead is to ensure that progress remains sustainable, inclusive, and reaches all Caribbean communities while deepening cooperation across countries and institutions. CARPHA is a natural partner in this effort, helping build these shared standards, support regulatory cooperation, and creating regional solutions to common health challenges we all face. The European Union remains and will remain a committed long-term partner to CARPHA and to the Caribbean region. Together, we are building health systems that are resilient, inclusive, and future-ready. Thank you.
Thank you very much, Mrs. Seychelles. Can I now invite Dr. Carla Barnett, CARICOM Secretary General, to give her greetings.
Thank you very much for permitting me simply to recognize His Excellency Dr. Mohamed Irfan Ali, President of the Cooperative Republic of Guyana, ministers, ED, CARPHA, all special invited guests, representatives of regional organizations, ladies and gentlemen. Good morning. I am really pleased to join you for this opening of the Caribbean Public Health Agency's 70th Annual Health Research Conference. The focus on innovations in health as a deliberate strategy to safeguard our future builds on the 2011 vision of the heads of government of the Caribbean community when they established the Caribbean Public Health Agency as an effective declaration that CARICOM would move as one in matters related to health. This collective approach, grounded in surveillance, laboratory strengthening, and research, remains one of our most critical defenses against health threats. CARPHA, as the region's premier public health agency, works in collaboration with member states and other institutions, allowing for an inclusive approach in managing complex issues. This is bolstered by scientific research undertaken over many decades by the University of the West Indies, alongside other regional and international universities, independent researchers, and scholars around the world. It is this broad collaborative effort that transforms raw data into today's life-saving policies and interventions. Across the community, as we've been hearing, at this set of meetings this week, there are a number of tangible examples of innovation being employed to strengthen our health systems. Several member states are advancing smart and green health facilities and supporting continuity of services, particularly in times of crisis. In Jamaica, ongoing digitization efforts, including the expansion of electronic health records, are improving continuity and the quality of care. Here in Guyana, the use of telemedicine to reach remote rural communities is addressing long-standing geographic barriers to access. During the COVID-19 pandemic, countries rapidly deployed digital platforms integrating travel management with public health surveillance. Increased investment in laboratory networks and genomic surveillance have strengthened the region's capacity to detect and respond to emerging threats. At the same time, as we've heard, mobile health outreach models continue to extend essential services to underserved communities. These are just some of the initiatives that demonstrate how innovation is being applied in practical ways to advance equity, resilience, and system performance across CARICOM. As we look to the future, the nature of innovation is already shifting beneath our feet. We are entering an era where artificial intelligence, genomics, and digital health platforms are no longer futuristic. but offer an immediate path to leapfrog historical barriers. Imagine a Caribbean community where genomic research enables us to tailor non-communicable disease treatments to our complex genetic heritage, or AI-driven surveillance that predicts a pandemic outbreak weeks before it hits our shores. These are the game-changing possibilities to safeguard the health and resilience of the people of the region. However, these possibilities come with a heavy responsibility. Innovation must be anchored by regional sovereignty, which responds to hard questions, some of which are being addressed by this conference this week. Who owns the data generated in our clinics? How do we ensure our citizens are not just data points for external extraction, but are the primary beneficiaries of the breakthroughs? How do we build a biobank that protects our biological assets while advancing global science? Our goal must be a model of health innovation that is sovereign, fair, and rooted in trust. Ladies and gentlemen, this 70th milestone belongs first and foremost to the individuals whose curiosity leads the research agenda. These are the students, the researchers, and the seasoned academics who year after year produce the evidence that fuels our progress. I acknowledge the critical work undertaken by the Research Advisory Committee and the various ethics bodies in our member states. They are the guardians who ensure that Caribbean research meets the highest global standards and that our science is not just good, but also ethical and just and in the interest of our Caribbean people. I also recognize the sterling work of the dedicated staff at CARPHA and those in academia who continue to be anchors of excellence and contribute to our collective knowledge. You have proven that when small states and institutions that serve them work in harmony, we do not just follow global trends. We lead the world with clarity, purpose, and principle. However, to be fully equipped for the new era, our professionals need new instruments in their toolkit. We need more researchers who understand public policy, data analytics, and ethical governance, and who are ready to make the paradigm shift required to accelerate our collective actions. We must ensure an inclusive approach that involves our people in their communities. If our people do not trust innovation, they will not adopt it. Our research must stay relevant, speak to the needs of the mothers in a rural or remote village as clearly as it does to a scientist in a laboratory. Distinguished guests, the decision in 2011 to bring together 5 separate regional institutions operating in the health sector to more efficiently and effectively lead our Caribbean region in the development and implementation of critical health policies and programs for our member states reflected the recognition that regional collaboration and cooperation is our greatest strength. As we navigate the complexities of 2026 and beyond, this recognition must remain our guiding principle. As a region, we possess skills, expertise, and competence to continue to shape a Caribbean model of health that is inclusive, ethical, and focused on the needs of the Caribbean people. This 70th edition of the Health Research Conference is evidence of that. I wish you all a productive and a transformative conference and look forward to the deep conversations that you will have and the many recommendations that will flow from the work that is ongoing. Thank you very much, ladies and gentlemen.
Thank you, Dr. Barnett. I now ask the Honorable Dr. Frank Anthony, Minister of Health, Guyana.
His Excellency President Dr. Mohammed Irfan Ali, Honorable Ministers of Health, Heads of Delegations, Dr. Carla Barnett, Secretary General of CARICOM, Mr. Martin Seychelles, Deputy Director General of the European Commission, Dr. Rhonda Seeley Thomas, Assistant Director of the Pan American Health Organization, Dr. Lisa Indar, Executive Director of CARPHA and our team, Dr. Priya Basu from the Pandemic Fund, esteemed researchers, scientists, and health professionals, ladies and gentlemen all, good morning. It is an honor to stand here at the 70th CARPHA Research Conference, a milestone in reflecting longevity and sustained excellence in advancing public health in the Caribbean. Let me extend heartfelt congratulations to CARPHA, its leadership and staff, and the researchers who have built this legacy. 70 conferences mark 70 moments of inquiry, discovery, progress, and decades of Caribbean minds committed to solving Caribbean problems through Caribbean science. This is certainly something to celebrate. I also want to extend warm welcome to everyone visiting Guyana. We are truly honored to host you in our beautiful country. Whether this is your first visit or one of many, I hope that you will experience not only our hospitality, but also see the commitment to advancing health, science, and development. Guyana is undergoing a period of transformation, one where investments in health systems, digital innovation, and human capital are shaping a stronger and more responsive future for our people. And it is fitting that this important conference is being held here, because the work aligns directly with the journey that Guyana is on. But today it's not only about looking back, it's also looking forward. We meet at a time when the world is changing at an unprecedented pace. New technologies are emerging, old diseases are reappearing in new forms, non-communicable diseases continue to place a heavy burden on our populations. Antimicrobial resistance threatens to undo decades of medical progress. And alongside all of this, we also face an infodemic, a flood of misinformation that challenges the trust in science itself. In such a world, research is not optional, it is essential. Research is how we see clearly in a world clouded by uncertainty. It is how we move from assumption to evidence. It is how we transform challenges into solutions. CARPHA has played a pivotal role in shaping the research culture of our region. From its origin to its current mandate, CARPHA has evolved into the center of excellence, providing surveillance, laboratory services, policy guidance, and more importantly, a platform for scientific exchange. This conference, year after year, has become one of the most important spaces for sharing, challenging, and strengthening Caribbean science. And that matters, because if we do not generate our own data, others will define our realities for us. If we do not publish our findings, our stories remain untold. And this brings me to a critical point, the importance of publication. Research that is not published is research that is not fully realized. Publication is not merely an academic exercise. It is an act of influence. It ensures that our findings inform policy, guide clinical practice, and contribute to global knowledge. It places Caribbean science on the world stage, and it allows our voices and our evidence to shape the international discourse. We must therefore strengthen a culture in which research does not end in the laboratory or at the conference podium, but continues in peer-reviewed journals, policy briefs, and implementation frameworks. We must mentor young researchers, not only to investigate, but also to write, publish, and lead. But beyond publication, we must also focus on innovation. Innovation is not only about high technology, it's about solving problems in practical, scalable, and impactful ways. And at this conference, we have amassed many examples, and you will see them in the exhibition booths. Innovation is a community health worker using telemedicine to improve the care of patients in remote regions. It is the integration of digital health tools so that we can improve the efficiency of care. In the Caribbean, innovation must be rooted in our realities. It must address our geography, our resource constraints, and our unique epidemiological profile. That is why research and innovation must go hand in hand. As policymakers, we have the responsibility. We have to create environments where research can thrive. We have to invest in laboratories, in data systems, in training. We must build partnerships, regional and global. And more importantly, we must ensure that research findings are translated into action. Because the ultimate goal of research is not publication alone. It must have an impact. It must lead to better outcomes, better health outcomes. It must lead to stronger health systems. It must result in longer, healthier lives for the people of the Caribbean. Today, as we open the 70th Research Conference, let us commit and recommit ourselves to a few fundamental principles. That science must guide our decision, that collaboration must define our approach, that innovation must drive our progress, and publication must amplify our voice. And if we do this, then this conference would have been a success. I wish you
I invite His Excellency Dr. Mohammed Usman Ali, President of the Cooperative.
Thank you. Thank you very kindly. Thank you. Please have your seats. The distinguished ministers of health, our dear Secretary General, the entire leadership of CARPHA, members of the diplomatic community, and some very special people in the room because they happen to be Guyanese. You're all Guyanese when you're here. But I have to mention Dr. Moti Ramgopal, Dr. Nivin Narain, Dr. Mahadyo, and then we have some honorary Guyanese. Dr. Rachel, she's here? Yes. From Mount Sinai Health System. And they're doing a tremendous job in helping us to take primary health care to every home. And importantly, yeah, I know we have him, yeah. And importantly, to help develop the baseline data for the next generation of Guyanese so we start their health care from birth and we're able to better manage budgets and policies to deal with public health challenges. We also have another honorary Guyanese, Dr. Eric from the Northwell Health System. And they are working with us on the development of our emergency management system, making it world-class. And of course, many other developers from around the world who are assisting us in building out what we want to be a world-class health ecosystem, not healthcare, health ecosystem that will allow us to position Guyana as a leader in health services and healthcare across the region and globally. Before I started, I asked my staff to do a quick survey, and I wish to present the findings of that survey because it is your thinking, and I think it's important for us to examine the way you're thinking before the conference begins, because that tells us a lot about the public policy. So if the guys can assist me in getting those two slides up. Innovation, yes. So the first slide here, we asked a question among all of you. What are the 3 top priorities of a modern health ecosystem? You will see 30.8% of you believe it's improve patient access and convenience. 22.2% enhance health outcome and quality of care. 20% increase system efficiency and reduce costs. Structural and technical transformation, 12.5% of you believe that, and improve patient and provider experience, 14.2%. So the top 3 priorities in this room would be improve patient access and convenience, enhance health outcome and quality of care, and increase system efficiency and reduce costs. The important question here is whether our thought process is driven by innovation or is driven by public perception. Is it driven by problems we encounter or driven by the feeling of our population? And if our thought process is confused in that matrix, we'll find it very difficult to innovate because we'll consistently be in that triangle of public opinion that does not allow us to make bold decisions and take bold steps into the future. The second slide I wish to share with you, what are the top 3 barriers to healthcare modernization? Of course, many of you said finance, 25% of those who responded. Then look at what comes second, technology, 23.4%. Then 29%, is human capital. So first is human capital, second is finance, and third is technology. So human capital is a major challenge. We cannot speak about innovation if we do not have a comprehensive understanding of what that human capital gap looks like in the region and how we are going to build this human capital. How are we going to develop this human capital to meet what we want to innovate, to achieve? So I think these 2 slides should be utilized during the course of your discussions over the next few days, because it is important for us to address these problems. Now, one important thing here is legislation and regulation. I think the thinking process is too medical and too patient-oriented. So it does not allow us to be outside of the box. Researchers are too much in the frame of health sciences and not the entire ecosystem. Because we know, for a matter of fact, that our legislations and regulations cannot allow us to innovate. They are old, they're outdated. Some of them is not linked to the realities of modern healthcare and modern systems. And only 12.1%. So perhaps sometimes in the room, you need that expansion of the ecosystem to allow a more holistic discussion around this subject matter, because it's a very important subject matter, that of innovation. So I wanted to share that first, and now I'll go a bit into some more structured thoughts that I want to share with you. And I want to join the Minister of Health in extending a warm Guyanese welcome to all those gathered here this morning, but especially to those persons who traveled from our sister Caribbean countries and further afield. Welcome to Guyana. This morning, I want to speak directly to your theme, innovations in health. Innovation has always driven medical progress, and we must never underestimate the importance of science, technology, and innovation in advancing healthcare throughout history. Consider what reduced surgical mortality with antiseptics, what defeated many of the world's infectious killers, vaccines and antibiotics, what made diagnostics faster and more precise, X-rays, CT scans, MRI imaging, lab science, and now artificial intelligence. What transformed survival rates in heart disease and cancer, better medicines, minimal invasive procedures, precision medicine, and early screening. And what is changing medicine today? Data science, genomics, robotics, telehealth, and artificial intelligence. That speaks to the power of ideas in healthcare progress. Ironically, today we are living through a paradox in global healthcare. Never before has humanity possessed so many tools to improve health outcomes. We have artificial intelligence capable of reading scans in seconds. We have digital platforms that connect patients to clinics across continents. We have precision public health systems that can map disease in real time. We have new financing models that promise to stretch scarce resources further than ever before. Yet, despite this, health systems across the world are struggling to turn innovation into impact. The problem I want to suggest is no longer a lack of ideas. It is shortage of systems that can absorb, govern, finance, and scale those ideas fairly. In many ways, the frontier of global health innovation has shifted. It is no longer defined primarily by invention alone, but by institutional capability. It is a question of whether countries have the regulatory strength to evaluate new technologies safely, the workforce capacity to use them efficiently, the digital infrastructure to support them, the financing systems to sustain them, and the social trust to ensure they're accepted by the public. Innovation today succeeds or fails not in laboratories, but in health ministries. Procurement offices, rural clinics, and community settings. Against this backdrop, I want to address the interlocking challenges that define the global struggle to make innovation truly serve health equity. The first challenge is, how do we scale up? And this is an important challenge, important issue. Fortunately, we live in a region where our entire population size can be a pilot. But guess what? We do not have the ecosystem, the infrastructure, the legislations, or the regulations to allow our societies to be pilots. We have an ethnic mix that is essential for pilots. Yet, how many pilots were conducted in this region? And they were not conducted here because we don't have the ecosystem to support those pilots. So how are we going to be pioneers? How are we going to be ahead of the game? How are we going to be leaders if we don't examine the ecosystem and design the model as to how this region will become a pilot for new technology, research and development, and be part of a global system of advanced medicine and technology. So that is the first mission maybe of this conference, to examine the gaps and come up with a document that can be shared among leaders in the region as to how we position this region, that is a pilot size, really, to be part of this model. That will give us first access, and that will give us scale very quickly. The persistent difficulty of moving from pilot projects to population-wide systems across low, middle, and even high-income countries is the problem. There is no shortage of successful demonstrations. Telemedicine pilots that improve access in remote communities, mobile health applications that improve adherence, AI tools that enhance diagnostic accuracy, and community-based diagnostic innovations that bring care closer to patients. Today, in Guyana, we've embraced telemedicine because of our geographic layout. And we've already seen great success. We have seen lives saved. We have seen need for medical evacuation reduced. And we have seen greater support by specialist staff to others in hinterland and remote areas. I think per capita, we may have the highest telemedicine reach, maybe globally, but definitely in this region. And we are ready to deploy this investment for the rest of the region. We are ready to partner with the rest of the region in creating a telemedicine hub here in Guyana to support the rest of the region, whether it's for clinical care, research, or educational purposes. Second is using AI. Speed and accuracy is important in care. Historically, maybe it will took us a day to organize a scan and then a day to read the scan. Today, we can get that scan done and get it read and evaluated within 3 minutes with AI. We have bought into the technology that allows us to do that here in Guyana. And we are ready to scale that up to the rest of the region. We have already implemented it in 4 of our facilities, and we would love to share that experience with you. Yet many of these tools remain trapped at that pilot stage. They do not become routine services. The reasons are not technical failure, but systemic weakness, fragile financing structures, outdated procurement systems, limited governance capacity, and weak operational infrastructure. As the World Health Organization has emphasized, governments must not only adopt innovations, but lead structured process of learning and adaptation. Without this, innovation remains episodic rather than transformative. And this is a major problem in the region. If you look in all of the ministries of health across the region, you will see stacks of study on every problem. And then we are studying the same problem again and again. Because we do not have a clear strategy of implementation. Moving from a pilot to a scalable project. And this is where a lot of the problem resides. We have great initiatives that went through a phase of testing, and after the testing, that's it. Back to routine. We have to be able to deal with this. Otherwise, we will not be able to achieve true transformation. The second challenge is the digital divide. Digital transformation is often presented as a technological leap forward, but in reality, it depends on much more than devices and software. It requires reliable connectivity, interoperable data systems, trained personnel, organizational readiness, and regulatory coherence. In many settings, these foundations are incomplete or unevenly distributed. Worse still is when we don't have personnel who are trained on data analysis, when we don't use data to guide our decision making. The risk of deepening inequality rather than reducing it. Innovation in this sense can become a multiplier of disparity rather than a solution to it. We have to establish the baseline. Healthcare innovation is not done in a vacuum. It is linked to data set of every citizen. It is linked to your digital ID card. It is linked to your school records. It is linked to your early clinic cards. It is linked to your travel history, which is immigration. So digitization in healthcare is how we integrate the entire system to advance a health ecosystem that is holistic. So we cannot, in my humble opinion, design a health ecosystem by digitizing health records alone. It is everything that surrounds the health ecosystem. This brings me to regulation. The third challenge is regulation. Health innovation is advancing at a pace that far exceeds the ability of many regulatory systems to assess, approve, and monitor. I'll give you a simple example. I spoke to our Minister of Health recently. Our regulators at the Food and Drug are still trying to approve Manjaro, and everybody using it. If the solution run too far ahead of the regulator because of their ineffectiveness or the ineffectiveness of the system to respond quickly, then the population will be ahead of you. The population will be ahead of you. And that is the complete collapse of a healthcare system. If the population is ready to accept a treatment or accept a technology, while the regulators are lagging behind. And it's a major problem. And it is not because we don't have good people. It is because the system is not designed to move at the pace at which healthcare is moving globally, the science is moving globally, and the technology is moving. And we can sit here and talk as much as we want and bring up all the research. If we don't fix it, we will continue to fail the population. We'll be lagging behind. We have to fix it. And we are a pilot size. With the political will, we can fix this in a day. The models are all there. We can gather all of the best lawyers in the region, parliamentary councils, and match them with the regulators and come up with one master legislation that the region can implement as a whole. Are we willing to do it? What are we safeguarding? What are we protecting? We are just a pilot size. We should be sharing, integrating, building common platform, building common systems. That is what we should be doing as a region. Artificial intelligence, digital therapeutics, and rapidly developed medical products are entering the market faster than governance frameworks can evolve. This creates tension between speed and safety. The challenge is now even sharper with generative AI and adaptive algorithms, where questions of transparency, accountability, and post-market surveillance remain unresolved. Without regulatory innovation, technological innovation risks outpacing public trust. And this conference must be able to do that. You have to find that balance. If we don't find that balance, then public trust will be eroded. The fourth challenge is inequality in research and innovation itself. Evidence from studies published in leading journals shows that global research output does not always align with global disease burden. Some of the most pressing health challenges, particularly those affecting low-income populations, remain under-researched and underfunded, while other areas receive disproportionate attention and investment. This creates a structural imbalance in innovation priorities. Health innovation risks becoming a reflection of economic power rather than global need, reinforcing rather than correcting inequities in health outcomes. And the example is right before us. The world has lost more than 60% of its biodiversity in the last 50 years. In this region, you have a country that's kept its biodiversity intact. Biodiversity and ecological services is linked with research and pharmaceutical discoveries and the biomedical area. Show me one research from University of West Indies that addressed this rich ecosystem of Guyana. You have any, Frank? CARPHA, we have any? You're having some, but you don't have any now. I'm just telling you as it is. You're looking all over the world for low-hanging fruits. It's right there. An enabling environment in the same region, under-researched. And it may have the answers for a lot of our problems. We have to fix it. I'm not lamenting it. You just have to fix it. Health innovation risks becoming a reflection of economic power rather than global need, reinforcing rather than correcting inequities in health outcomes. The fifth challenge is financing instability and the research for sustainable funding models. Global health financing is under pressure from multiple directions. Declining development assistance, rising out-of-pocket expenditures, and competing domestic priorities. At the same time, inefficiencies in health systems mean that increased funding alone is insufficient. Money must be matched with improved purchasing strategies, accountability mechanisms, and service redesign. Increasingly, global health experts argue for blended financing approaches that combine domestic resources, private sector engagement, and innovative funding mechanisms that are resilient beyond donor cycles. Without stable financing structures, even the most promising innovations cannot be sustained. The sixth challenge is human capital constraints. Innovation does not scale itself. People scale it. Yet many health systems face chronic workforce shortages, uneven distribution of health professionals, skill mismatches, and high attrition rates. The ability to adopt and sustain innovation depends heavily on training, mentorship, institutional support, and workforce redesign. Digital tools, for example, are only as effective as the people who use them. Without investing in people, technological advancement remains underutilized. And here in Guyana, we are now working with ExxonMobil to invest $30 million in a STEM education center for children at a very young age, bringing them up in an environment of science, technology, innovation. Now, one of the difficulties in our education system is not only the fact that we don't have enough children in STEM or in sciences, it's the fact that it is too expensive sometimes to maintain labs in the secondary schools or the primary schools, the reagents, and all the things that are needed to keep those labs growing. But guess what? Technology has solved that. You can use a lab, a digital lab, to do the same experiment 100 times until you perfect it, and then go into the practical setting. And again, guess what? Guyana has already invested in that for all of this region in the Guyana Digital School. And guess what? We have to go behind ministers of education in this region to get them to be excited enough to get their children to sign up on the Guyana Digital School. Here, the technology is there, the financing is there, the product is there. We have to fix this, because we will continue to have the human capital gap if we don't fix the input. We have to get children excited about science. Technology has shown us that children can be overexcited about what this new game is, Roadblocks. What, that's it? Roblox. You see, all these guys know it. The same technology can be deployed to get our children excited about science. We can't fix this human capital problem in medicine or health services if 75% of our graduates are coming out of social sciences and other areas. When the demand is in the STEM area. It's a problem. But it's a problem where you are facing the final outcome. But you are not part of fixing the system from the beginning. And that is what we need to do. Get to fixing the system from the inception. The seventh challenge is climate change. I don't know if you have it on your agenda. But if we lose our biodiversity and all our ecosystem, then what you're going to research? Where are you going to research? So the seventh challenge is climate change as a health system stress, as a health system stress multiplier. Climate is no longer an external environmental issue. It is a core determinant of health system resilience. Rising temperatures, extreme weather events, shifting disease, vectors, and food and water insecurity are already reshaping health outcomes globally. Health innovation must now account for environmental sustainability because the systems we build today must function in a climate-altered future. Very important. Whatever we build today must be able to function in a climate-altered future, different environmental circumstances. Antimicrobial resistance. All the speakers spoke about this. The eighth challenge is antimicrobial resistance, one of the clearest examples of a failure in current innovation incentives. Despite decades of awareness, AMR continues to grow, particularly in low and middle-income countries. The problem is not only scientific, it is economic and structural. There is limited financial incentive to develop new antimicrobials, and existing systems often reward overuse rather than stewardship. Without structural reform, biomedical innovation alone will not solve the problem. The ninth challenge is fragmented primary care and weak service integration. Too often, innovations are layered onto health systems that are already fragmented. You have to fix the fragmentation in the health system first. You can't layer innovation on a failed system. You have to fix the system. You have to get doctors to follow the system. You have to build practices that are implemented, not by choice, but by institution, and not layer a broken system with innovation. Rather than being used to design care delivery around patients' need, this results in duplication, inefficiency, and missed opportunities for continuity of care. Emerging evidence from global health research suggests that the future of innovation lies not in standalone technologies, but in integrated systems, primary care networks, referral pathways, data interoperability, and community-based service delivery models that work together seamlessly. Innovation must therefore move from isolated tools to system-wide architecture. An important question here is, how do we align public and private healthcare providers? Because it's a health system. It's not a private system or a public system. The system must be able to work as one. So we have to get the public healthcare system and the private healthcare system operating on one platform. Otherwise, again, we'll have fragmentation. Now, the 10th challenge is legitimacy, trust, and co-design with communities. Increasingly, global health research recognizes that technical excellence alone is not sufficient for success. Innovation fails when they're imposed rather than co-created. And we have an example here. How many students in the primary school were able to test? 84, and now in the secondary school. So we have launched a program for our children across the country. And we did that in collaboration with the parents, the teachers, and the community. Consent forms were developed that had to be signed. And we were able to screen in the primary school system more than 80,000 children. Now we're going to the secondary school system. So by the end of this year, we should have full data on all our children in the primary and secondary school system so we can better align our public health care policy. But that took time. We had to build trust. We had to create awareness. We had to let the parents and the children understand that this is part of the future. So legitimacy and trust, important. Community engagement, participatory design, and local ownership are essential for accessibility and sustainability. Now, we have to get our pastors, our imams, and the pundits to include in their sermons aspect of public health every time they speak to the congregation. And then we have to integrate our public health into their congregation, because this is a captive audience that can allow us to drive change at a faster pace. We have to get into the churches, the temples, the mosques, the community centers. That is where public health matters. That is where structural changes can occur. Not the waiting game. We wait to see what is coming at us. We have to proactively approach the health ecosystem if we want to change the dynamics of what is happening. And we have given this mandate. When people are treated as passive recipients of care rather than active partners in its design, even the most advanced interventions can fail to gain traction. If we create religious ownership, we saw during COVID the battle between religious thoughts and vaccination sometimes. So you can't underestimate religious ownership. People have trust in religious institutions, trust that is already built up. That is why we need to maximize or optimally utilize that trust that is already there in the system. Taken together, these 10 challenges reveal that the future of global health innovation will not be determined by the next breakthrough technology alone. It will be determined by whether health systems can evolve to observe, govern, finance, and scale innovation in ways that are equitable, sustainable, and trusted. I cannot leave without sharing just a few thoughts. Ezzy, should I share a few or a bit more than a few? About Guyana. Guyana is responding to the challenge of transforming its healthcare system. Let me briefly outline Guyana's the way we're revolutionizing healthcare in our country. First, we are partnering with some of the best hospitals and institutions in the world to digitize our health record system, modernize patient management, including appointments. Because we know the experience of the patient counts. And we are starting even from appointments. Secondly, we are dramatically expanding access to primary and secondary health care through the construction of 12 new state-of-the-art hospitals across Guyana. Third, we are acquiring advanced medical technology and deploying artificial intelligence in diagnostic testing. Fourth, because Guyana's geography includes vast hinterland areas and scattered settlements, we're expanding telemedicine. A mother in a remote village deserves access to specialist advice just as much as families in Georgetown. Distance should be a challenge of geography, not the basis of inequality. I'll give you an example. At the Lethem Hospital 4 years ago, 4.5 years ago, right, Vishwa? More than 90% of our patients who required not even advanced care, we say most basic care, would have had to go to neighboring Brazil or Medivac to Georgetown. Today, our referral rate is less than 2% from that hospital. From more than 90% to less than 2%. But guess what? The reverse has occurred. We are now providing services for thousands of Brazilians at the Lethem Hospital that 4 years ago could not have done that. That is what structured approach allows us to do. Where was I? Second or third? Third, we are acquiring advanced technology in the, and I said that. Fourth, because Guyana's geography, I said that too. SG. Fifth, we're incentivizing and partnering with private healthcare providers under a model of public-supported, private-delivered services. So what we have done is that we have assessed the true costs of public health care. And we brought the private sector into the room and we said, listen, guys, this is our true cost. This is your cost. Here is where we are apart. Let us come together on one cost so the patient can enjoy the same care in private or public health at the same cost. And guess what? In almost 10 services, we have already met agreement with the private sector. So it can be achieved. We just need to get in the room and have the discussions. We are not trapped in old ideological boxes that view the private healthcare system as separate and distinct from the public healthcare system. If partnerships improve care, reduce waiting time, and expand access, then partnerships make sense. 6, we are moving increasingly towards the use of 3D printing to make custom-made medical items for patients, such as artificial limbs, replacement body parts, dental crowns, and models that help doctors plan surgeries. 7, Guyana is introducing robotics in performing surgeries and drones for medical delivery of blood and antivenom products to areas not easily accessible by land or river. 8, we're intensifying the training of health professionals, including through the use of hybrid training programs. And I want to say that we're building up our nursing program and our hybrid program to be available to all of the regions soon. So we are building that up to be available to all of the regions soon. I said before that our prosperity and development must lead to regional prosperity and regional development. 9, we are developing, you guys are, I'm happy. You guys are paying attention. This is a good audience. 9th, we're developing a life science park to foster research and development in science, promote manufacturing of pharmaceuticals, and the development of a biobank. 10th, we are actively graduating towards improved precision medicine. That is Guyana's unfolding story in healthcare innovation. But we operate in a global health landscape, and we are keen on cooperation to help us overcome some of the challenges of that system. As a small state, Guyana is also subject to the vulnerability of being sidelined during global health crisis. But we are very thankful that our international partners were right by our side during the pandemic. For a matter of fact, only recently, the minister remarked that he was accompanying the US ambassador and the Indian High Commissioner almost every week to the airport to pick up vaccines. That is real partnership. We know how CARPHA worked and CARICOM. People forget that, SG. The early days of your tenure, we dealt with COVID, and we had to coordinate across the globe on how to address COVID. People think that that was a distance past. It was just a few years ago. But that is how life is. So we saw this during COVID when demand rose. The line for vaccination was an inequitable line. We cannot be content with a world in which life-saving drugs, vaccines, and technologies arrive late to our people, simply because our markets are small or these things are too expensive. Flowing from that vulnerability, we must deepen regional cooperation and strengthen South-South partnerships to enhance our capacity to respond to future health emergencies. And our response to COVID was a prime example of how important CARICOM is as an institution to our region and how better off we are as a community in CARICOM. Many countries acting together can negotiate better prices, share stockpiles, coordinate surveillance, train specialists, and pool research. We need stronger procurement system, yes. We have to build stronger procurement systems, shared medical manufacturing production, joint training and research platforms, coordinated disease surveillance, and regional emergency readiness. And beyond the Caribbean, we must build deeper cooperation with Africa, Latin America, and Asia. The future of resilience will not be built through dependence alone. It will be built through partnership. And as I said before, by whether health systems can evolve to absorb, govern, finance, and scale innovation in ways that are equitable, sustainable, and trusted. So in that sense, the question is no longer what can be invented. The real question is what can be made to work for everyone, everywhere, at scale. And that is the charge I wish to leave this conference with. Not merely to discuss what can be invented, but to confront with urgency and purpose what can be made to work for everyone, everywhere at scale. In this regard, I look forward not only to the richness of your discussions, but to the lasting impact that will emerge from how you choose to address this defining challenge of our time. I thank all of you and God bless you. Please enjoy this beautiful country and take some time to indulge in our food, culture, and spirits. Thank you.
Thank you very much, His Excellency. I know that you have another engagement, and I do understand that you'd have to leave us. So I will ask for us to stand to allow you. Thank you very much. I would like to now invite Dr. Inda to. Okay. Go ahead. Excuse me. So we're going to go into the next session, and that is going to be chaired by Dr. Inda.
Okay, we are running a bit late, so we ask some persons to return within 2 minutes so we can start the other session.
Nearest washroom. Nearest washroom.
We need to get people back in. I don't know why it was never a break. It was never a break. So where are the people who are coordinating? Nobody is around. Hello. It was never a break. Why did people leave? The chair was supposed to say we're going straight into the thing. No, but if they're going for coffee, we trouble. All right, so what do we do? If we could get the loud guy, what's his name? From, yeah, tell him that we're about to start. No, but Mark, we're not gonna break. I know, I was saying, but yeah, no, not you. Everybody went. They can't. So what do we do? Change? Roxanne, we're out Roxanne, what do we do then? What do we do now? People have. No, so what do we do? People have coming down. But it can't start the time. Can someone make an announcement outside that we're starting, right? Thank you. Oh, we're not seeing you. Are you online? Okay. All right, no problem. We all just getting pieces. So we're going to put you on screen. Okay, great. Thank you.
Again, I hear.
All right, no problem. We all just getting seated.
Oh yes, I'm fine. So I'll come. You want me to come off until you're ready and let me know? Again, I hear.
All right, no problem.
Okay.
We all just getting seated.
Oh yes, I'm fine. So I'll come. You want me to come off until you're ready and let me know? Again, I hear.
All right, no problem.
Okay.
We all just getting seated.
Oh yes, I'm fine. So I'll come.
uh, to come back in. We're about to begin. Honorable Dr. Terence Drew, thank you for taking the time to come. Good morning, Honorable Dr. Terence Drew. Thank you for taking the time to come.
Okay. Yes, yeah. Welcome.
Good morning, Honorable Dr. Terence Drew.
Yes,
Thank
good
you
morning.
for
Yes, can
taking
you
the
hear
time
me?
to come.
Yes. Yes, good morning. I can hear you loud and clear. Can you hear me?
We can, thank you. Good morning, Honorable Dr. Terence Drew.
Yes,
Thank
good
you
morning.
for
Yes, can
taking
you
the
hear
time
me?
to come.
Yes. Yes, good morning. I can hear you loud and clear. Can you hear me?
We can, thank you. Good morning, Honorable Dr. Terence Drew.
Yes,
Thank
good
you
morning.
for
Yes, can
taking
you
the
hear
time
me?
to come.
Yes. Yes, good morning. I can hear you loud and clear. Can you hear me?
We can, thank you. Good morning, Honorable Dr. Terence Drew.
Yes,
Thank
good
you
morning.
for
Yes. Yes, good morning. I can hear you loud and clear. Can you hear me?
We can, thank you. Good morning, Honorable Dr. Terence Drew.
Yes,
Thank
good
you
morning.
for
Oh my goodness. Just can somebody?
Yes.
Thank you. Good morning, Honorable Dr. Terence Drew.
Yes,
Thank
good morning.
you for
Just can somebody?
Yes.
Yeah.
Good morning, everyone. Welcome to the special ministerial panel discussion on leveraging innovations in health to reduce disease burdens in the Caribbean. I have the privilege of a distinct set of panelists. The Honorable Dr. Terence Drew, Prime Minister of St. Kitts and Nevis and the Minister of Health. The Honorable Dr. Frank Anthony, Minister of Health, Guyana. The Honorable Lakram Boodoo, Minister of Health from Trinidad and Tobago. The Honorable Kevin Bernard, Minister of Health, Belize. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford, Minister of Health, Grenada. Good morning. The Honorable Kevin Bernard, Minister of Health, Belize. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford, Minister of Health, Grenada. Good morning. Honorable Kevin Bernard, Minister of Health, Belize. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford, Minister of Health, Grenada. Good morning. Honorable Kevin Bernard, Minister of Health, Belize. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford, Minister of Health, Grenada. Good morning. Honorable Kevin Bernard, Minister of Health, Belize. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford, Minister of Health, Grenada. Good morning. Honorable Kevin Bernard, Minister of Health, Belize. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford, Minister of Health, Grenada. Good morning. Honorable Kevin Bernard, Minister of Health, Belize. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford. The Honorable Kasani Lavelle, Minister of Health, Dominica. And the Honorable Philip Talisford. The theme of this conference is innovations in health. We have this esteemed panelist of ministers of health, and we have two questions that we are asking. The session will consist of 2 rounds of questions. 1, outline the key health innovations in your country. And 2, can any of these innovations be expanded to the Caribbean region as a whole? And if so, how? We would like to start with Prime Minister St. Kitts, who is online. Dr. Terence Drew.
Yes,
Expanded
I
to
am
the
here. I
Caribbean
hope
region
you
as
can
a
hear me
whole.
well. Can you hear
And
me?
if so, how? We would like to start with Prime Minister St. Kitts, who is online. Dr. Terence Drew.
Yes, I am here. I hope you can hear me well. Can you hear me?
And if so, how? We would like to start with Prime Minister St. Kitts, who is online. Dr. Terence Drew.
Yes, I am here. I hope you can hear me well. Can you hear me?
And if so, how? We would like to start with Prime Minister St. Kitts, who is online. Dr. Terence Drew.
Yes, I am here. I hope you can hear me well. Can you hear me?
And if so, how? We would like to start with Prime Minister St. Kitts, who is online.
I want to recognize, of course, the chairperson for this panel and all of my colleagues around the table. I hope you can hear me. I am Dr. ready to go. I know there are some technical difficulties. I'm the Prime Minister of St. Kitts and Nevis. In addition to that, I want to recognize of Health, the chairperson for this panel, still a practicing and all physician. Of my colleagues around the table. I am Dr. Terence Drew. Well over 20 years. The Prime Minister of St. Kitts and Nevis. In addition to that, I say that because I think today the focus is still a practicing physician. And I wanted to outline that. I have been practicing medicine for internists well over 20
Okay, good morning again. While these technical difficulties are being sorted out with our online panelists, we would start with the persons who are here. Minister Tallisford, you have 2 questions that I pose to you. Outline the key health innovations in your country. And can any of these innovations be expanded to the Caribbean region as a whole? And if so, how?
Thank you, and good morning to everyone. In Grenada, we are undertaking a major project called Project Polaris. It is not just the construction of a hospital. It is a medical city that includes a hotel which cascades along the beautiful Shemin Valley beneath the gently sloping mountain ridge under the warm Caribbean sun, offering the perfect environment for healing. This 250-bed teaching hospital is designed to leverage our partnership with the St. George's University and genuinely answers the question of health sovereignty. For over 50 years, a tiny nation depended on doctors from other friendly nations, while Grenada, through the St. George's University, graduated over 25,000 medical doctors who practice in all 50 states in America and in over 50 countries worldwide. St. George's University consistently places the largest number of graduates into the U.S. residency each year across more than 20 specialties and is the largest single source of physicians entering the U.S. healthcare system. Project Polaris is designed to meet the growing needs of our while tapping into the medical tourism market. This hospital is expected to showcase some of our best regional talents and will be equipped with cutting-edge technology and equipment, utilizing telemedicine, artificial intelligence, and robotics, thus creating the perfect environment for our clinicians, a strategy to build medical sovereignty. We recognize that while higher pay attracts our healthcare workers, working environment is equally important. Illnesses do not choose sides. They do not wait on election results. They do not wait on the conclusion of an argument or debate. They do not choose time and place. Therefore, our healthcare system must stand as a beacon of fairness, dignity, and compassion. Project Polaris is the embodiment of that principle. In Grenada, we are laying the foundation for a healthier, stronger, and more resilient, productive nation. Thank you.
Thank you very much, Mr. Health Grenada. And indeed, the STU and the caliber of graduates that are coming out is really a force to be reckoned with. And of course, we would all need to go to this lovely place with this gentle soup areas to look, to be able to experience Grenada. Minister Bernard, you're coming from Belize, which is on the South American side, a bit far from the rest of our smaller islands. So we were looking forward to hear the key innovations in your country, and can any of these innovations be extended to the Caribbean region as a whole?
Thank you very much, Dr. Inder, and to all those here today at this conference. And of course, in response to your first question, in Belize, our approach, of course, is grounded in one principle, in building a stronger, smarter health system, one that where decisions are driven by evidence and focus on people. What we're doing, we've been strengthening research governance and evidence use. We have established at the ministry and government an institutional review board within the ministry to ensure ethical coordinated research that aligns with national priorities. And importantly, we are closing the gap between research and action by translating evidence directly into policy and service delivery. Secondly, what we're doing, we are advancing digital health transformation. This includes the upgrade to our National Electronic Health Record System, known as BHIS, and the rollout of our clinical data exchange platform, allowing different electronic health systems to speak to each other so that we are able to access and data much more faster. At the same time, we are similar to Guyana, who has already implemented telehealth. We are at the point of starting the introduction of telehealth, so that we want to ensure that there's better data use, interoperability in our systems, and the continuity of care. Thirdly, we're investing in our health workforce through our first ever human resources for health policy and strategic plan, alongside targeted retention packages for nurses, community health workers, lab professionals, pharmacists, and public health inspectors. At the community level, we are as well reimagining primary health care, expanding integrated mobile services, promoting workplace wellness, and advancing healthy municipalities to bring prevention and care closer to the people. And so we are advancing public health initiatives, which includes our Healthy School initiatives to remove sugar-sweetened beverages from schools. And we have also been introducing HPV self-swabbing alongside vaccination as part of our commitment to eliminate cervical cancer. As well, I've listened to this morning, the president spoke about, and including other speakers. What we're doing as well in Belize is that we have been upgrading our facilities into smart, climate resilient health facilities to be able to ensure that there's continuity of care during hurricanes and other shocks that may affect our country. I think one thing we need to remember is that in Belize, for us, innovation is not just one initiative. It's about connecting research, policy, and practice to deliver better health outcomes for people. So in terms of the region and how can these innovations be relevant across the Caribbean, I think that there's real opportunity. The real opportunity is not just replication, but it is regional alignment and collaboration that will assist. First, in terms of research governance, our countries can strengthen institutional review boards and better coordinate research while aligning it with national and regional priorities. Secondly, I think that we be able to focus on using evidence and not just producing it. And we heard that this morning, embedding research into planning, into budgeting, and service delivery across our countries. Digital health, of course, presents a major opportunity in all of this. And by developing shared standards for interoperability, data governance, and digital platforms, and leveraging pooled procurement, we can accelerate transformation while reducing the costs in the region. Of course, workforce challenges also require a collective process. And so adapting HRH policies and working together as a region on training, on retention, and migration will strengthen our health systems across the region. And so our primary care innovations that we have, including mobile services and community-based prevention, can readily be adapted to different country contexts. And as a region that is highly vulnerable to climate change, investing in resilient, smart health facilities must be a shared priority. So these innovations, for me, I believe, can be scaled through CARPHA, PAHO, WHO, and other regional platforms supported by knowledge sharing, of course, technical cooperation, and joint capacity building. And so the opportunity for the Caribbean is clear, to move from isolated national efforts to shared evidence-driven solutions that will improve our health outcomes for all of our people.
Thank you, Minister. And indeed, definitely, it is good to hear about the work that is happening and believe transforming, digital transformation, strengthen workforce development, transforming information into action. And indeed, these are things that we can all think about how we can be able to leverage that for the region. And I'll go back to our small islands, going down to Dominica. A very unique island, but different from our islands that are so easily accessible. But of course, one of our pristine islands in the region. And I would want to ask Minister Kasani Lavier.
Good morning to everyone. And first of all, thank you, Dr. Inda, for being so kind to our country by way of your introduction. Minister Anthony, thank you for your wonderful hospitality, and all of you, greetings. I know this morning what went on in terms of the minor glitch may have suggested to you all that innovation is not the way to go, but the gods above are saying that innovation is in fact the way to go. So I'm reminding you, I wish to say that for us in Dominica, as a small island developing state, that innovation is not a luxury for us. It is essential. And may I state further that it is not merely focused only on the technology aspect, but it is more about how we can use that technology, how we can use different strategies to bridge that gap between need and access to healthcare. So this is what it is about for us. In Dominica, we are transforming health in many different ways, and we are focusing on 3 pillars. And in terms of innovation, that would be connectivity, capability, and capacity. For us, we have recently invested about $6.5 million in doing a new and comprehensive health management information system that will be launched later this year. Of course, we have had different components of HMIS operating in silos in various departments, but it's the first time that we have in this comprehensive type of health management information system, digitalizing about 42 components throughout our healthcare sector. So we are pleased about that and looking forward to the transformation. Also, there are many other things that we have been doing. So in the last 3 years, we would have launched, in fact, our first ever cardiovascular and imaging center, and also a telemedicine center. And this is based at our main hospital. We have collaborated with the first affiliated hospital of Sun Yat-sen University in the People's Republic of China. And we have been able to coordinate and treat complex cases using specialists and subspecialists that are now available to us. And by way of our population and scale, never before would they have been so easily available to us. And that is certainly noteworthy and transformational for us. In terms of capability, we have invested in a lot of equipment in order to have a functioning telemedicine center, particularly focused on the Department of Cardiology. So we have had to invest in cardiac ultrasounds and portable ultrasounds and cardiac MRI and mapping workstations and MRI contrast injectors, and so many different components are outfitted to have this functional. In terms of capacity, we have had to ensure that we focus heavily on training of our clinicians and our various health professionals. And that has been done in many components, face-to-face, in Dominica in some cases. Some would have had to travel, and we have had elements where virtual training, in fact, incorporated as part of overall continuous learning experience for our clinicians. And, we have taken this a step further to establish overseas training and simulation center at our main hospital. And this is something, that has truly been transformational for us. And we have, in fact, coordinated with university. And with that, we have primarily, in this first instance, focused on minimally invasive surgical procedures. So we have simulation devices in this training center where you have, guided surgery. We have many of our clinicians for the very first time having these experiences of doing laparoscopic surgery and, learning suturing and using this technology and improving the hand-eye coordination and various techniques. So this is what we have really been investing in. And, that we hope will move a step further into areas like ablation technologies. So for us, all these areas we believe are transferable and scalable to all states within CARICOM. So we are not the only ones who stand to benefit. And, I must take note of the utterances made by your distinguished president this morning. Because that is the type of thinking to not merely have hubs within the Caribbean, but to have what in fact is a health ecosystem. And that is how all of us can benefit. If we are reasonable, realistic, and honest, we realize as a Caribbean region, we're faced with many challenges. And one of those would certainly be the attrition of our health professionals. And not only that, there's increased pressure right now. And we have to look inwards for the solution. And there's no reason why, if we in Dominica can collaborate with universities in China or the USA or wherever it may be, why can't we then have our own pool or network of specialists and subspecialists operating at a center somewhere? In this case, I know you spoke about having a hub in Guyana. Why can't we then have that type of collaboration that can extend to the wider Caribbean region? And so I think it's in fact scalable, it's realistic, and it's something that can happen very quickly. There are no hindrances barring our success in that area. A second area that I wish to mention would be shared training systems. Say, for example, for us, with our training center in Dominica, there are many training components that can be done virtually. We just have to ensure that there's the connectivity aspect that is invested in our various localities. This is something we can do. Say, for example, many of us in the small island developing states, we're very reliant on tourism. And with that being the case, we sometimes have challenges with divers who suffer from bends and decompression sickness. So for us, what does that mean for us? We decided that in order to be ready for this, we're going to train one of our anesthesiologists and angiologists, and that training will soon commence in terms of being able to be prepared in various treatment modalities. So they can be, well positioned in hyperbaric treatment and oxygen therapy to treat with bends and decompression sickness. So for us, this type of specialized training is something that is absolutely transferable. Why only have us being the ones benefiting in Dominica when this is something that can benefit everyone? And finally, the third area would be the simulation-based training. We have our own hub in Dominica, and while it is new to us, it's an area that we can extend and expand and ensure that more of our clinicians have an opportunity to be trained. So for us, I believe that the way forward is to collaborate, to work together, and not merely mention it in this difficult period, but to transfer words to action, to absolute commitment, where the good people of the Caribbean can stand to benefit profoundly. Thank you.
Thank you, Minister. And what the common theme that is coming out, strengthen our workforce, digital transformation, and operational research that is allowing us to be able to respond faster, to respond better, and to strengthen systems. I want to now introduce Dr. Frank Anthony. I know we did hear a lot about Guyana's innovation, but I think he's the most appropriate person when it comes to innovations in health in Guyana to speak about this. Minister.
Thank you very much. Good morning. Well, I think it's a little bit after morning, huh? It's still morning. First of all, let me say, as the president said earlier, that we are building a health ecosystem that's not only for Guyana, but for the entire Caribbean. And with that framing in mind, that's how we have been transforming our healthcare system here. And we have, I think, a lot of innovations that we can share with the region. So if we think about primary healthcare, in primary healthcare, we wanted to extend the range of services that we can offer at any one of our health posts or health center. And we worked with PAHO, and we were able to develop a list of services that we can offer. So that is now about 115 different services that we can offer at a primary healthcare center. That is then further enhanced by introducing telemedicine, where we now have about 150 telemedicine sites across Guyana. And that's going to grow so that we can expand the range of services that are offered to remote communities across the country. In addition to that, if you go to the next level, which would be like health center and district hospitals, we realized that a lot of our district hospitals, or what we were calling district hospitals, did not have surgical capabilities. So we were able to add theaters to these hospitals, and we would send in medical teams that would go in and do electives for people in those communities. So rather than having to medevac somebody out to Georgetown or to a regional hospital, these services can be provided closer to home, where patients can be cared by their relatives at home. In terms of other prevention things that we are doing, the president spoke about the school health program. And this, we think, is a very innovative program. We have been able to screen about 84,000 children in nursery, primary, and secondary schools. And our goal is to get to 280,000 children, because that would be our school population. And what we've been doing is checking for hearing impairments, any eye problems, dental problems, and a general screening that is age appropriate. And so once we detect anything, we're able to bring the children into care, and we fix those problems so that they don't have to be in a classroom and they're not seeing properly, and that would result in education loss because they're not learning properly. So this is one way in which we are addressing that, introducing this program. And I think really that's a program that can be utilized in other countries. Another innovation perhaps is the one that we're doing with the private sector. We have introduced several vouchers, and we have set the price with the private sector. So right now we have about 50 to 60 private sector provider in eye care, and they help us to go out into various communities to test people's eyes. And if the person needed a spectacle, then the government would also assist in paying for the spectacles. So far, in the last 2 years, we've been running that program. We have tested about 196,000 people, and we have assisted more than about 180,000 persons in getting spectacles. So this is a massive program, and that continues this year as well. We also want to tackle the area of cervical cancer, and apart from introducing the 9-valent HPV vaccine, what we have done is to provide HPV screening to women across the country. And that we are seeing a lot of uptake because, again, we are working with the private sector. We have done a similar program for men because prostate cancer is a big problem. And so we're using PSAs to first do an initial evaluation. And once we finish that, and if it's evaluated, then we'll be able to bring people in and do biopsies. And with that, we are catching the prostate cancer earlier so that we can have an impact on outcomes and treatment. So these programs are helping to change what we're doing, but you'll have an opportunity to see some of the things in action here at the conference. For example, digital health. We're doing quite a lot in digital health. We've introduced electronic health records at one of our polyclinics, and this is now being scaled up at the main referral hospital. So by mid of this year, that should be fully operational. So patients now would not have to come in and wait a very long time. You go by appointment. So that's going to cut down waiting time. We have, as I said, telemedicine, which has enhanced the services. We have been using digital health to look at 3D printing. You heard the president spoke about what we are doing in terms of prosthesis. So we can, and that's really a game changer, because before it used to take us at least 5 days to make a socket for a person who need a prosthesis. Now it takes 2 hours. We have been doing what I'll call digital pathology, because we digitalize a slide, and rather than having to send a specimen out to a lab for a second opinion, you can now do it digitally. And that also has been a game changer, because it has moved our diagnostics from somebody waiting for 3 months to get a diagnosis to now us being capable of doing this within 3 days. So these things are changing people's lives and how they get diagnosed. So 3D printing for prosthesis. We have also been doing 3D printing for crowns, and that too has saved people a lot of money, because prior to this, we have had to send these crowns to Miami, and it takes 2 to 3 weeks before you get it back. Now you're doing it right here, and in 30 minutes to an hour, it can be fitted right here. So it's a big change, a very big change. Other things that might pique your interest is that we're introducing a drone that can do drone delivery. And right now, the drone that we're testing flies to about 150 kilometers, and it can go down. They take out whatever is in there, and they can put samples or whatever they want to send back, and that comes back to the airport that we're building, the drone port. So lots of interesting innovations that can assist. And then at our tertiary center, among the things that we do, they do quite a lot of complicated surgery at the tertiary center. Aneurysms now they're capable of fixing, and we have been doing kidney transplants for a while now, and we are going to explore even further types of transplants. But one of the interesting thing, and I think a lack in the region, has been capabilities of doing HLA testing. And so because of our transplant program, we wanted to have that capability. And so we have introduced that. We have a lab, we have all the equipment, we have trained a person who is able now to do the check the results and see what's going on there, and can provide the advice. And so transplant programs in the Caribbean might want to consider, if they want to do HLA testing, they can do that with us. But there are many, many other innovations that we have, and I'm sure during the conference, if you have a look around at some of the booths, you'll be able to see some of these things in action. You can come to the Ministry of Health booth. We have a good presence downstairs. You can't miss us. We're right in the entrance there. And you'll be able to see, and you can talk to some of the directors who are there and learn more about the programs. Thank you.
Thank you, Minister. And we are witnessing the advancements in telemedicine and others that is happening to fit the context of Guyana. I'm told now we can resume online. I would invite Minister of Health from Trinidad and Tobago, Dr. Lakram Bodo. Please go ahead. Minister, can you check if you're muted?
Can you hear me, Lisa?
Yes, we can. Please go ahead.
Okay, wonderful. Good morning, colleagues. I'm very happy to join you online for this conference. I want to thank and congratulate CARPHA for convening this very important health research conference, and of course to commend the team, which is innovation and leveraging innovation in terms of looking at our problems in the Caribbean. I also want to thank my colleagues who have spoken so far, for sharing their experiences, and it shows that in different countries, of course, there are different needs. In Trinidad and Tobago, we have our special needs in terms of treating with NCDs. I took note of President Ali's presentation this morning, and the fact that in Guyana, one of the key challenges is to look at the improving system efficiency and reducing costs. I think that's a very important goal. One of the challenges we have in our country is in terms of how to deliver better and more timely care whilst containing costs. And so, of course, in common with some of the other innovations in the other islands will be our focus on the health system digitization. So we are currently advancing a national program to strengthen our patient records. This is very, very important. One patient, one record. And of course, that is going to help us in terms of gathering our workforce data and service planning. The telehealth for delivery of services in some of our remote areas is being explored. And I took note, of course, of Guyana's suggestion that perhaps there can be a hub for telehealth. That is something that perhaps, Trinidad and Tobago could look at. In terms of looking at how we can treat with NCDs, the other issue, of course, is prevention. In that regard, we've advanced legislation for front of package labeling. We are also taking a whole of government approach, what we call a cluster approach to treating with this issue. I'll give you an example. The Ministry of Health has partnered with the Ministry of Education to introduce a healthy foods initiative in schools. And we wanted to go further than that. And we've also partnered with the Ministry of Agriculture in terms of going really to the root of the problem, pun intended, to grow healthy foods. So that is something that we're looking at. One of the issues that I'm sure is common with our Caribbean neighbors would be the issue of human resources for health. We know this is, of course, central to reducing the disease burden. And of course, the gaps in staffing directly affect our waiting times, and the continuity of care and the clinical outcomes. So in that regard, we've had recently completed a comprehensive workforce assessment done with the Inter-American Development Bank. This actually will now enable us to do some targeted recruitment structured engagement with our diaspora, we've realized that there's quite a bit of experience and trained healthcare personnel who reside outside of Trinidad and Tobago and indeed outside the Caribbean. And this is something that we're looking at in terms of tapping that resource. Rehabilitative services are also important. Minister Anthony mentioned about prosthetics. We are in the process. We've recently, through the assistance of the government of India, we're able to provide prosthetic limbs for some 800 of our patients, mostly diabetics, and for some as a result of trauma. And it is, we're very close to operationalizing a permanent prosthetics center in the country. And in terms of sharing with the Caribbean, we're hoping that we'll have the capacity to be able to allow sharing with, seeing patients from the other countries. So that remains in our agenda. The last but not least has been the opportunity for us to create a specialist hospital, what will be a tertiary, perhaps quaternary hospital at the Hoover Children's Hospital. Because of our increase in bed capacity over the years, we are now able to focus on that facility to make it a tertiary quaternary hospital, not only to serve Trinidad and Tobago, but of course to share that with the rest of the Caribbean. In terms of other things that we can share, and we've learned, in terms of Jamaica's experience with pharmaceutical management, this is very important in terms of procurement and so on. We look forward to what has been done in the other countries. The pool procurement model is something that we would look at. And of course, the alignment of the public and private healthcare system that was spoken about in Guyana, Minister Frank, I think is something that perhaps, can be explored a bit further in terms of how we can best provide services for our countries. Of course, there's also the potential to share medical officers. We're looking in terms of the health force, in terms of the number of doctors, for example, we produce at the university, and the arrangements that can be made in terms of perhaps some of our doctors working in other Caribbean countries. So I think, again, I would want to emphasize that this is a very important conference. Innovation is important, not only in terms of the technical innovations, but also the system innovations in terms of how we provide care for our citizens and for Caribbean nationals. So I just wanted again to thank you for the opportunity. I want to commend CARPHA again for the important work that we do throughout the Caribbean. And I also, want to endorse that the research that is done at these conferences really need to be shared a bit more widely, so that we don't have to reinvent the wheel in each country. We can benefit from all of our experiences. So I want to say thank you again, and I look forward. Although I'm not there in person, I do have a representative from Trinidad and Tobago who I know will be looking on. Dr. Fulong will be looking on very closely and taking some notes, I trust, to bring back so we can go forward. Thank you so much. Thank you.
Thank you very much, Minister Bodo, and thank you kindly for waiting a long while and for bearing with us with the technical difficulties. We do hope that we see you next year face to face. And now we have Prime Minister St. Kitts, just checking if he's still online. Max and IT to confirm if PM is still online.
I am still online. Can you hear me well?
We can. Yes, PM. Thank you very much. Thank you for your indulgence. Please go ahead.
All right, thank you very much, and I'm happy to be here with my colleagues. Of course, on Wednesdays, I'm out of the office and I'm in the community, but I wanted to at least be able to speak on this. I listened to most of the presentation, and I'm very pleased with what I hear. Based on what I have heard thus far, even from President Ali and the panelists, is that a lot of good things are happening in the healthcare space in the region, in the Caribbean. One of the things I would like to say from my own perspective, not just as Minister of Health, but Minister of Finance and a Prime Minister as well, is that I've come to recognize that the health burden on each country is tremendous. And I've also recognized that hardly any of our countries in the region can really cover the true cost of advanced healthcare for our people, even though I must say that there are improvements. What was mentioned, and I want to reinforce, is that we create a system where we can share our resources across the region. For example, if you go to any of our countries in the OECS, none can build a center of excellence for each major area of healthcare. In cardiology, how many of us can really build an advanced center and still build an advanced center for neurology and still an advanced center for pulmonology, advanced center for urology, even cancer care, where you can have radiation. And in addition to that, you can have PET scans and so forth, and even using new types of technologies that are being used to treat cancers accordingly. What I would like us to look at from our regional level is how can we leverage our resources so that we can move across the region and receive healthcare at a very high quality. For example, would there be a center of excellence, let's say in one country, where we can then access that advanced care by some sort of agreement which would move people from one area to the next? From my own perspective and looking at health economics and the costs associated with this, that no country will be able, at least in the foreseeable future, maybe except for one, maybe Guyana this time in the next few years, will be able to afford the type of, will be able to afford to deliver to their people the most advanced delivery of healthcare at, I would say, the extreme end in terms of the newest technology and so forth. It will be extremely expensive. Think, for example, a robotics, to offer robotics to your people. That is extremely expensive. They're just one. Think about the new cardiac interventions that are being used. Extremely expensive. Hardly any country can really afford the extent of it to their population. I can say that. And so I think that part and parcel of this has to be, how can we collaborate to ensure that we leverage our resources to help the region? I'll give one example. We have the OECS PPS. In the OECS, all of us group together and we buy medication in bulk. What that does is that it carries down the unit cost per country, and it works. If I were to buy insulin, I think it's Nevis alone, it will be almost twice as much or more than buying it through the OECS PPS system. That's the pool procurement that we use to drive down the unit cost of medication across the sub-region. And that has been working extremely well. As a result of that, we have access to good medication at a much lower cost. So we have a model already. And I really want to reinforce how can we create that ecosystem. For example, I listened to Dominica well, and I heard about the simulation center. I mean, that is tremendous. How can Dominica, for example, leverage that simulation center across the region so I can send a few doctors from here to Dominica for some time to train in that simulation center, so I don't have to set up an advanced simulation center. I might have some level of simulation that I can handle on a day-to-day. But if I want advanced simulation, why can't they go to Dominica? With telemedicine, why can't we create an ecosystem in the region where all of us have telemedicine and then we can access each other's health professionals across the region? I think that can also be an area where we can look. So there are already some low-hanging fruits that can be used, and we can employ to help each other across the region. Barring that, I heard about Grenada now moving to build a brand new hospital and what the offerings will be. I am saying, looking at Grenada's population, and I know the cost of the technology that the Grenada is discussing, if Grenada were to depend on its population alone to drive that hospital, it will be bankrupt in very quick order. But I'm very sure that Grenada is seeking to see how they can leverage that center across the region so that they can bring people in from across the region and internationally. I haven't seen the model, but it's the only model that will really make sense if they can offer that type of medical tourism to help to finance the center. So if Grenada is doing that, and they would have some good offerings, and it would take significant investment, why would another country do that, knowing that it would not be able to maintain that facility because of extreme cost? And I see it happening across the region. Something pop up, you can't afford it, you drop out. You start a cardiac center, you don't get enough patients. In 2 years' time, you go bankrupt. You start a radiation center, you don't get enough patients. In 3 years, you go bankrupt. And I've seen that happening over and over and over again in the health space in the region. The other thing I would like to say is that the societies, the medical societies in the region, should really continue to leverage themselves to the region so that we can learn from each other across the region. We don't necessarily have to go beyond the region all of the time. We have to establish our own ecosystem. And lastly, I would say, why is it we can't build or procure factories in the region that can produce at least the basic medications? Why? So that we can have at least some production within the region of those basic medications. And as far we can also go to produce vaccine. Why do I say that? I was in Cuba, and Cuba is not a huge country by any standard. I mean, by Caribbean standard yet, but Cuba has about 11 million people, and they make almost all of their vaccines in Cuba. And I know we can do the same thing in the region where we can make our own vaccines and basic medication at a much reduced cost. And not only that, it will reduce vulnerability, build resilience, and allow us to create an ecosystem where we can survive. So that COVID, if something were to happen again, we will not be left outside and vulnerable at the behest of other countries that were thinking, should we even send them a mask? Can you imagine we were competing with developed countries, let me say, the advanced economies, as to whether we should get a mask or not, as to whether we can get a gown or not? We were left totally vulnerable as a region that has resources that could have built up an ecosystem to protect us, but it was not done. So I really want to emphasize that collaboration at deeper levels will help us tremendously in creating an ecosystem that will protect all of us. And I think that is what CARPHA is about, building collaboration across the region. And that is what CARICOM is about. How can we integrate more for the benefit of all of us? And so I really wanted to let my presentation be centered on those things, but I'm very pleased with the strides that I heard today coming from all of the countries, from Guyana to Dominica and the others, Trinidad and Tobago and the others who presented Grenada and support. So I want to really thank you all for your efforts, and thank you for being a part of the panel of which I'm a part. And lastly, I will say, togetherness and working together is, I would think for the region, the best way forward for all of us. Thank you very much.
Thank you so much, Honorable PM St. Kitts. And I think you did my job for me and made my job very easier in terms of summarizing all of this. And, I think we are in very good hands. Just hearing from the 6 panelists, the Ministers of Health, as well as the Minister of Health and the Honorable Prime Minister from St. Kitts, there's a lot of innovations. The Caribbean is pioneering, and there is innovations in telemedicine, digital health, transformation, research. But, how the question is, and I would take it exactly from what PM said, is how do we leverage this? We are one region and we are interdependent. Our borders are porous. We are interconnected. We depend on each other. So my question, and not for anyone to answer right now, but as we go through to this next few days, is how do we become more interconnected? How do we leverage one over the other, and to be able to use what Guyana is doing and what Dominica and Belize and Grenada and Trinidad, as well as St. Kitts. How do we work together so we become, we have a better Caribbean? We'll have a Caribbean that could stand against the bigger countries when it comes to procurement and healthcare and the health delivery. So with that, I know because we are really rushed for time, I would want to thank everyone for being on this panel. I'm really honored to be able to have your time, that you would have taken your time to spend this with us. We know you're very busy. Thank you very much. And this is the start. We would, of course, CARPHA does pledge, and which we do work together very closely, but we want to pledge to even more, to work closer more into this regionalization based on health innovations. Thank you very much.
Thank you very much.
Morning, everyone. Those of you who have the program would recognize that we're running a bit late. So by way of introduction, I'm Marvin Reed, otherwise called the Time Master. So this is the little thing here, you'll hear it. So I'm just going to do a few public service announcements for you to help you through the day. Right now, we're going to be breaking for coffee. At this point in time, that's going to be on the ground floor to your right. It's a little cramped because originally we were planning to do it on the outskirts, but as you can see, it's raining. For those of you who need to find the restrooms are on the floor just below this and the final floor. All right, there are restrooms on either corners for you to find. The other important thing, those of you who, because of security considerations, we had to ask some of you to come up without collecting your badge. We can ask that you can now visit the registration desk to sort out your badges at this point. We're going to still give you a half an hour break because it's a smaller space. So we will reconvene when you hear the bell in another half an hour. Don't worry, you'll hear either the bell or my mouth. All right? Thank you again.
Them to push back.
So, thank you very much. And we can move on to the second session, where we have a number of presentations on the theme of innovations in health. And since I'm very conscious of time, we'll move straight to the first presentation, which is on CARPHA's new and emerging innovations to support public health in the Caribbean. And it's my pleasure to give the floor to Dr. Lisa Indar, Executive Director, CARPHA. The floor is yours.
Good morning, everyone. I'm hoping this is the last time you see me on the podium for the rest of the conference. Okay, do we have a clicker? I know we're rushing for time, so I'll try to be as quick as possible. No clicker? Okay. All right, so, the theme of this conference is innovation in health, and CARPHA has been leading with a suite of different innovations. And today we want to bring to our audience a suite of these various innovations. Who is CARPHA? Just for persons who don't know, we are the regional public health agency where the CARICOMs help lead, and we are established by and mandated by our heads of government as a regional coordinating entity for public health. So this is our vision and our mission. We brought together 5 former regional health institutions, so people may have known CARIC, and SAHI, CRDTL, CFNI, and CHRC. So it means our work is not just infectious disease, so it's communicable, non-communicable, environmental health, drug testing, research, nutrition, and we have specialized programs as well that deals with a suite of different things like vector-borne diseases, travelers' health, and so on. We do have in the Caribbean, though, many challenges, and I wouldn't go through it, but you're seeing these challenges, and more so in the Caribbean, that specific travelers' health, diarrheal disease, because we have such a high tourism dependency, and we also have a situation of now aging population. So how does CARPHA address this work? We have to address our work from a regional health security point. And if we improve regional health security, it means we are going to improve, it means our global health security is going to improve. So regional health security encompasses the capacities that are required for our member states to prepare and respond to public health threats that transcend national boundaries. The thing is, the way how the Caribbean is set up, diseases are going to move from one boundary to another. The fact that we are tourism dependent to travel dependent, diseases are going to move from international borders to regional borders. And so when we are looking at anything in the Caribbean, we have to think about transnational boundary spread and how do we prevent that. So because of all of that, we have a wide range of core programmatic activities so we can adequately address the wide spectrum of public health threats in the region. But the approach is an integrated approach. It's a One Health approach, and from our regional health security. So we have normal surveillance of communicable disease, focus on emergency and response. We are the only regional referral lab, and we have 3 laboratory hubs in Jamaica, Trinidad, and St. Lucia that just doesn't not just test for clinical isolates, but food and environmental and veterinary isolates. We have a travelers health program, only one of its kind in the world, where we have persons, the travelers and the tourism sector reporting vector-borne disease because, of course, this region is endemic to the Aedes aegypti, foodborne and zoonotic surveillance, environmental health, non-communicable AMR, medicine and pharmaceutical testing, field epidemiology lab training, Caribbean regulatory system, M&E, health and support to the OECS. So it seems like a lot, and people may ask the question, well, why all of this? When you're serving a region with 26 different member states of varying capacities and varying public health threats, you need to have a comprehensive approach to public health. So what are our gaps pre-COVID and pre-pandemic fund support for improving resilience and pandemic preparedness? Most of our local population surveillance did not have an early warning mechanism. So it means something is happening in the local populations. We are quite not sure, and we may find out from the newspapers or our syndromic surveillance at 7-8 days late. And of course, in small islands, that is not acceptable. It needs to be real time. Our traditional systems and mechanisms also do not always align to this Caribbean interconnected context. Our surveillance platform, we talk a lot about integration, but we did not really have that integrated digital surveillance platform. We had data that was coming in late, sometimes not at all, and we didn't have real-time alerts for local infection. The only real-time surveillance we had was for the traveler's health. And we had issues like manual and delayed workflows and so on. So taking all of this into the Caribbean context, small island developing states, that's the first thing when you're developing research and interventions in the Caribbean, we have to consider. The president spoke about that this morning. What about context? Our populations are small, they're under-resourced, they're very, they're heterogeneous, you have different capacities in surveillance, lab, human resources. But then when you add high mobility and porous borders, you just add to the increased risk. So we are the #1 cruise ship destination in the world. And, there's frequent travel. And the travel is not just, let's say from the US or the UK to the Caribbean. It's within the islands. So a ship comes and will go to 3 or 4 different islands before it comes. But this heavy reliance on travel and trade is our bread and butter. We need it. So we can't afford to not be able to detect diseases and to be diseases quickly and not prevent it quickly. The other thing President spoke about it this morning, climate vulnerability and vector-borne disease risks. And when you look at the impact of climate, the rise in temperatures are impacting on vector-borne diseases and so on. And of course, we have this historical outbreaks of many infectious disease. So the Caribbean context necessitates Caribbean-tailored or regional early warning systems so that we have early warning, preparedness, notification, and response so that we are able to protect the locals and tourists, we are able to improve regional health security and reduce burden. CARPHA, given its role as regional role, safeguards lives and livelihoods in the region through these innovative Caribbean-tailored interventions suiting the Caribbean context. And we put this slide up because we wanted to show you how close the islands are. All right. If you're a good swimmer, you could probably swim across from one island to the next. But that is the type of interconnectedness. And when we talk about borders, there are legal borders and illegal borders, and that type of migration that goes along. So this unique context necessitates the robust, specific, tailored, regional, integrated systems that has early warning and mechanisms, laboratory and workforce capacities, but also supported by strong partnerships so that we can have well-coordinated a well-coordinated system and mechanism for addressing public health. I want to go too fast. Right, so in keeping with its mandate and through funding from Pandemic Fund Grant, thank you, Dr. Basu, CARPHA developed a package, and I want to say it's a package of novel Caribbean tailored tools and intervention for real-time early warning and response. The key there is early warning and response to public health threats. So we are safeguarding the region as a whole. We can't just safeguard one country because an outbreak in one country is likely to to transfer to another country. This was endorsed at our ministerial meeting last year. We presented the progress just yesterday at our special COSA meeting, and it will endorse us soon. But how do we work? We don't get up and decide, well, this is how we think. Everything we do have to have stakeholder consultation. So We have 26 countries. We work with our technical leads, the chief medical officers, epidemiologists, lab directors. Then we also have the regional collaboration with our agencies in terms, and as well as the international collaboration with our global experts to be able to develop these tools. This is what we are talking about. If you forget everything I said, remember this. This is a suite of services. And the reason we have a suite, we cannot come together. We cannot come and address this piecemeal. We have to look at our entire surveillance systems, the different gamuts, and come together so that we can have an early warning mechanism. So it ranges from syndromic surveillance, travelers' health, mass gathering, cruise ship surveillance, climate integrated disease early warning, environmental monitoring, antimicrobial, food and waterborne, vector-borne, and so on. All of this comes together to create a regional early warning surveillance system that is Caribbean tailored, early warning with inbuilt alerts. It means that the relevant persons are getting those alerts, instant reports, confidential. That's important, especially when you're living in a Caribbean, a tourism-dependent region. And it's interoperable, and it's allowing for seamless, fast emergency and response. And of course, this was approved. How are we progressing? Just, we got the pandemic fund grant, just over a year and a half, coming down to 2 years. But what is really good is that, we have been able to progress a lot in terms of developing 2 years and a half, developing Caribbean specific thresholds, integration, expanding the systems, and getting the systems to talk. Many times, not many times, we have systems that are operating in silos. Your syndromic surveillance has to speak to your laboratory surveillance. Your traveler's health has to speak to EMR. It's one person who might be getting sick, and they will have different types of, you need to trace that back. What type of EMR type might be for this particular person who has a particular bug, and so on. So the integration is important, and we supported that by the lab integration as well as the digitalization. And then, of course, strengthen our workforce, outbreak investigations, global outbreak network training, and so on. We intend to present the final thing to the board and then implement now. The proof is in the pudding. You have to now implement at country, but you're implementing a package of services that you're going to, tailor it for the country. So this is the system, integrating all the different platforms. And, when I first saw this word, I thought it was USB, but, it's unlocking surveillance potential. And it's, there is a video outside. If you go out into the Pandemic Fund booth, I urge you to go look at it. You will see the system operating, and you can see how you can enter information and get instant alerts. When we want to put all of it together, this is the model. The idea is to look at all of it using different data sets, the normal DHIS that countries use, open source for syndromic vector control. We have a platform for the traveler's health, the mass gathering. We have Senate for lab. And of course, we're also looking at infodemic management. The idea is to detect sooner, notify faster, and act together. And I wouldn't go through all of this, but this is national data to regional intelligence, showing you the back end of what we have been doing. And the key is to really work with your existing data set so you can get that type of threshold. And we are really transforming all the work we are doing at CARPHA, putting alerts into it with the existing system. Why we are doing that? We want to not give any countries more work, not to burden them, and we want to make the reporting interoperable, because these are existing systems of reporting. So, showed you just some of the platform, but I urge you to go onto the booth on the Pandemic Fund and actually see this working. Real-time dashboard, you enter data, it's coming. I actually get real-time alerts, by emails if something is happening. Integrated early warning outputs, alerts and decision making, and this is so important. chief medical officer has to tell us who are the people he or she wants to get this alert, because of course it's privy information. But if you go outside, you'd see you have the system. As soon as there's a flag, you get that email as well. All right, this is the regional tourism. This has been operating for the last couple of years. I mean, it was really important during COVID by being able to present the chief medical officers alerts before, persons arrive, and that was important. The One Health, we have been able to input data for the last 8 to 9 years, and so this data set is actually working. And for countries that are here, these are the various systems. On top, those are the ones that the countries are using it and countries interested. But CARPHA is a regional body, and the idea is to get everybody, to get everybody involved. What is the impact? The impact is improvement in timeliness. If you're dealing with diseases, infectious diseases, you want, especially in the Caribbean context, you want to be able to first detect now, notify, detect, and response. And that timeliness, depending if it's occurring, let's suppose on a cruise ship, tourism, we're in a mass gathering area, it can't be 2 days, can't be 2 weeks, it can't even be a week. It has to be at the same time, real time. Talking about the different surveillance systems where we integrated, I'll just, in the interest of time, pass all of this. And I see I have 5 minutes. All right. The next set of slides will tell you what is already happening. The cruise ship surveillance is very innovative. And this was hard to develop because you're dealing with the private sector, which is cruise ships. But in September, we worked with our chief medical officers as well as the cruise ships to really come up with these dashboards and these alerts. We were just in Belize talking about how we implement. But what is good about this is that real-time information that allows you to provide information, whether if a country wants a grant practice, if they want to keep sick persons on board, so you're getting it in real time. And my slides is moving faster than me. What are the lab innovations? We have expanded laboratory. To do the surveillance, you need a lab. So we expanded clinical testing to all 3 of our hubs, and we have worked out as well mechanisms for enhancing transport, because you see how we are set apart. Somebody from Cayman, it will take a week to get to CARPHA to be able to test. So now they can easily send to Jamaica. And we have gone further because of grants. We have able to put some funding into all of that. So in the beginning, that is already funding. But the type of expansion has been with state-of-the-art PCR equipment that allows you to test in very quick manner. So lots of innovation. Just 2 weeks ago, we were in St. Lucia where we launched. So that's the PS and the chief medical officer. But more importantly, for those of you who are lab techs, you'll understand MALDI-TOF and all those types of equipment, whole genome sequencing and so on. Because you've got to stay ahead of the technology. So whole genome sequencing is where we are moving. We are moving to, we've signed agreements with CAL and others, Caribbean Airlines, so that we're able to have, faster and more seamless sample transport. Must strengthen your workforce. We heard that this morning with the ministers. So while all that is happening, we are strengthening workforce internally at CARPHA, making sure everyone is involved. When we had a simulation exercise, and we involved persons from logistics and finance and the epidemiologists and the laboratorians and so on, because everybody needs to know what's happening. And then we developed a Tingwa simulation exercise. It's a fictitious island in the Caribbean, but it's based on the Caribbean context, and it's wonderful. It works well because, in the Caribbean, you have something, you're not going to have an ambulance. 12 and 15 ambulances to you and a whole ton of hospitals. What is going to happen? Many times also, it's one epidemiologist, it's one CMO, and they have to deal with many things. And what is the priority? So this was set up just for that. And in fact, when we have mass gatherings, it's not just an infectious disease, it's also a fire or a burn or something else. So this really reveals how you need to work together, the multi-sectoral approach. And this is the simulation exercise we are moving. And to add to that, the timeliness metrics, looking at, it takes, the 717 global methodology talks about 7 days to detect. If we have an outbreak of measles in one of our islands, people will just die off. A lot of people, the island might be wiped out. So in the Caribbean, you need 1 day. So we have taken the international norms and modified for the region. So this is the Tinga, and we actually have, a president of Tinga and so on. But it's all there, and these are documented things that you could just take and implement at country level. The timeliness metrics, just moving fast. The global norm, moving it from 7 to 1 and 1 and 1. Right. So 717, for depending on where you are and what type of syndromes and what type of setting, like a norovirus, you want to be able to detect that quickly and to be able to act quickly. If you're on a ship, case of influenza could be anything the same day, because persons are going to go or they're going to move to another island and so on. So how are we improving? In the last, I want to say 2 years, we have built this capacity and in pandemic preparedness and response in over 21 countries, over 1,000 persons, 214 activities completed. And, these systems supported by lab, workshop capacity and partnerships. And, persons can go onto the booth and see this. Lots of photos here, but the partnership is what drives this. I said this yesterday. While we are pushing regionalization, our global partners have worked with us really, really well. Pandemic Fund, World Bank, IDB, EU, and others to really push this. And you're seeing PAHO there, we are doing joint missions as well to see how we can be able to collaborate and coordinate better. So lots of partners. I am in red, and I think I did well. Thank you very much, and it will be remiss of me if I do not thank the Pandemic Fund for providing the funding that really propel a lot of these innovations. Thank you very much.
Thank you very much. Thank you very much, Dr. Rindar. I mean, you did a splendid job with so many functions to describe. So congratulations. You mentioned the Pandemic Fund, so that's a very good transition to the next presentation from Dr. Priya Basu, Executive Head, Pandemic Fund of the World Bank, who will give us more information on the fund and how it supports innovations in global health. Priya, the floor is yours.
Thank you so much, distinguished co-chairs, distinguished participants. Good morning. It's a pleasure to be here in beautiful Guyana and to join you at the CARPHA annual conference. Let me begin by thanking the CARPHA Executive Director, Dr. Lisa Indar, for the kind invitation and for the great partnership. I also wanted to acknowledge the valuable insights that were shared this morning. The ministerial panel just before this one, as well as Dr. Indar's presentation, underscored the critical role of innovation in advancing public health across the Caribbean and beyond. In my remarks today, I'll highlight how the Pandemic Fund is supporting innovation in global health, with a particular focus on progress across our growing portfolio, including here in the Caribbean. I'll also reflect on key lessons from our early years and share how we are looking ahead to further strengthening pandemic preparedness and response. Recent outbreaks from Ebola and avian influenza to rapidly spreading vector-borne diseases show that pandemic threats are not just real, they are accelerating. In the Caribbean, dengue surged to record levels in 2024 and remained a major threat in 2025. Emerging viruses like Oropuche are now appearing in the region. And after Hurricane Melissa in 2025, Jamaica saw leptospirosis outbreaks with similar risks across Haiti and other vulnerable settings. So the message is clear. The Caribbean is on the front lines. Strong reliance on tourism and vulnerability to natural disasters creates unique health security risks and requires improved capacity and coordination not only at national levels, but also at the regional level. How do I move the clicker? Okay. Sorry about that. So turning to a brief history of the Pandemic Fund, established in 2022 with the leadership of the G20 and generous contributions from the United States and the European Union and others, the Pandemic Fund was created to close a critical gap: chronic underinvestment in pandemic, sorry, the clicker is moving. Chronic underinvestment in pandemic prevention, preparedness, and response, or PPR, if you allow me to use an acronym, especially in high-risk countries. The COVID-19 pandemic showed that this gap is a shared global risk. As the only financing mechanism dedicated exclusively to investing in pandemic PPR, the Pandemic Fund keeps focus and resources on early detection and stopping outbreaks where they start. Demand has been 6 times oversubscribed, underscoring both the relevance and unmet needs. In just over 3 years, the Pandemic Fund has grown from a concept into the world's largest dedicated financing platform for pandemic prevention, preparedness, and response in low and middle income countries. Our model is built on speed and impact. We channel funds through established partners to avoid duplication, maintain a lean secretariat, and deliver coordinated, country-led financing that catalyzes additional resources for every dollar that we award. So let me now share a brief overview of what our portfolio looks like. Thanks to the co-financing that we've been able to mobilize from international partners, as well as co-investments, importantly, from the recipients themselves, both countries and regional entities, our portfolio across 3 funding rounds that have been awarded so far now stands at $11.5 billion with a B. The fund is supporting a total of 128 countries across 6 geographic regions through 67 projects, of which 12 are in the Latin America and Caribbean region. And these projects are helping to strengthen pandemic PPR capacities within and across borders. This map shows you how grant dollars have been allocated across regions. To date, 44% of grants have been allocated to sub-Saharan Africa, where the needs are highest and the gaps are the widest. But Latin America and the Caribbean accounts for 16% of grants allocated, making it the 2nd largest region in our portfolio. And on April 1st, the Pandemic Fund just launched its 4th call for proposals, which will further expand our geographic reach and impact, which it prioritizes 15 countries facing the highest risks and capacity needs, including 1 country in this region, Haiti. Demand, as I mentioned, however, continues to far exceed available resources, and on average, we've received requests at roughly 6 times the funding that we were able to allocate. So here's a snapshot of the 12 projects that we are supporting in Latin America and the Caribbean. 7 single-country projects, of which 3 are in the Caribbean: Guyana, Suriname, and Trinidad and Tobago. 3 multicultural projects that include 1 that's focused on the Eastern Caribbean, and 2 regional entity projects, CARPHA, that you just heard about from Dr. Indar, and IICA, which is a a regional entity that's focused on agricultural cooperation, noting the nexus between environment, human health, and animal health. And for these 12 projects together, the Pandemic Fund has helped mobilize $1.3 billion, $217 million in grants awarded, helped catalyze 839 million in co-financing from international partners and 278 million in co-investments from the recipient countries and regional entities. The stubborn clicker. All right, so that just gives you a sense of the catalytic financing model, which is ever more relevant in today's aid landscape. Every dollar so far that we've awarded has helped mobilize $7 additional, so 1:7 leverage ratio. And with the $1.4 billion in grants that have been awarded so far through 3 rounds of funding, we've managed to unlock $10.1 billion in additional financing, $4 billion of which, importantly, is actually coming in domestic investments from the governments and regional entities that have received resources, and then just over $6 billion in international co-financing. So these numbers indicate strong early momentum and commitment from both international partners as well as from our co-investor countries, as we call them. So I'll now show you a little bit of a snapshot of our results that are being reported by the projects, which demonstrate that we're delivering with urgency and scale, and that the fund's investments are already translating into tangible results on the ground. As highlighted in our latest progress report, the pandemic funds projects are delivering measurable results across our 3 core priorities: early warning and surveillance, laboratories, and workforce development. Surveillance and diagnostic capacities have been strengthened in over 12,000 health facilities. 271 new sites were established. 105 of those are at points of entry, which are critical choke points for cross-border spread. More than 350 laboratories have been built or upgraded, and the fund's investments have helped strengthen sample transport systems, and often overlooked but critical link in the diagnostic chain. Over 140,000 health workers have been trained, including community health workers, epidemiologists, veterinarians, and laboratory specialists. And I'd like to emphasize that these investments build core health system capacities, improving routine care and strengthening resilience across diseases. And that preparedness really is not disease specific, it's about system strengthening. And we take a disease agnostic approach because we don't know what the next pathogen that has the potential to turn into a pandemic might be. We're also advancing 2 priorities for global health security. One Health, that links human health, animal health, and the environment to stop threats at source. And secondly, cross-border collaboration through building interoperable surveillance, data sharing, and lab networks. This slide focuses on the emphasis on multisectoral collaboration through One Health, which is foundational to achieving global health security and a hallmark of pandemic fund projects. Nearly all projects apply a multisectoral approach, bringing together ministries of health, agriculture, environment, finance, animal husbandry, to ensure that the interventions are well coordinated. And more than half of our projects have established national or regional One Health coordination platforms, often formalized through government decrees and strategic plans, ensuring high-level ownership. These efforts are strengthening integrated surveillance and data sharing while building a workforce trained to respond across sectors. And many projects also embed antimicrobial resistance strategies, strengthen border health, and deepen community engagement. Our investments are anchored either in national systems, budgets, and legal frameworks, or in regional entities to ensure ownership and long-term sustainability. 82% of pandemic fund projects under the first 2 rounds of funding have established or strengthened national public health institutes or equivalent institutions. Our projects are also helping to build regional and global capacity. You just heard from Dr. Indar about the support to CARPHA. We're also supporting regional institutions in other parts of the world, including Africa CDC in sub-Saharan Africa. And looking ahead, the fund could also help build capacity in areas which are actually part of the scope of the pandemic fund, but not in our medium-term strategy, but areas related to coordinated development, procurement, distribution, and deployment of countermeasures and essential medical supplies. So let me illustrate what these results look like in practice here in the Caribbean. We are really proud of our partnership with CARPHA and the Inter-American Development Bank. Dr. Indar has already given you an overview of the CARPHA project, but I just want to say that this was actually the first of the pandemic fund projects to be launched in December 2023. And it's produced so many tangible results. The region's first digital One Health platform, a new real-time mass gathering surveillance system that was launched and successfully implemented during the T20 Cricket World Cup in 2024, with training provided to over 1,500 stakeholders. 12 countries have been equipped with TrueLab micro-PCR systems to test for priority pathogens, including SARS-CoV-2, influenza, and dengue, ensuring that the region meets its diagnostic targets. The project helps strengthen joint laboratory training networks and active surveillance systems with CARPHA coordinating supply delivery, 2 new specimen referral systems and transport systems, regional health information systems. I could go on, but we're really proud and congratulations to CARPHA for all the progress made and looking forward to more to come. Now, while the pandemic fund's core priorities are to strengthen long-term preparedness, it's also worth noting that in 2024, in the wake of the Mpox outbreak in Africa, the fund demonstrated its relevance, agility, and commitment. In September 2024, the Pandemic Fund's board fast-tracked $129 million to support 10 African countries in responding to the Mpox outbreak. In the Democratic Republic of Congo, for example, nearly 1 million surveillance tools were deployed and laboratory capacity was rapidly expanded. Diagnostics were enhanced in 9 laboratories. 4.1 million people were reached through risk communication campaigns, enabling large-scale detection and response. In Rwanda, another great example, not only was the Mpox outbreak contained, but the country also simultaneously managed a Marburg outbreak within 3 months. So we've looked at how countries are investing in core capacities, surveillance, laboratories, and workforce. Let me now turn to how these investments are translating into preventing outbreaks from escalating. In other words, pandemics that did not happen. Dr. Indar mentioned the 717 framework. This is also a way in which the Pandemic Fund is measuring success in terms of ongoing outbreaks, how quickly and effectively these investments are helping countries and regions to respond when outbreaks emerge. And we're seeing tangible progress here as measured through the 717 performance benchmark, detecting outbreaks within 7 days, reporting within 1 day, and containing response within 7 days. Across supported countries, the number of outbreaks managed to this standard has increased 6-fold, and the share of countries meeting the target has risen from 14 to 52%. So let me highlight 2 examples, and next time I'd love to highlight one from the Caribbean as well. But in Mongolia, for example, an anthrax outbreak was detected in just 2 days, with response initiated within 4 days, well ahead of the target. In Togo, strengthened systems enabled detection of the highly pathogenic avian influenza within 4 days, alongside responses to Mpox and other threats. Now, behind all of this progress, there's one common thread, and that's strong partnerships. The fund's progress reflects partnerships among governments, multilateral development banks, UN agencies, civil society, philanthropies, and the private sector. Private companies are contributing technology and expertise, from diagnostics and laboratory equipment to innovations such as drone-based technology for surveillance, mentioned by Health Minister Anthony this morning, and last-mile logistics. Civil society organizations and faith-based organizations are also engaged across a broad spectrum of activities in the implementation of Pandemic Fund-supported projects. In fact, more than half of the projects supported under the fund's first two rounds of funding explicitly include CSO and faith-based organization engagements involving over 50 distinct organizations. Last year, the Pandemic Fund launched an external advisory council with more than 20 organizations to strengthen knowledge sharing, innovation, and coordination across sectors. And the call for organizations to join this external advisory council is open. Just contact us at the Secretariat. Together, these partnerships are multiplying the fund's impact through combining innovation, local knowledge, and global expertise to build stronger, more resilient health systems. So we've learned important lessons which are driving improvements in what we do and how we work. First, we are refining the design of our calls for proposals. The latest fourth call for proposals that's ongoing right now targets countries with the highest risks and needs while increasing predictability and flexibility in funding. We're also broadening participation among our implementing entities and streamlining the application processes, making it easier for applicants to submit proposals. And at the same time, our board has also introduced emergency financing procedures to enable faster response should another major crisis hit. Equally important, we are deepening engagement with the private sector and civil society and improving how we capture and share knowledge alongside ongoing improvements in governance to strengthen the fund's overall effectiveness. Sorry. Okay. So my last slide, the Pandemic Fund's early successes demonstrate the power of country-led, collaborative, and catalytic financing to strengthen global health security. Looking ahead, we're committed to learning and adapting the model, to innovating and scaling what works, embedding investments within national institutions, and expanding regional coordination. We continue to enhance agility and responsiveness and to strengthen collaboration among international funders to align investments with country and regional priorities, reduce fragmentation, and amplify collective impact. Momentum continues with the fourth call that is ongoing. With demand so heavily oversubscribed, underscoring the fund's relevance and unmet needs, we will continue to work towards mobilizing resources and maximizing catalytic impact. This is about meeting the moment. With partnership and shared commitment, we can build stronger, more resilient health systems that have the capacity to stop outbreaks where they start. Thank you.
So thank you, Priya, for that comprehensive presentation. Before we continue, I've been informed that there is a car blocking someone's exit. So the number is PJJ9989. If you recognize that number, please move the car from where it currently is. Thank you. Over to my co-chair.
Thank you. Thank you, Dr. Basu. That was very informative. We're not only getting better at responding to the next pandemic, but also at preventing potential pandemics. It's now my honor to introduce our next speaker, who is Professor Chaz Buntra, who is the Pro Vice Chancellor for Innovation at the University of Oxford. And he will be speaking to us on translational medicine and innovations in healthcare towards improving health outcomes. Professor Buntra.
Well, ladies and gentlemen, good morning. Thank you very much. I think now that I've had the applause, I may as well just sit down, I think.
I apologize for disturbing you. Could you please make an announcement that this speaker is blocking one of the...
He's just done it. The gentleman there has just done it. Right, thank you very much. He was asking me to make an announcement about the car, but anyway, look, I've been asked to talk about translation and innovation. What I thought I would do is share with you some of the things we've been doing in Oxford and some of the lessons we've learned, and I hope some of those are of interest to this audience. So I'll split the talk up into 4 bits. Firstly, I'll talk about some of the challenges that I worry about, and I know many of you worry about. I'll then share what I think are some of the solutions to these challenges. I'll share some of the things we've been doing in Oxford. And then finally, I'll finish with a few anecdotes just to try and illustrate all of this. So in terms of challenges, so I'm interested in the discovery of new medicines. And I worry a lot across the world, we've got more and more patients suffering from many diseases where we do not have good treatments. So I live in the UK. Let me just share some figures. So in the UK, our population is 70 million, just under. In the next 12 months, we will have 350,000 people diagnosed with cancer. That's 1,000 people every day. That's 1 person every 90 seconds, just in the UK. In the next 12 months, 14 million people across the world will be diagnosed with cancer. And in cancer, the pharmaceutical industry and many charities and many governments over the past 4 or 5 decades have invested hundreds of billions of dollars of research. But there are still many cancers that are death sentences. Esophageal cancer, pancreatic cancer, ovarian cancer, many brain tumors, etc. We desperately need new treatments for cancer. Let me talk about neurodegeneration. In the UK today, we have 850,000 people with dementia. That's almost the population of Guyana. By 2050, we will have 2.1 million people with dementia. And all of us here are going to live to more than 80 years of age, and 1 in 6 of us will get Alzheimer's. And of course, if you live to 90 or 100, the numbers are even greater. In the UK today, we have more patients than we have carers. And we do not have a good, effective treatment for this devastating disease. Just recently, there was a publication that some of the drugs that have been launched, for example, to treat Alzheimer's from Biogen and Lilly, they have marginal efficacy, but they have lots of side effects, and they're pretty expensive. Aging, it's a massive issue across the world. We have aging societies. Again, in the UK, in the next 20 years, we are going to see a tripling in the number of pensioners with cancer. We're going to see more than a doubling in the number of pensioners with diabetes. Mental health. It was a massive issue before the pandemic. Post the pandemic, it's just got even worse. We've got more patients with anxiety and eating disorders and depression and so on. In the US last year, there were 49,000 suicides. That's 130 every day. This is terrible. We've talked a lot about AMR at this meeting. At the moment, more than 1 million people across the world die every year because they are resistant to existing antibiotics. By 2050, Jim O'Neill predicted there would be more than 10 million. I suggest it will be significantly more than 10 million. And he said if we don't come up with a new generation of antibiotics, it's going to cost the planet in excess of $10 trillion of lost GDP. Rare diseases. We call them rare diseases because there's not many patients with each of these diseases. But the fact is there's more than 7,000 rare diseases. If you add up all the patients, that's more than 350 million patients. 30% of those kids do not reach the age of 5. It can take 6 to 8 years to get a diagnosis. and 95% of them have no approved treatment. Can you imagine being a parent with a child with a rare disease? You're basically just watching your child slowly die. We have massive issues. Colleagues have talked today about the impact of climate change on health, and of course it's going to be massive. You know, pollution, biodiversity, access to food, water, etc. But inequality is a big issue. Even in Oxford, if you live in a nice part of Oxford or if you live in a poor part of Oxford, the life expectancy is more than 10 years different. This is in a tiny town, 7 or 8 miles apart. So these are big, big issues. So what are the solutions? The solutions are manyfold. Of course, we have to translate lab science into the clinic with speed and urgency. Of course, we have to be collaborative because no one person, no one lab, no one institution, no one company can solve these problems on their own. We're going to have to work together. And these collaborations, by necessity, are going to have to be global, not just regional, because all these challenges are global. But the other things we need is, of course, we need innovation. We need innovation in terms of new drug targets, new biological insights, new biomarkers, new ways of stratifying patients, new processes, new ways of working. We need lots of innovation. But I would suggest we need a couple of other things as well. We need great entrepreneurs. Entrepreneurs are people who do risky things. They have a passion, they are determined, they have an idea and they will prove that idea right, and they change the world. You know, you think of individuals like Bill Gates, Elon Musk, Jeff Bezos, and I apologize, I've just listed a bunch of men. But these individuals, they have not just created a few companies, they've actually created new industries, they've created thousands of jobs, they have changed the world, they have produced lots of millionaires, and actually they produce quite a few billionaires as well. We need more entrepreneurs to change healthcare. And we also need great leaders. Great leaders are people who can bring people together, inspire them, energize them, create a vision, and pull them all along and make great things happen. So let me share with you some of the things we've been doing in Oxford over the past 20 years or so. So I used to work in GSK, GlaxoSmithKline. I was there for 19 years. And then in 2008, I came back to Oxford because I was a bit frustrated that in the pharmaceutical industry, there was not enough innovation. Most companies then, and still it's a case, they work on the same diseases, they work on the same drug targets, they work with the same opinion leaders, they use the same technologies, etc., etc. They do all of this in parallel and in secret. You could have 20 companies doing exactly the same thing. The tragedy is that in drug discovery, when we do translation, 90% of the time, maybe even more than 90% of the time, the things that we do in the lab do not work in the clinic. They do not translate into the clinic. So if one company fails, the other 19 companies doing exactly the same will fail as well. That's a horrendous waste of money, people's time, resources, etc., etc. So when I came back to Oxford, I said, right, I'm only going to work on completely novel genes, novel proteins, novel targets. No other academics working on them, no companies working on them. So we pulled in nearly 60 million of funding from the Wellcome Trust, and we worked with 10 pharmaceutical companies who donated close to £100 million of funding. With that funding, we generated thousands of novel tools. So purified human protein, assays, structures, inhibitors, antibodies. These were novel tools for drug discovery. And these tools, what we did, we didn't create intellectual property on them and just use them for ourselves. We shared them with the world. We gave them to any academic on the planet, any biotech and any pharmaceutical company. So at one point, we were working with more than 200 academic labs. We gave these tools out. They enabled thousands of publications. They enabled lots of academic careers. They enabled lots of our academic colleagues to create new companies. And when we gave these tools out to biotech companies and pharmaceutical companies, some of these companies, they actually stopped some of their existing programs and started new programs based on our tools. So by generating novel tools and making them freely available to the world, we accelerated translation, we accelerated innovation, we accelerated open science, and we accelerated enterprise. The second project we did about 12 years ago now, I've been worried for a long time about the impact of Alzheimer's and how we're not coming up with new treatments. Now, 12 years ago, it's fair to say in Oxford, we didn't really have any expertise in discovering new medicine for Alzheimer's. So I initially got funding with Peter Ratcliffe and Simon Lovestone from Alzheimer's Research UK. They gave us £10 million. And then 5 years later, they gave us another 12. And last year, they gave us another 15. Now we have about 60 or 70 people in Oxford working on Alzheimer's drug discovery. They've come up with 3 completely novel targets. These novel targets, they've now partnered with 3 different pharmaceutical companies, and those compounds are now currently in clinical development. So this is what we can do if we can pull the resources and use the brand name of institutions like Oxford to do some of these things at scale. The third example I'll give, and we've talked a little bit about it today, is what happened in the pandemic. So cast your mind back to the start of the pandemic. We had no vaccine, we had no treatment. Even in the UK, lots of people were dying every day. We were all told to stay at home and not work. The streets were empty, the airports were empty, the department stores were empty. So what we did in Oxford, so John Bell, who many of you may know, was the Regius Professor of Medicine. And Louise Richardson was the Vice Chancellor. 2 absolutely amazing individuals. Together with Adrian Hill, Sarah Gilbert, Andrew Pollard, what they did was they created a consortium. They partnered with AstraZeneca, the pharmaceutical company. They partnered with the UK government. They partnered with UK regulators. They worked with many funders like the Wellcome and Gates, etc. And importantly, they worked with the Serum Research Institute in India to create these vaccines. And this consortium together generated a vaccine in 9 months, something that normally takes 9 years. And this vaccine they then gave away at cost price. So the cost of manufacture plus the cost of distribution. And this vaccine saved more than 6.5 million lives during the pandemic. That's more lives saved than either the Pfizer vaccine or the Moderna vaccine. That was an amazing success story. Now, it's very easy as an academic to say we're going to generate a vaccine and we're going to give it away at cost price. But I have to say hats off to Pascal Soriot, who was the CEO and still is the CEO of AstraZeneca. For him to agree to do that was absolutely incredible. And I think he deserves all the accolades that are possible. At the same time, a couple of other of my colleagues, Martin Landray and Peter Horby, they started a program called the Recovery Trial. So of course, at the time, there was no drug that worked against COVID-19. So what they did was they set up this program called Recovery. They worked with lots of hospitals across the country. They accessed tens of thousands of patients who had COVID, and they looked to see, are there any existing drugs that had any benefit in treating COVID-19? And of course, what they did was they first of all showed that hydroxychloroquine, the anti-malaria drug, had absolutely no efficacy, despite what the current resident of the White House used to say. But then they showed that dexamethasone, this cheap generic anti-inflammatory found in every pharmacy store, was effective. And that finding alone saved more than 1 million lives across the planet. More recently, my colleague Adrian Hill has achieved his lifetime ambition of coming up with a new vaccine for malaria. Now, you're probably aware that many hundreds of vaccines have been developed for malaria, but they all kept failing. And then a couple of years ago, Adrian's now come up with a vaccine, and that vaccine is estimated to save more than 600,000 lives of young kids in the continent of Africa every year going forward. This is going to save more lives than the COVID-19 vaccine. This is incredible. The final thing we've done that I think may be worth sharing is that over the past 7, 8 years in Oxford, I've been looking after innovation across the university. And that involves helping students and helping faculty to create new companies, to create new enterprises, to attract venture capital funds, and to create new companies for diagnostics or med techs or therapeutics or climate companies, battery companies, et cetera, et cetera. And what we've done in Oxford is we've trained students in leadership and entrepreneurship. We've also enabled academics. We've made it easier for them to create new companies as well as doing their academic research and teaching. We've encouraged more female entrepreneurs. We've attracted more venture capital funding into the university. So in Oxford now, we get more venture capital funding than any other university in the country. We get more industry funding than any other university in the country. And we also get more philanthropic funding than any other university in the country. And we also get more research funding than any other university in the country. So we're doing pretty well in terms of the funding. So these are just some of the things that we've been doing. And I think what they illustrate is translation, we need to do it quickly. We need great leaders, we need great entrepreneurs, we need to collaborate, we need to partner globally, and we need to drive innovation in everything we do. Let me finish with 3 anecdotes just to try and cement all of this together. So these are things that have happened to me over the past several years, and I'm sure you could come up with similar stories. So in 2005, I was still working at GSK, and I went to visit a Alzheimer's care home. And I visited this patient who was sitting in a side room, and frankly, he was just staring at the wall. He was about 70 years old, he had Alzheimer's, and he was literally, he didn't even recognize that I was there. His daughter was sitting with him at the time, so I spoke to his daughter for about 5 minutes. And just as I was leaving, she held my hand and said, "Please help my father." At the time, I thought, it's too late for your father. The tragedy is today, that was 2005. If that happened today, I would think exactly the same. In 21 years, we have not made much progress, I would suggest, in coming up with new treatments for Alzheimer's disease. The second story, around 2012, a mother of a patient with a rare disease visited my office. The mother lived in a place called Bath, which is about 60 miles from Oxford. Her daughter had this rare GI stromal tumor. Her daughter's physician lived in Cambridge and he was visiting as well. So the two of them are sitting in my office and the mother started to cry. I said to the mother, "How is your daughter doing?" And she said, "My daughter's 21 years old and they've just removed the whole of her stomach." And I sat there thinking, how on earth does any parent cope with that? A few months later, on a Sunday afternoon, the mother sent me an email saying, "My beautiful, precious daughter has just died." I felt pretty awful because the mother had come to me asking me for help and I did nothing. The third story is about 2019. On a Sunday morning, I was giving a public lecture. And at the end of this lecture, this lady comes up to me and she gives me this slip of paper. And she said, "Professor Bountra, if you want to access my daughter died with a brain tumor the previous year. She said, if you want to access her brain, this is where you can get it from." So on this slip of paper was her daughter's name, the date of birth, the day she died, and where her brain was stored. Immediately after this lecture, my wife came to pick me up, and I said to my wife, "I've just had a complete stranger come up to me and offer me the brain of her dead daughter." Ladies and gentlemen, this is how desperate patients are. This is how desperate patients' parents are. And this is how desperate patients' relatives are. I used to work with a brilliant man named Tashi Yamada, who was head of R&D at GSK. And he used to say to me, he said, "Chaz, patients are waiting." And they are. Patients are waiting. And unfortunately, the numbers of patients are going up. All of us are going to be affected by some of these stories, I regret to say, in our future lives. Either ourselves or somebody we care about. So I would just say again, we need to accelerate translation. We need more innovation. We need more partnerships. We need to think globally. We need great leaders. We need great innovators. And we need great entrepreneurs. Across the world, there are millions of researchers, but not all researchers are leaders. Not all researchers are innovators, and not all researchers are entrepreneurs. I feel so passionate about this that a few weeks ago, I decided to leave the university and start working with our next speaker, who is arguably one of the smartest people I've ever met. He is a great leader, he's a great innovator, and he is a great entrepreneur. Ladies and gentlemen, thank you very much.
Thank you very much, Professor. That was a masterclass in how to make a huge global impact. And I think also very much reinforced the President's remarks earlier today about the need to innovate and the need to bring that to patients in a timely fashion, more nimble than we've been able to do in the past. One other quick announcement about a car. I'm afraid there's another car blocking someone in. It is license plate PRR 3776 and is a red Kia. If that's yours, please move it. And it is now my honor to welcome Dr. Niven Narayan, the President and CEO of BPG Bio, I believe also co-founder, who will be speaking on can innovations in precision medicine and AI improve health outcomes in the Caribbean. Welcome, Doctor.
Thank you. So it's very much an honor to be here with all of you today, I have to say, for a few reasons. I think this is a sentinel time and an extremely important moment in hemispheric biological security. I think we sit on the cusp of an innovative curve that's going to see this hemisphere stitch innovation that's occurred in North America, notably in the U.S., because I have to say I'm also here as a Guyanese American, so that's very special to me. But But I also, I think we've heard a lot today, and I know that lunch is next, so I'll try to be as quick or succinct as possible. But this is a moment in time that I think that we need to take stock. We're all living comfortably in an age of technology. Even with the geopolitical, volatility and macroeconomic changes, it is an exciting time. We get up in the morning and we grab our phones and it's always, well, this is negative, that's negative. No, hold on a second, like time out. It is positive. Because all the things that Chaz just spoke about, there's a chance, hopefully Chaz, it's not going to take 21 years for treatment in Alzheimer's. We're starting to make some incremental advancements, Finally, like Lilly and Biogen in Boston are doing some great work. But I will say this, I have a slide deck if the AV team can please put up. I want to talk about the practicality of the time we're living in. There's an opportunity to, from a technological perspective, we're also living in the age of biology. We've comfortably come out of the age of physics and chemistry that's allowed us to understand structure and function, and mathematics has helped to solve a lot of the world's most difficult problems. It helped to end the World War. It helped to create a vaccine and a pandemic. But now AI, so AI is really just math. Did you all just know that? So we hear artificial intelligence. Well, it's artificial intelligence is just real math. And it's put onto a hypercluster of supercomputers. And then we end up with, with algorithms that help us, demystify biological mechanisms, to help us make sense of big data, to help us think of problems in a different way. But I think most notably, it helps us to offer a hypothesis that is outside of the capacity of the human brain. So I don't know if someone can help me to. Should I? How do I play? I mean, I just said all this great opening statement. I'd love to show you my, the presentation, Yeah.
My apologies for the delay. I used to have a colleague who would say, I don't have a PowerPoint, I have powerful points. But we do have a PowerPoint for you, and please bear with us.
Just to keep things positive, they say under 64 degrees, which I think it is. It feels like it's under 64 degrees in here. We burn more calories. So Manjaro and the GLP-1s may not be approved in Guyana, but the ecosystem that the president talked about is inducing, brown adipogenesis. So, there is a positive to the extension here.
I think this was intended to keep us awake before lunch. You know, if we have a couple of minutes, we were not really going to have any time at the end for questions. Might I propose that if we have 1 or 2 minutes, if anyone has a burning question for one of our speakers, that you could take this opportunity to ask? All right, I will jump in then. I have a question up at it. I think all of our speakers today could very much be labeled change agents, but human beings don't like change very much. It's very difficult to persuade us about the need for innovation and change. What techniques, what words, what ways of making arguments do you find to be effective, briefly, that have been helpful at putting innovation into practice? Please, do you have the mic?
You want me to answer? So in Oxford, I think we've seen a bit of a culture change when it comes to innovation. And the way we've done this is by almost publicizing role models and successes. So 7, 8 years ago, I think it's fair to say in Oxford, there were very few academics who were innovators or entrepreneurs. In Oxford, frankly, it used to be, oh, we don't want to do anything to do with industry or money creation or whatever. But now we've got a number of academics who they're on their 3rd or 4th company. And of course, if you publicize this, everybody else says, well, if they can do it, then I can do it. So it's produced a real culture change. We've also had many students come to me and say, Priya, I don't want to just do another PPE degree and then go and work at Goldman Sachs and then become the next prime minister or something. I care about the climate emergency, or I care about mental health. I want to create a new company. I want you to teach me how to be a leader, how to write a business plan, how to talk to venture capitalists, how to build a team, et cetera, et cetera. So many of the youngsters are very passionate about all of this innovation and enterprise, et cetera. So I think those are a couple of thoughts.
Yeah, so maybe I can just add in kind of the organizational culture in which I operate. I think innovation really requires creating safe spaces for people, and also accepting that sometimes failure is okay. You don't always have to succeed, because if you fear of failure, then you're not going to try to do things differently, to think outside the box, to innovate. So that's what I would add to that. Thanks.
Do we have any other questions from the audience?
I have a comment. So, Dr. Basu, I saw it with the pandemic fund. You're looking at over $12 billion. And it reminds me back to the PEPFAR story in 2002, 2003, when they allocated $15 billion. And I look at similar locations where pandemic fund is working in the same space. So the question is, since the PEPFAR funding is going away significantly in a lot of the Southern African countries, Sub-Saharan Africa, do you see that? Are you piggybacking on some of the infrastructure that was set up by PEPFAR, like the labs and the infrastructure that has been there since PEPFAR time, or is it just totally disconnected from that era of funding to this era of funding?
No, that's a good question. So firstly, I just want to clarify that the $11.5 billion portfolio that I spoke about is actually because of the catalytic sort of model that that the pandemic fund has. So it's not $11.5 billion allocated by the pandemic fund, but rather it's $1.4 billion that helps mobilize additional $10.1 billion, right? So that's how we end up having an $11.5 billion portfolio. I think the important point here is that we're, very much a country-driven, country-led model. As far as possible, we try to make sure that the resources actually go to countries on budget, and then countries decide how they want to spend the money to fill gaps. So we're not sitting in Washington, D.C. and saying to countries, spend it here and spend it there. We want good good plans, good proposals that we have a technical advisory panel that reviews them, and we have a board that that decides on what to fund and what not to fund ultimately. But the proposals themselves are country-led. So if funding is going away from here or there or whatever, it's the country that decides how it wants, where the gaps are and what it needs the funding for. And that also, really, I think, ensures sustainability and durability because, the project is for 3 years, but if you're training workforce, you want that workforce to continue to be trained over time. If you're upgrading a lab from BSL2 to BSL3, you want to keep, you want to maintain that standard. So that kind of long-term sustainability is what the country. And I should say also, it's not just countries, it's also regional entities. So if we're working with CARPHA, then we're telling CARPHA, you tell us what your gaps are, and and then you get the money and you fill the needs. So thanks.
Thank you for that. I'm sorry to do this over the loudspeaker, but do we have an IT person that is going to be able to help us get Dr. Narayan's presentation up? All right. In that case, while we're waiting, any other questions from the audience for our speakers? Yes, I see a hand over there. Okay,
Hello,
next.
yes.
You first, you next.
Yes, Colleen Radix from Ross University. I just had a question about the impact of shrinking resources on innovation. Do you think that it helps to catalyze innovation out of necessity, or do we need financing in order to catalyze innovation? Just wondering about your thoughts on those two sides of the coin.
That sounds like a question for Professor Butcher.
I mean, I personally think that there's potentially more resources for innovation. I think across the world, we all realize we've got some enormous challenges and we need to do things differently. And we need new technologies and new processes and so on and so forth. And, that's why there's lots of these venture capital groups who are growing in number. Many governments, certainly in the UK, they are putting more and more money into innovation and research that creates solutions for problems, as opposed to just pure blue skies research, etc. So, and of course, this innovation, enterprise, commercialization. I mean, now there's so much happening in China. There's so much happening in the Middle East, in Singapore, Brazil. Everybody's doing it. And in the drug discovery space, I mean, when I went into the pharmaceutical industry in 1988, I mean, in those days, drug discovery was largely in the US, UK, Switzerland, France, and a little bit in Japan. And now everybody's trying to do it. And even in the US now, it used to be Boston and San Diego, but now it's Houston and Miami and New York, and many philanthropists, many billionaires are putting lots of money into it. So I'm optimistic on that front.
We had another question over here to the left. Yeah, I believe so. Was that Dr. Basu? Was that the next person? Yeah, okay. Yes, please go ahead.
Much. Yes, I think it was very interesting listening to some of the acknowledgement of what the problems are, affecting the CARPHA community in particular, but perhaps globally as well. And my question, particularly to Professor Boutros, is regarding the non-communicable diseases. I mean, it's really important that we're addressing innovation and research around that. But there seemed to be a gap in that kind of early window when the molecular changes are taking place, and that is the most crucial aspect that is still remains blind to us from a clinical perspective, because that's the period during which there are no symptoms. And I wonder how much of the funding and the strategies that are being put into place are aimed at looking at that rather than more of the reactive type treatment options, which is currently what our medical approaches are quite largely. So it would be really good to see those types of emphasis being taken forward, and it's something that we will probably talk about at later stages. But it would be interesting to find out whether there are some specific approaches that are aiming to address those gaps. Thank you.
I don't know if this answers the question, but I mentioned mental health as a big issue. Now, frankly, as a community, we have not been good at coming up with new treatments for psychiatric diseases. And, but I do believe that in the next couple of decades, we're going to see big step changes in our understanding of brain disease. And the problem with many brain conditions, of course, is, you can't access a human brain biopsy. You can access human cancer cells and study them in a dish. But so I'm more optimistic. I think we're going to see a lot more changes. The problem, of course, with psychiatric diseases or brain diseases, many of them have been developing for probably several decades. They are massively influenced, not just by genetics, but they're influenced by environment, diet, sleep, stress, early life experiences, pollution. I think all these things have a big effect, etc. So again, I'm optimistic about what's going to happen in the next couple of decades.
Thank you to our speakers. That was an unexpected opportunity for questions, but I do apologize for the delay. I think we can go ahead now with Dr. Narayan's presentation.
All right, can you guys hear me? So I don't know what the hell happened, but I joined someone's like the Wi-Fi from someone's phone because the Wi-Fi is out. So please, I beg you, just don't touch your phone. I'm not going to move. No one touched their phone. We'll make this happen. So anyway, so as I was going into this presentation, look, I was just saying we're comfortably into this age of biology, and this opportunity that the Caribbean presents is extremely interesting, because in a post-colonial Caribbean, we have populations that are from Europe, from Africa, from India, from China, the indigenous individuals, etc. But what's also really cool is that they're families that are monogenic. Indians who've married Indians, or Africans who've married Africans. But we also have families that have intermingled, and that's really it's a healthy thing for biology, but it's also a really interesting case study, because what we do know is that the cancers in the Caribbean are more aggressive. The hypertension and blood pressure is more uncontrolled. For diabetes in the Caribbean, we have more comorbidities. So there's a higher incidence of wound healing, impaired wound healing, end-stage renal disease, cardiovascular disease, dementia, etc. These all present an interesting opportunity to learn, why is that? Why are what are the biological underpinnings that make these diseases so much more aggressive or uncontrolled or non-responsive? And why it is important is that it's important not only for the Caribbean. So one of the most valuable assets in this region of the world, and I hearken back to hemispheric security or biosecurity, is the basis of information, the insights that are going to be inferred. And the conclusions that we see from these data not only help us to create more specificity of understanding and diagnosis for diseases in this region, but the data itself, like in Boston we talk, or San Francisco we talk a lot about a data lake. A data lake is a resource information that amalgamates different types of data sets or different types of information. These data, like we talk about data centers, we talk about artificial intelligence, global collaborations, the portability of the anonymized data, because we're not going to have any privacy issues, et cetera, to everything where we talk about building public trust. How do you build public trust? You communicate. You be transparent. You be honest about the risks. There's a 360 feedback of information from the innovator to the pharmaceutical company to society to community. And these models have already been successfully portrayed in other parts of the world. We're now going outside of the OECD nations, like in the Caribbean, where these opportunities are taking hold. But I don't want this to be didactic. I don't want to be, look, there's been all types of, silly things with this presentation already. So I want to just be clear about the time is now for us to act. The opportunities are there. The technology is enabled. And as we even heard from President Ali this morning, the embracement of reality is on the ground. There's tons of things, for us to learn about, regulation. I sat here today and I thought about things that are, Commissioner McCary at the US FDA has lately had a pretty big push on rare diseases and ultra orphan diseases. And I thought for a second, well, an orphan disease is categorized as something that's less than 200,000 cases. But if we can just like truncate the bits of epidemiological cases under 200,000, why can we not like borrow some of the policies and the things that are happening at the current FDA? So let me try to get to these slides as quickly as possible. And I'm going to go through it. So bringing the voice of the Caribbean into the it's not moving on here. No, it's not. I think I'm on a Zoom. Okay. So bringing the voice of the Caribbean into the global innovation ecosystem. So the layer of diversity that we see that I just spoke about is largely absent from the global fingerprint on innovation. I don't know if these guys, can you please go to the next slide if you're controlling it there?
That's not your screen anymore. I think maybe you can say advancing or something.
I don't know.
Apparently your deck was all linked to a cloud with the cloud profile.
Okay. I'm trying to share on this. Oh no, no. Advance the slide. Hey, can you guys please advance the slide, please? The next slide. I don't know. I mean, I got out of someone's taken off the Zoom. Someone's taken it off. Yeah, I can share it again. Still moving something. Oh.
How you connected?
I'm on Zoom, but I don't know why it's not connected.
I believe I can talk.
If not for anything else, you will always remember this presentation. Always, no matter what, you're always going to remember this. Yeah. Seems to be working again. Let's see. Okay, so the equity gap here. So I talked about the opportunity, but what is the opportunity? If you look at the Caribbean and Latin American population, it comprises 10.8, as of today, 10.8% of the overall world population. Yet the voice of all the drugs that are approved or in development comprises for less than 1% of individuals from this region, or even Caribbean Americans, or Caribbean in Britain and other parts of the world. So even the Caribbean, these data include the entire diaspora, not only the individuals in this region. So if you think about that, drugs, and you ask yourself, why do the folks from the Caribbean not always respond to some of these drugs, these chemotherapies, ovarian cancer, breast cancer, colon cancer, pancreatic, etc.? Well, they were never in the clinical trials. So the representation of the biology was never inculcated into these processes. And look, there are many reasons for that. I had a biotech and a pharmaceutical, company. So, it's even in the United States, only 3% of all individuals who enter into clinical trials are minorities. So, I got the one slide. We'll try it again. And this burden increases significantly. I touched on diabetes, but if you look at cardiovascular diseases, it's the leading cause of morbidity and mortality in underrepresented research, because the research samples, we hear about the development of a biobank, which I'll get into. The actual tissues and the cell lines and the material that's used in research is also not represented. So Dr. Simone Badal at the University of West Indies, who the people in here may know, she created the first ever prostate cancer cell line a few years ago in the Caribbean, and I've been doing some work with her. What's really interesting is, chemotherapies that we use even on the African American population in the US, when she used those samples and tried to sensitize the cells and the responses to chemotherapies, they were different. So the cell, so which means it's not really a mystery. If we take the time to look at the biological underpinnings of why this is happening, it is not a mystery, because the biology is so different. So from a gender base and the augmented incidence, so we know that in the Bahamas has the highest rate of per capita incident and also death of triple negative breast cancer. Prostate and colon cancers, breast and ovarian cancers are a significant issue here. And it's not only an issue of, well, it's easy to say, well, these cancers are diagnosed at a more advanced stage. That's partially true. But the other part of it is the pathways and the genetics and what we refer to as the mutational burden of these cancers are very different. This is why human genome sequencing is so important, so we can start to understand how the mutations in the Caribbean are different. I promise you I'm on the next slide, but yeah, I'm sorry. So I'm just gonna move forward. So how are we going to do this? So there's something called population health. And in the U.S., there's the, the million person, genomic program that's been advanced, the Genomics England program in the UK. But it's about building a community, what I refer to as community biology. And community biology, and it was really fun. I heard the president talk about churches earlier this morning, but it is literally going out into the community in mobile units, bringing together various stakeholders, schools, patients, et cetera. Importantly, the families and physicians. I'm trying to get to the next slide. It's really bad like that. Yeah, why don't you give me the answer then? That's the whole problem. Okay. Okay. This one? Are you on? Where? Okay. All lowercase? It's one. We're done. Now, when I'm on someone else's Wi-Fi, so please, I'm going to jump ahead to precision medicine. So, what is precision medicine? Precision medicine is defined as giving the right drug to the right patient at the right time, and if possible, at the right dose, because dosing is always an issue in medicine. But the real way of bringing the layers of biology is not only genetics. Like, we're not only our genes, we have 30,000 genes, but there's so much more to the human layer of biology, or proteins, or lipids, or fats, or metabolites, et cetera. We now have the capacity through something called multi-omics, the ability to sequence and annotate and measure the levels of proteins and lipids, et cetera, from various tissues in the body. So when we talk about patient biology, we have to think about this in the full narrative of who we are, the full narrative as ourselves, as patients. And, Chaz, touched on this. We need to understand novel drug targets, understand which proteins or genes are subject of a potential biomarker for early disease diagnosis, but also for potential drug. And even in cases where drugs exist, maybe there's a drug that Novartis made in Switzerland that was indicated for psychiatry, but understanding the chemical in a different population, it may be repurposed for a completely different disease. And this biology first approach is important, especially as it pertains to biobanking. And how do we build out this process? Internally, we refer to this as an interrogative biology platform in Boston. Has produced a number of drugs that are now in late stage development and nearing approval at the FDA. But it's to acquire, in its most simplest sense, the ability to acquire blood and urine and tissues from patients, the processing of these data sets, the analysis not only from the perspective of what are the biological elements within the tissue or within the cells, but also between how those cells are communicating, how those the proteins change over time, and then the AI models that are built. And I won't get into it here, but I will mention AI needs to be deconstructed in its different forms. we cannot use just a broad stroke, category when we talk about AI. There's something called generative AI. Generative AI is based on what is already known, prior, knowledge, and obviously that it doesn't always work. So if we want to discover new biology, new pathways, it's important for us to use causal AI. Causal AI is what BPG and other groups within government have been using to try to offer new insights into disease model, and then of course getting to the hypothesis and validating this. So this supply chain of development, from the acquisition of tissues, processing the data sets, et cetera, then result in optimized, clinical trials. So how do we start to think about doing these clinical trials, even here in the Caribbean on the ground? Building these models and understanding the insights first will then help us understand what type of clinical trial makes the most sense. Is it a large trial? Is it a smaller trial? Is it a more diverse a trial? And then before we even think about the dream of precision medicine, actually creating the medicine. So again, just like going back to the practical elements. And then when we think about medicine as a whole, it's not unilateral, it's not unidimensional, it's not static. We don't just wake up and have cancer or just wake up and have Alzheimer's disease. I like systems medicine. We're built as systems. We're built of a constant dynamic process. Chaz talked about Alzheimer's disease, but the example here in this video is about, just take liver cancer. You have a disease in a normal liver. You take the tissues from the same liver, the same patient, and you look at what we refer to as biological intelligence, looking at genes, looking at proteins, looking at lipids, how they interact with intracellular, parts of the cell intracellularly and within, so that we can create what we refer to as biological intelligence. And for the sake of time, I'm not gonna get into this, but I wanted to give you real examples of how this process has worked. I'll just say that the lead drug in our company, BPM 31510, has been developed for multiple cancers, aggressive solid tumors. And why it's important is because we've learned so much from seeing how this drug acts in very highly aggressive solid tumors. But the data, when we talk about the portability of data out in the Caribbean, it goes both ways. The data that's been created on this drug and with all our partners around the world, bringing the data set into the Caribbean to say, well, we see how aggressive solid tumors respond to a master regulator in metabolism. Let's compare it to some of the data sets that can be, created here. And a biomarker is either a protein or a gene or an element in the biology that guides our insights, that helps to guide our decisions. So again, the samples and acquisition and data compliance. Maybe I'll skip over this, but I'll give you an example of a project we did with Harvard Medical School. It was led by Harvard Medical School, but there were other centers, the Mayo. I don't want to leave anyone out. Even what we did is we took, and you have the capacity to do this. We went into live surgeries, 435 patients with pancreatic cancer. We compared them to individuals across the spectrum of disease, because cancer is not just one. It's not one process. There's early cancer, there's malignancies, there's metastatic cancer, there's metastatic refractory cancers, and we took live, surgeries where we took adjacent. We took the tumor tissue and adjacent healthy tissue from the same patient with the pancreatic juices, and then we took blood and urine from these patients every month for as long as they lived, and some of them lived over a year. And we were able to profile, like in the last video, all of the various elements of the biology over that time period. You can imagine how much data this was. We then put all that data into a massive AI system, and we've now partnered with the Oak Ridge National Labs. Since the pandemic, we have the capacity to use the world's fastest computer. So we're processing these data sets from these patients in a live manner. And we were able to define the world's first clinically validated cohorts of early disease biomarkers in pancreatic cancer. This is now ready to be a product. So taking a biomarker for a disease that we cannot, these patients in pancreatic, they don't have symptoms until the disease is advanced. A lot of pancreatic cancers are diagnosed at stage 4, or incidentally because the doctor's doing a scan on another part of the GI system. But early disease diagnosis in aggressive solid tumors are exactly what's going to make the mark. These are the types of projects that can be readily translated into the Caribbean. The other one I'll think is very pertinent to the Caribbean. This is a project done with the U.S. Department of Defense. A lot of folks don't realize there are tons and tons of research done, within the DoD, et cetera. So this is what was led by the Centers for Prostate Disease Research at the Walter Reed. We had access to 20,000 cases, and our soldiers are examined every 3 months, and tissue or blood and urine are collected every 3 months. So imagine the biobanks that exist within the military. But one of the big issues within the military is that our African American individuals have a higher rate of prostate cancer. Our pilots have a higher rate of prostate cancer. Everybody thought it was just about G-forces. It's not. So there was a project where the DoD said, well, can we use your platform? We'll give you the tissue, we'll give you the urine, the samples, et cetera. Can you guys help us understand some of the nuances between different types of prostate cancer? Well, over a period of about 4.5 years, we worked extremely closely. This was probably the most massive data set we've ever built. Clinical data, biological data, demographic data, outcome data. We were able to actually discover this protein, filament A, which is a part of defining how a cell is going to be shaped and formed, et cetera, as a microfilament. But filament A was specifically, as a biomarker, had higher rates of filament A in individuals who presented an opportunity where, in the Caribbean, for example, I think most men around the world, but especially because of cultural nuances, most men will not get a biopsy in the Caribbean. I could be wrong, but I think I'm right about that. But if you go to a man and say, look, you have an enlarged prostate, you're having these symptoms, you're not going to have to get a biopsy. Take a blood test. Just give us a chance. If this blood test is positive and it looks like you have a higher rate of filament A, the data is suggesting that you probably have a higher likelihood of prostate cancer. Now, this is a local, actionable, impactful biomarker that brings the doctor, the patient, the family together, but it also helps to have an immediate effect on society. So this is, again, something that's ready to be productized. Maybe I'll skip over some of these. I've talked through the importance of epidemiology, how important it is to, create partners. I'm gonna just end on these 2 slides. These are the stakeholders that really matter. If you're gonna build a health ecosystem, it's not just physicians and scientists. There are tons of folks like, pharmacists, biostatisticians, regulatory experts, and they don't all have to be local. This is why partnerships are so important. And then growing the leaders of tomorrow is going to take a lot of mentorship, collaboration, cross-border collaboration, et cetera, in both ways. Data sets going outside of the Caribbean, coming into the Caribbean, to really catalyze and digitize this. But I'm going to end on this video, which I hope to God it plays, and you can hear the sounds. And if anybody who doesn't believe in God, if this video plays, there's a God. So
welcome. Today, I will show you how we can ensure that every patient in the Caribbean receives care that truly reflects who they are. So let's start. The Caribbean is a crossroads of populations: African, European, Indian, South Asian, and indigenous ancestries. We are a true microcosm of global human genetic diversity. shaped over generations. In our hospitals, we see it every day, biology shaping how patients respond and how we make decisions. By combining genetic data, patient phenotypes, multiomics data, and clinical records, powered by artificial intelligence. Precision medicine promised to guide decisions based on each patient's biology. But in reality, it only works if we truly understand what drives those differences at their roots. 900 million people, a unique biological microcosm. Yet these populations remain largely absent from the research guiding our decisions, built predominantly on North American and European populations, leaving critical gaps in how we understand and treat patients. But this diversity is not a limitation. It is one of the greatest opportunities to advance how we understand disease for the Caribbean and beyond. By building a Caribbean-centered platform, integrating patient data, multi-omics, and causal AI, we can uncover the true drivers of disease and guide therapies grounded in real biology. Precision medicine only works when it reflects the patients it serves. For us, that is the challenge and our opportunity to finally get it right.
Thank you. Thank you all.
Thank you very much, Dr. Nareen. Sorry, apologies for the glitches in technology. We haven't gotten it right yet. And thanks to all the speakers. We are running very late. So we're going to break for lunch now. So put your hands together, please. Don't leave. Put your hands together for all the speakers, and thank you for being here and being your patience. We're going to break for lunch now, and we're going to have 45 minutes for lunch. Lunch is outside the courtyard, in a courtyard. There's a tent, a covered tent. I will take you, go downstairs and walk towards the back, and there will be volunteers guiding you to lunch. We will reconvene in 45 minutes.
Yes, yes. So there's a VIP lounge that couldn't have the. Oh, okay. I'm very excited you're here today. We're all it's great to I've worked
much of this has been funded by the Pandemic Fund. So if I were to take you through this, the first one, Regional Integrated Early Warning Surveillance System, I really want you to treat this as an umbrella framework then. And all the other components, all the other data modules or repositories are really unified in this umbrella framework. And with this framework now, we are adding on the features of the automated notifications, the alerts when thresholds are passed. We are using that visualization, creating those dashboards to really provide that bird's eye view. Moving on to syndromic surveillance, we are bolstering again the aberration algorithms, having that early warning configuration there. The tourism and health information system, mass gathering surveillance system, and the cruise vessel surveillance system. All these are functional operating early warning systems that CARPHA has, and these are being implemented in countries currently. Tourism and health information system is used to monitor on land-based tourism facilities, mass gatherings for events in the Caribbean, large mass gatherings like carnival, music festivals, food festivals as well. Caribbean vessels surveillance system is used for maritime surveillance, and we have enhanced this specific surveillance system, and we have now included the online upload of the maritime declaration of health form, as well as we also added the feature where you can notify islands downstream or downline in the cruise ship's itinerary if a certain threshold has passed. Climate integrated disease early warning surveillance, we have vector-borne disease early warning surveillance, foodborne disease, that One Health approach. We're looking at, of course, that coordinated approach, right? We're looking at including clinical, environmental, animal, and having it under one module, one framework, having that intersectoral coordination. Expanded integrated environmental surveillance. This is still a work in progress, and we are continuing to advance this. But we're looking at water surveillance. We are looking at wastewater surveillance. And this too will be integrated under the umbrella of this regional integrated early warning system. And lastly, we have environmental information monitoring, which really deals with social listening, right? So it analyzes the chatter. And with that, we could have potential early signals to see really what the community is talking about. And we could, of course, tailor our risk communication approaches to suit. In terms of CARPHA innovations, I won't speak of it too much because I know we have an upcoming presentation on this, but we have expanded, enhanced our regional capacity across the region. There are new microbiology tests with AMR as well included across the 3 campuses in Jamaica, St. Lucia, and in Trinidad. And we also have strategic partnerships with the CARICOM regional security system, as well as Caribbean Airlines. In workforce development and emergency response, we spoke to this already before in the morning. We have novel emergency and response tools. We have that fictional island where it's that safe to fail environment, right? And it really allows member states to get fully involved, to explore the operations, to identify the bottlenecks in coordination, in surveillance and communication, and especially when there's crunch time and we need to make a quick decision. The timeliness metrics as well is based on a 717 framework where there's 7 days to detect, 1 day to notify, and 7 days to act. But of course, in the Caribbean region, again, knowing and understanding the context of the region and the importance of tourism and our national health systems, there is need to act quicker. And sometimes 717 might just be too late. Impact and significance, of course, these innovations, these CARPHA innovations, really, they lead to a more coordinated response. We have those integrated electronic systems with quicker detection and alert. We have those lab innovations, those strategic partnerships for enhanced sample transportation, for quicker detection of pathogens, for enhanced regional laboratory capacities. We have trained regional workforce across the different components of surveillance, the different components of lab, and so forth. And all in all, what this leads to is quicker turnaround times, reducing the number of outbreaks, and overall the enhancement of regional health security. So basically, in conclusion, what this presentation is about is really to highlight the Caribbean context and to really state that a one-size-fits-all approach may not work, and we need to have specific Caribbean interventions for us in the region. And CARPHA is taking that leadership and having these Caribbean tailored interventions, and it is through surveillance, laboratory workforce, and underpinning all those things. We have those partnerships that can accelerate this. So, in terms of acknowledgement, I would like to thank the CARPHA, our Pandemic Fund team, Pandemic Fund, of course, the IDB, other partners, agency, and member states for really supporting the CARPHA innovations and making this possible. Thank you.
Thank you very much for that presentation. Questions from the audience? Well, I'll go ahead and get us started, so I'm not going to let you off easy. Well, the question may be easy. In terms of when I hear surveillance system, realize I have a military background, so I have my own visual of what this may look like. But when we look at the data that's feeding your surveillance system, is this diagnostic data? In other words, a confirmed diagnosis of dengue or confirmed diagnosis of something else is, laboratory made or clinical. Is that what's filling the dashboard, or is it more even basic data of we have 10 unidentified fever cases in a single city that, type of thing? So what does it look like that we're seeing on your
Sure,
dashboard?
so it's actually both. So we have the laboratory component that deals with the confirmatory or the diagnostic detection specifically to tests, right? So we have that confirmation part of it. But also in terms of CARPHA, we look at syndromic surveillance. So we're looking at different syndromes that give us essentially early warning predictions. We're looking at the syndromes such as fever and rash, fever and respiratory symptoms, fever and neurological. We have 6 of them that we're really focused on. And once, for instance, once we have that historical data, once we can say that there's an aberration or something unusual is occurring, it can mount an investigation. We know then, okay, this is something we need to look into. And also, just on the when you said military, it also nudged me to say something else, because during, I believe it was MPOX, we also collaborated with CARICOM Impacts, which is crime and security, implementation of crime and security in the region. And we partnered with them through the APIS, the Advanced Passenger Information System, that really, gave us, confidentially, of course, the relevant person, gave us that indication when specific persons are coming in, for instance, where there's a high level of threat.
Right.
So there is that communication as well.
How do you collect so the disease aspect or the diagnostic aspect is fairly straightforward. You get a laboratory confirmed diagnosis of, malaria, whatever, is straightforward. How do you collect the syndromic, the 6 that you mentioned, in somewhat real time, and how do you process those? Because that's really the power of this sort of thing.
Yeah, and exactly that's where we're moving towards, right? That's the goal we want to achieve. Because we do have a system in place at CARPHA where we collect this sort of data on a weekly basis, or a 4-weekly basis as it used to be, but we understand the urge to report in real time. And through these early warning systems, we really want that real-time edge, that automated feature. And hopefully, when this becomes very, very easy, it will encourage member states, of course, to report very, very quickly, and especially being it an online or electronic version. And some of this is being done, as I said before, we have some systems that are already functional, and we are seeing this once we have that consent reporting.
Great.
You good?
Any questions? All right. Thank you very much.
Okay, thank you.
Sorry. No, wait.
No.
Yeah, you mentioned the real-time reporting. Is this reporting be done within the country or within the regions? And what's the time span in reporting these results?
So with CARPHA, we are at the regional level, but of course we work nationally with our member states, and we have 26 member states. So once we have and we do have that relationship with member states, that we have that routine reporting. So once we get that information, right now it might not be where we want it to be, but at least where the goal is done, it will be that automated report. So when it's inputted in the national system, at the same point then, at the regional level, we would see it. So that's the goal of it. That's what we want to work towards, for it to be in real time.
And is there regulations? You guys have formed regulation already in terms of protecting
the data?
The data and all of that?
Yes, so we at CARPHA, we take cybersecurity and data privacy and policy very, very important. So we do have those things in place. And of course, the data is the country's data, so we don't try to say that the CARPHA owns the data. No, it's the country's data, and we just provide the analytics to make it easier to visualize and get that regional perspective.
Okay.
Yeah.
Could I?
Dr. George?
Thank you so much.
Easy question, please, Dr. George.
Yes, okay. So CARPHA has been very instrumental in our mass gathering surveillance, where we have large crowds, we get real-time information. We do this on a daily basis. So when we hosted Cricket World Cup, we got real-time information on, let's say, food poisoning, gastrointestinal outbreaks, injuries, the full gamut of stuff. And I think that has shown us that we, as member states, have the individual capacity to generate real-time data. The other issue is that the Russian fever, this region is at any point in time can have a measles outbreak, and that is a surveillance system which needs to be quick, because we need to intervene fairly quickly with respect to isolation of the case, quarantine of suspected individuals, and giving the appropriate treatment where necessary. So CARPHA has really stepped up in terms of regionally allowing member states to report quickly on many diseases which previously would have taken some time. Thank you.
Thank you, Timo.
Excellent. We thank Dr. Kisundan.
Thank you.
All right. Okay, so at this time, I'd like to invite Dr. Brian Armour, who will be speaking on unlocking surveillance potential through CARPHA's novel regional integrated early warning surveillance system. And Dr. Armour is from the Caribbean Public Health Agency and will be sharing presentation 02. Dr. Armour.
Thank you very much, Chair. Good afternoon, one and all. I'd firstly like to thank the collaborative authors from CARPHA within the Pandemic Fund Project, as well as other CARPHA departments for presenting this paper, and for the Evaluation Committee for accepting same. So I know it would have been said this morning, but against surveillance challenges in Caribbean small island developing states, based on fragmented surveillance systems cross-border, small, generally under-resourced populations that are very tourism dependent, such that if you do have an infective case, it could propel disease spread across borders. Based on our geographical positioning, we have high vulnerability to disasters and climate-sensitive diseases, and inability to detect cross-sector signals and emerging threats, and have a very unique exposure in this region and vulnerability to quite a wide array of public health threats. Why the need for an integrated early warning and response system? Simply put, outbreak in one CARPHA member state can rapidly spread to an outbreak for the region. The traditional systems that do exist tend to be siloed, as well as they do have delayed insights. And in terms of the emerging global literature, multi-source real-time surveillance. I would say at this juncture, in terms of, in many settings where CARPHA works in an ecosystem with the CARPHA member states, you do have that spectrum from the individual healthcare data that is as real-time as it could get. But as we know, the general common good, there are several dimensions at that level of care, whether they be political, economic, and human capital delays, that goes to the, what I would like to call the traditional surveillance end of the endemic diseases, that you do have some latitude to have a relative delay to analyze that data. And that, of course, informs national and regional policy regulatory standards and also allows for mobilization of resources. But then when you do have these scenarios that you have in the Caribbean, where we saw the COVID-19 pandemic and there are unique gatherings, for example, you do need a middle spectrum sort of surveillance. Yes, information for action, as I said before, at the longitudinal level, but if you need information for action based on a potential for emergency, or for emergency becomes urgent, then the need for the integrated early warning and response surveillance system exists. And in terms of being creative is where CARPHA has made some strides, particularly through the Pandemic Fund project. So in terms of the innovation, speaking in this paper of the Regional Integrated Early Warning Surveillance and Response System. And this has really transformed the traditional fragmented surveillance areas into an integrated early warning intelligence and response system. So the objectives as presented in the abstract and manuscript was to develop a multi-domain integrated early warning surveillance and response system. So this real-time detection across several facets of surveillance areas that I said would normally exist for endemic channel diseases would allow, where there's risk for an acute increase in the detection signal, in order for it to be detected real time with this innovative tool, whether it be syndromic surveillance, tourism health, laboratory pickup, antimicrobial resistance issues, foodborne disease, vector-borne disease, and even the information monitoring surveillance. So therefore, with this, we would be in a position to strengthen regional epidemic intelligence across all our 26 CARPHA member states, and also to, in particular, support the One Health surveillance concept, which is the ecosystem of transmission between the human, animal, and environmental domains, and of course, engender the appropriate timely response. So what has been designed? A unified platform, cross-domain, multi-module, the areas that I mentioned before. And in that schematic diagram, you would see that there are points of encounter at the healthcare or transactional level. And for that, you would pick up the data from those entry capture points, which the arrow leads to the top right. And those would be the traditional form of fragmented different entry points, because we do have surveillance platforms for several of the surveillance domains. But what we have done is that we have taken that and integrated through processing servers and the equilibrating platform to develop this actual dashboard. So it's a visualization dashboard that detects the alerts. And as I said, in terms of not only to detect, but there's a notification pathway where you can program the software to get email alerts, general reports, and then that goes to regional and national entities that should allow for the response to be appropriate and timely. This just shows it in another way from an IT-based perspective, health informatics, the data architecture and flow. You have a multi-source ingestion. So if we go to the top of the schematic diagram, all 26 CARPHA member states, they currently enter data through their national electronic systems or using some of CARPHA's system. We have done an analysis and several CARPHA systems are used nationally. What is done, therefore, is that there's a source data exchange. All the data is put in a data lake, and therefore you do have that extract, transform, and loading of the data house. That data house actually is pulling data from the limbs that are shown in the diagram from the different formerly siloed surveillance domains, and puts it all through towards the bottom of the grid into using our Shiny Pro platform. So with that, you do get the analytics on one dashboard. And then, of course, as I indicated before, any aberration detected by the software should certainly send off an alerts. And of course, we are also looking at building GIS-sensitive pinpointing of where we would have clusters or other aberrations. So as I said before, so our Shiny dashboard as a visualization tool that's been used innovatively has the cyber security or cyber resilient factors that allows for authentication, processing, and visualization. And all the analytical modules are seen within this one dashboard. So therefore, you can pick up cross-domain epidemiological signals. So for example, if you see fever and rash syndromically, you can look to lab to see if there are any upticks of any disease that has fever and rash as a syndrome, for example. I know this was shown earlier today, but this is a good schematic that was also presented in the paper. At the center is the R-Shiny Pro. You have TalkWalker, the infodemic. So from a real underground perspective, before you pick up any cases, you might actually pick up, it was said this morning, the population is ahead of the regulators. So you would pick up chatter on the social listening platform, which is where TalkWalker resides in our architecture. And you could actually pick up abnormalities or detections of something is going on, even before you pick up syndromic cases. Caribbean has a lot of imported risk. The tourism health was mentioned before. There's our cruise vessel surveillance system, as well as our tourism health system, where we have the tourism industry is also being monitored in terms of health risk. We have the lab, that's obvious, in terms of the role in the surveillance architecture. And then we have platformed the DHIS2 modules, which is a sub-innovation in of itself. The DHIS2 module from the University of Oslo as an open source software has been architected for national systems. We did have discussions, CARPHA, with the University of Oslo, and have been able to repurpose the DHIS2 open source platform to convert it to actually a regional data house tool. So therefore, we have done some tweaks, and therefore, we are able to design future modules on DHIS2 platforms, being very cognizant that a lot of the CARPHA member states have this in their national systems, which lends itself to interoperability. So that's the architecture that all allows for sooner detection, faster notification, acting together, and it's modular. So there's no need for any CARPHA member state to have to adopt all in order for it to work. And certainly for any CARPHA member states that uses one of those peripheral tools, you automatically can get the visualization platform. So if you use more than one, it is already readily available. Oops, sorry. I seem to have gone to the end. Okay, so integrated early warning outputs. These are just examples in terms of what has been designed. Top right-hand corner is the landing page from when you log in, and those shows on a tiled approach what the R-Shiny Pro platform looks like in terms of giving information. CARPHA would see stuff at a regional level, multi-country. This can be installed, it's already programmed to be installed for each country in their own data instance, and you own the data, and therefore you can certainly see at a subnational level for your particular CARPHA member state. And as I said, particularly for modules that you have from CARPHA, if even this is not from CARPHA, then there is aspects of interoperability at a level of epidemiological and IT collaboration. This is a reminder in terms of the regional impact of having such a tool, as I said before, particularly where you have potentially epidemic surges that you want to pick up in real time. And therefore, the transformational impact is that this innovation eliminates the traditional surveillance silos, enables multi-sector early warning and response and regional coordination, and is of a critical value for small island developing states in the context as described earlier. So in conclusion, this system delivers the integrated early warning system and response system, real-time decisional support, and the future directions of such an innovation is that it could be used more for predictive modeling, particularly for climate health is being worked on, automated risk scoring, and of course, expanded national customization. The entire system will be fully finished in June this year, and therefore we would engage CARPHA member states as per their needs allow to do a very detailed country mission visits. So I'd like to acknowledge at this time the Caribbean Public Health Agency, the Inter-American Development Bank, the Pandemic Fund, and of course my colleagues in the Project Execution Unit as well as CARPHA, and of course our Executive Director, Dr. Indar, who is the Project Director that has provided visioning to lead to this milestone. Thank you.
Thank you, Dr. Armour. We'll take 2 questions or interventions from the floor.
I have one. In regards to the syndromic data, which I asked about earlier, looking at your data lake and the construction, is it a pull system or a push system? And what I mean by that is this information automatically being fed into the data lake, or when you call up your dashboard, is it going out and pulling that information of how many gastroenteritis cases am I seeing today, kind of thing? Do you know which is occurring, particularly for those?
I would say it's a push system because the pre-existing entry into the syndromic software that remains. So that remains unchanged from the end user end, right? But the software allows the data when it's extracted into the lake to automatically analyze it. And therefore the system is customized. You can actually select by epi week or by year, and it automatically recalculates the data and indicates if there's an alert miss. So if even for a short period you're not seeing it, once you expand the period of analysis, it may show an emergent pattern. So therefore that can automatically be done, yeah.
How often is the data uploaded from health records and things like that into the data lake? Is it
Well, I have limits of,
approximately?
yeah, well, it's real time. So I actually have to depend on my biostatistician to answer, but I know he's presenting a paper as well, but it is real time. So as it is entered, it's repository. Yeah.
Perfect. That's great answer. Thank you.
Okay. Yes, we'll take one more question, please. No. There's a button. It's not working. But
apologies. Kunrak from UE. So I just wanted a comment on, so you have the data lake where all of the data is being stored. How is that being connected to the Our Shiny app? Is it through an API, or do you have to externally download the data and then have that be processed within the Our Shiny app?
Okay, so I would have to say I don't know, I'll be honest. But as I said, the biostatistician who has a related paper, I could recommend you pose a question back to him. In terms of my role and contribution is that of the health system architecture itself. I do believe it is an API that is connected, but that could be confirmed with Mr. Bagwandi when he presents.
thank you so much, Dr. Amour.
Good thing I have my disclaimer. Our next speaker is Mr. Brendan Bagwadine, speaking on CARPHA's aberration reporting system, a DHIS2-based web application for syndromic surveillance and timely detection of elevated signals. He's a biostatistician and lecturer in actuarial science at the Caribbean Public Health Agency and the University of the West Indies in St. The floor is yours.
Good afternoon, everyone. So effective disease surveillance is not only about collecting data, but about recognizing patterns and when they deviate from what is expected and doing this early enough to act. In the Caribbean, small island developing states, the epidemiological context is unique. Small populations mean that even subtle increases in cases could mean something significant. If you combine this with high mobility, climate-sensitive risks, and limited surge capacities, then delays in detection, they could quickly escalate into a regional threat. So this is where syndromic surveillance plays an important role. If we use the pre-diagnostic signals to identify potential outbreaks earlier than the laboratory confirmations. But the data that we have here is inherently noisy. So the key analytical challenge is being able to distinguish between true epidemiological signals from what would be considered normal variations. The traditional surveillance systems that we have, those are often very descriptive and retrospective. So what is needed is a shift, and that shift should be towards a real-time automated detection that would support coordinated regional response. CARPHA's regional integrated early warning surveillance and response system provides this framework. And as you would notice, syndromic surveillance is a core component. Our objective was straightforward: to develop something called CARPHA's Aberration Reporting System, or conveniently coined as CARS, and to develop it as a scalable and automated early warning analytical engine that would improve detection of elevated syndromic signals. It would reduce false positives and strengthen regional response across the 26 member states. The system that we designed is a DHIS2 integrated web application, which uses weekly syndromic data across 6 regionally important syndromes, including gastroenteritis, undifferentiated fever, fever and hemorrhagic symptoms, fever and neurological symptoms, fever and respiratory symptoms, and fever and rash, and 2 age groups, namely under 5 and over 5. Importantly, however, it was designed for the realities of the Caribbean small island developing states, accounting for variability in data quality, infrastructure limitations when it comes to digital health, and also that need that we have for standardized rapid analysis. So to ensure data integrity, all incoming cases would undergo validation checks, including range and consistency checks. And given the analytical challenges of the high variability and limited baselines, we developed a dual gate statistical framework that was tailored specifically for these environments. So firstly, short-term anomalies are detected using an adaptation of the CDC's early aberration reporting systems C1 to C3 methods. So C1 detects signals greater than 2 standard deviations above a 7-week mean. C2 adds a 2-week lag to C1, and C3 sums the positive deviations over 3 weeks. Then we used something called a locally estimated scatter plot smoothing regression to model expected trends and seasonality to confirm whether the signals that we have exceeded what would have been expected. So overall, the alert is only triggered only when both conditions are satisfied. And so that was to ensure stable specificity and also to reduce false positives. So in operation, users could input weekly case counts, and the system immediately applies the detection algorithms. It would generate the baselines, and it would flag any of the exceedances. So this would enable near real-time identification of potential public health threats. So when the dual gate condition is met, the system then generates alerts through visual indicators. It would log the event, and then it would also enable automated email notifications. So that would be to, of course, support rapid dissemination of the information to the various national and regional stakeholders for timely response. So for an interactive demo of CARS, you're welcome to join us at the Pandemic Fund booth. The system overall demonstrates strong performance in the Caribbean context with processing times under 5 seconds and a measurable reduction in the false positives from 6.2 to 5.2%. So this might be small, but it is practically significant because it directly reduces alert fatigue. It would conserve what we have here in the Caribbean as limited public health resources, and also to prevent that erosion of trust in the surveillance system. Because in public health, as we know, where surveillance would monitor large data sets containing these rare events, a high rate of false alarms could become overwhelming on the epidemiologists, on the analysts, and then this would lead them to, in some cases, legitimately ignore what would have been actionable alerts. So importantly as well, however, the system maintains high interpretability and it allows users to understand and of course trust the outputs. Overall, CARS operationalizes syndromic early warning by transforming the routine surveillance data into actionable data-driven insights. So it strengthens regional epidemic intelligence. It would support timely response and also contribute to improved public health security across the Caribbean. But like all systems, sorry about that. So like all systems, CARS remains dependent on data completeness, and some member states have limited historical baselines. So this would, of course, require ongoing calibration of the parameters that we would have used to calculate the baseline. So moving forward, enhancements would incorporate things like machine learning, algorithms, expanded predictive analytics, and of course, continuous refinement based on user feedback. So overall, this work it represents a regional collaboration and was only possible with the vision of CARPHA's Executive Director, Dr. Lisa Ingar's support and funding from the Pandemic Fund and the Inter-American Development Bank, and the technical expertise to make this concept into a functional system. So overall, CARS represents a regionally tailored approach to early warning designed to detect signals earlier, support coordinated response, and ultimately strengthen public health resilience across the Caribbean. Thank you.
All right, I can't see behind me, but questions?
It's fine. You can project. You can project your thoughts. In the interest of time.
Use your outside voice.
Right. Sure.
Hold on. Second, there is always a trade-off when you're trying to decrease false positivity rate, false negativity rate, and so on. So what was that all about? Second. And third, did you actually end up comparing with other algorithms before selecting these two algorithms? And how did that work?
Right. So this paper that we presented here is part of a larger paper which compares the various algorithms which would have ended up with us selecting this as the choice to develop into the application. So we compared it with 7 other aberration detection algorithms, and this combination that we came up with performed the best. So because with the syndromic data that would have been collected, there are no true, I use that term loosely, true events to have been recorded as outbreaks. We use that as a general baseline to simulate a data set in order to make the comparisons. So based on various scenarios, we saw that our algorithm would have came up with the largest reduction in false positives based on different spikes that we would have injected into data sets from 6.2 to 5.2%. What was the question? False negatives. I can't remember offhand what the values were, but we could always talk offline and I would relay those numbers with you.
Question. You're on.
Hi, thank you. Thank you. Really interesting presentation. I had another question about the aberration kind of calculation algorithm. In terms of, did you consider accounting for any kind of previous known outbreaks for those countries in that 7-week window that you said you took an average for? Is there any accounting for if there had been an outbreak and that had kind of given a wider range? And then the second question was where you've then seen alerts or triggers from this, has that typically been a single country, so helping their kind of public health detect what's going on, or have you seen any kind of multi-country triggers?
Okay, so to answer the first one, that's why we use a dual gate mechanism. So even if those short-term spikes would have been picked up, it still has to pass the second gate before it would overall be signaled as an alert. So the second gate, which uses the regression modeling, that would incorporate the seasonality. So if there's anything that deviates from what would have been expected, then it would pick it up in that gate. And could you repeat the second question?
Sure. The second question was kind of in your experience from looking at the alerts that come out of the system, are they typically kind of single country alerts, or have you seen triggers happening from the syndromic data across multiple countries?
Quite often it would be for single countries, but there have been epiweeks that reported multi-country outbreak. Well, I shouldn't say outbreaks, but events.
Thank you.
Thank you so much, Brendan.
Okay, thank you.
Okay, so at this time, we'll recall Dr. Brian R. Moore, who will speak to us on Fiction to Function, CARPHA's novel Caribbean-tailored Republic of Tingui Emergency Preparedness and Outbreak Response Simulation Exercise. And as we know from before, Dr. R. Moore is affiliated with CARPHA, and he will deliver oral presentation 04. Dr. R. Moore.
Thank you very much again, Chair, and thanks again. Want to again recognize the collaborative authorship within CARPHA departments, and particularly those of Pandemic Fund, and particularly in this presentation, our infodemic management consultant, Ms. Elizabeth Wilhelm, who we all collaborated co-authorship with. So I'd like to present on behalf of CARPHA based on the paper presented. So in this context, the Caribbean region faces complex multi-hazard public health threats, including climate shocks, as well as outbreaks due to porous borders. So preparedness requires testing systems in this unique Caribbean context, not just mere plans or tabletop exercises, and using systems that are not necessarily designed for small island developing states. So simulation exercises, as is known more generically, is a core global standard that is enshrined in the International Health Regulations 2005 as a tool to assist in dealing with pandemic prevention, preparedness, and response. However, most of these SIMEXs, as is known, are not regionally contextualized. So therefore, we do need, even in this context, a tailored Caribbean-specific emergency and outbreak response simulation approach. So in this paper that was submitted, we are introducing the Republic of Tingui in this context, which was designed within CARPHA, and particularly with the input support from the Pandemic Fund. So Tingui is actually a fully fictional Caribbean country with familiar epidemiology, governance, and health system profile that fits small island developing states context. In this scenario, outbreaks, emergencies, and other public health events occur for participants deployed as CARPHA responders must help address. So the design principles is one of adult learning, which is learning by doing, cross-disciplinary collaboration that is required in this simulation environment, and is a safe space for experimentation. In other words, it's safe to fail in a simulated environment for the purpose of learning. So in the Tingui simulation as designed by CARPHA, we actually do use realistic data sets to simulate. We actually do injects of media and reports, and therefore it is in a time pressure with sometimes incomplete information. And I would pause here to state, as has been stated before, is that this sort of innovative adult learning simulation exercise, Caribbean tailored, allows us, for CARPHA is advocating for with the timeliness metrics, because This is one where we detect and notify, and we saw earlier in another presentation with the featured speakers, the action times. So therefore, undergoing these simulation exercises in a Caribbean context would mean that when an actual emergency arises, the lessons learned here can actually shorten your action window period for a more effective response. So in terms of methods and implementation and the preparation and design, discrete learning objectives need to be clarified based on the audience. The scenarios intricately built using different types of outbreaks that are in a Caribbean context, whether it be vector-borne, climate-related, and so forth. And of course, to develop the tasks and inject timelines in which to respond. During the simulation, we generally have it in terms of multidisciplinary teams of 6 to 8 participants. Real-time communication is very much an enhanced feature, which starts to lend with respect to infodemic environment that you tend to get during an emergency. So you do get a lot of information in real life, and this is simulated in the design. And of course, there are the lead facilitators and coaches to guide the process. So therefore, tasks in this sort of infodemic, both community-based and epidemiological-based, there's need during the simulations for data interpretation, performing quickly a risk assessments, activation and staffing of the Emergency Operations Center is a task, as well as evaluating all the communication outputs and the policies and decisions that would assail the participants in the simulated environment, but mimicking what happens in the Caribbean context. These are just some examples. We started off at Tingwa 1.0 in Jamaica last year, July 2025. And this just shows some of the exercises that would have taken place. As you will see, we do some level of AI as well in this, and therefore we do have Pineapple happens to be the mascot of this country as well. So we arranged that initial inaugural workshop across teams, coaches, several assignments. It was based on a hurricane-based scenario, and therefore we also have to deal with psychological support as part of the design. We had data that came from lab investigation forms. There were early warning alerts on persons' WhatsApps, and therefore there were issues of confounders like measles cases. We had the political dimension as well as the timeliness metrics where in real life you're still under pressure deadlines to manage information that the population requires, as well as the principal officers and decision makers at a national level. So all that occurred in the simulation. Right. This just shows more types of the scenarios that have been used in such a simulation tool that have been all generated as part of the CARPHA innovative tool. We actually created social media posts, created newspaper articles, actually had video demo alerts as well as we even have playing cards for potential EOC deployers as well. So therefore, all these modalities come to bear within a pretty compressed time frame with respect to the Tingwa simulation exercises, which is well beyond a typical simple desktop planning exercise. Results and outcomes of this Tingwa approach: we trained over 120 participants, including 16 CARPHA staff. High participant satisfaction based on the monitoring and evaluation of this methodology, and collectively across the several iterations, it's been across 21 member states. We've had Tingwa 1, 2, and 3.0 versions, and the last version, which was the third version, which was the One Health workshop in November 2025 in Trinidad, brought a relevant scenario that involved the One Health principles. The qualitative improvements, communication and teamwork is normally part of the debrief, analyzing team and individual critical thinking, and of course, application of the surveillance tools. And as we have said in other papers, as we mature the surveillance tools, we'll be embedding that into the scenario as well. So what are the implications and future directions given this innovative adult learning simulation tool that's tailored to the Caribbean context? The Tingwa simulation exercise is to be further used in CARPHA's emergency and response program framework at a regional level. And recently too, in March, CARPHA would have partnered with the GOAN network that really brought a global dimension to simulation exercise planning that involved a lot of multilateral agencies and the lessons learned there. So not only participants were trained across CARPHA member states, but also several of CARPHA staff were selected as junior facilitators. We plan to further enhance the innovation of Tingwa to infuse the simulation scenarios. So the lessons learned for strengthening future CIMEXs, clearer participant briefings was some of the constructive feedback, strong facilitator preparation, improving multilingual accessibility, particularly in our Caribbean dynamic, expanding cross-departmental involvement, and as I said before, applying the GOAN recent learnings as well. So Tingwa can be scaled to new public health audiences and also involve new topics. Those are the list of some of the topics that could be expanded on in the Tingwa scenario as well. This just gives you references and acknowledgements. And again, I would like to acknowledge again the executive management leadership led by Dr. Indar for visioning of all this on a pandemic fund, my colleagues, Inter-American Development Bank and Pandemic Fund, amongst others. So thank you all very much.
Thank you very much, Dr. Amour. We'll take interventions from the floor. All right. Dr. Amour, thanks so much.
Thank you.
All right, our next speaker, Mr. Keston Daniel. Okay. And he was speaking about the setting appropriate syndromic surveillance alert thresholds for mass gathering events in small island developing states in the Caribbean. And another CARPHA presentation. And you're from Trinidad and Tobago, correct?
Yes.
All right, the floor is yours, and thank you very much.
Okay. Thanks, Teachers. Good afternoon, everyone. So I'll be presenting, it kind of follows what my fellow colleagues from CARPHA have been presenting in a little more specific way as we are looking at a specific area of surveillance that we conducted for Cricket World Cup and beyond. So it's with regards to setting appropriate thresholds for our small island developing states as we see that is important for early warning and response. So as I mentioned, we would have created a system for mass gathering surveillance because of the need of Cricket World Cup. And subsequent to that, countries would have seen the value of utilizing that system for many other Caribbean mass gathering type events, such as additional cricket games being played. CPL, as we know, is a big thing in our Caribbean region. Carnivals, we have carnivals in mostly every month in one of our Caribbean islands. We have regattas, food and music festivals, a host of these large large events that bring together local and foreign visitors to our islands that can bring in infectious illnesses when we mingle amongst ourselves. And that, as I was mentioned, these events because of that high mobility, the way a lot of people are congregating together, high risk of disease spread. So we needed to know how we can ensure that we have some sort of early warning system that we can identify at the shortest point in time, some sort of public health threat that we can respond to adequately before that explodes into anything of significance. So with that, we did some research, we did some trials, and we came up with a system because of our uniqueness in our small island developing states, our interconnected borders, particularly our limited health infrastructure. A mass gathering event in the United States, for example, a basketball game, they may not see that as a mass gathering event because of their size, their sheer ability to deal with such a crowd of people in the event that something happens. But in our small island developing states where infrastructure is limited, our capacity is small, a few cases may cause burden to our health system. So we needed to have such a system to protect our region. Delays in supplies, underdeveloped digital health information system, which this system that we developed clearly targeted and is developed to help with electronic surveillance. The need for early warning systems, it was based upon syndromic surveillance. So we would have heard a bit about syndromic surveillance in previous presentations, and it follows the same format and modality. Looking at symptoms and getting an idea, pre-diagnostic wise, what are the issues that may be occurring that we have to treat with immediately. So the role of thresholds in the system is based on generation of alerts. And the systems that we have interconnect various stakeholders in the chain, from the persons on site collecting data, the mass gathering, to the Ministry of Health National Surveillance team that will be monitoring the country, and even CARPHA, where we can have that regional perspective and get that information. So understanding what thresholds to be used is important, because we don't want to overburden the systems, as I mentioned, with the resource limitation. Having persons going out for any and everything would severely stress those persons involved in the process. So we want to ensure that where there is a real alert, that the resources are sent to treat with that in that point in time. So the objectives of the study was to determine the key parameters we will be considering for syndromic surveillance, and to show how the selected thresholds that we would have adopted worked for the 2024 T20 World Cup and still applicable at this point in time, and identify data gaps currently in the Caribbean and the need for continued data collection in order to inform the system as we go forward. The methodology we used, utilizing the same symptoms and syndrome diagram that you're seeing there, collecting symptoms to indicate what are the 6 syndromes that we are looking at. That was applied for this paper as well. And, And we also came up with a list of thresholds based on that research that we would have trialed at that point in time. Again, taking into consideration the need not to overburden the resources, as well as ensure that we capture the relevant cases that we need to avoid the spread of illness in the event that it occurs. So what we came up with is 5 elements or parameters. At this time, it's not an exhaustive list, but the research that we came up with pointed to these 5 elements. Global evidence, very importantly, that links to our visitor population that comes to our Caribbean region, and what is happening out there tends to impact the Caribbean, as we know. So we needed to know what is happening outside of the region to inform that decision. We also look at the local content or the local demographic, socio-demographic picture of the country, the high tourism dependence, for example, connection through air and sea transport, as some countries have a large cruise vessel tourism sector, the health infrastructure, as I mentioned, and the economic strength of the country to have the resources to deal with such an influx of illness. Thirdly, and very importantly, is the type of event. We need to take that into consideration. In the circumstance of cricket, it was outdoor events, but the risk of disease spread varies from indoor to outdoor. The infrastructure that those events would have been taking place in, the types of participants and their age groups, for example, old people as opposed to children or mixed, the behaviors of people, if they're alcohol drinking, if they're allowed shouting, singing, for example, as opposed to possibly a conference where we wouldn't have all of that type of behavior. We also take into context the local disease profile, very importantly, as we know there are endemic diseases in our region and our country, so we also needed to do our due diligence there in order to understand, because visitors will also be coming to our region for many of these events, as well as take into consideration any local related data to mass gathering events, which is the major gap, and we didn't have much of that to work with during that time. So the results, what it shows is that the threshold sensitivity was not too high to overburden the health teams. The single case of a potential threat was identified quite quickly, as we had 2 alerts during these events. So in a game of about 50 games during the World Cup, 2 alerts we were able to get and treat with them quite quickly. No outbreaks were detected or reported during that period. It also provides, very importantly, as point 5 would have said, some sort of baseline data for us to work with going forward in the future to reassess in our case, and to determine if there's a need for revision of these parameters, and facilitated the adoption of surveillance across Caribbean and for other mass gathering events as well. So in conclusion, our CARPHA Caribbean tailored mass gathering surveillance system successfully protected our small island developing states. It didn't overburden our systems, our health practitioners who were working during the event. And it was a system where we could have easily replicated and utilized it going forward, following the Cricket World Cup to other types of mass gathering events. So that worked well moving forward. It provided scientific and replicable models for mass gathering events in the Caribbean, and it highlights the importance of data for early warning and response, very importantly in public health settings, as this is the first stage pre-diagnostic where we want to ensure that we can detect and treat with public health threats at the earliest point in time. So with respect to future studies, and we understand that this is evolving, and we would, by collecting additional data, we will be able to refine and address any changes in the environment that will occur. So we want to ensure that there is some sort of ongoing data collection, expansion, reviewing of the parameters based on this data and information we would have collected through adoption of the system throughout the region, and exploring establishing possibly weights and measures to these parameters, as all of them may not have the equivalent measurements across the different areas, because some may be more important for certain events or certain countries as we go forward. Again, as a team, we would like to make the acknowledgements as well to Dr. Indar for her guidance in this paper as well. Very importantly, Mr. Mohamed El-Shibini as a key person with respect to designing and writing this paper, and Dr. Kisundan as well as the Tourism and Health Program team, Pandemic Fund team, and member states who have participated during these mass gathering events. Thank you very much.
Questions?
Can you hear me? Okay.
Yes.
I actually have two questions. So first of all, like, I just want to figure out, like, who would be the receiver for the kind of like automatic emails? Would that be facilities or like the country? And secondly, I just out of curiosity, like, what kind of like tools are used for the automatic emails for the platform, for the Shiny dashboard to set up this kind of like workflow? Yeah.
To your first question, the system is set up in such a way where both facility and ministry also gets emailed concurrently. So that alert is shared at the same time with both parties for that early notification that there's some sort of illness or some sort of event happening. Your second question, you mentioned something about R Shiny.
No, like I was going to ask earlier, like you mentioned, it should be sent through the automatic email, right?
Yeah.
So like what kind of like tool you use or like platform you use to sending the workflow of these kind of like automatic emails through the dashboard? Yeah.
Yeah. Our system is built upon a couple of things. And forgive me, I'm not the developer. It's just the so I can get that specific information for you, but I don't have it at this point in time, so we can chat after.
Okay, no problem. Thank you.
Other questions? Very good. Thank you very much.
Okay, so we'll call on Ms. Tamara Bernard, who is the Foodborne Disease and Zoonosis Coordinator at CARPHA, and she'll be speaking to innovative expansion of CARPHA's Regional One Health Foodborne and Zoonotic Diseases Program, which corresponds to oral presentation 06. Over to you, Tamara.
Thanks. All right, good afternoon, everyone. My name is Tamara Bernard. I am the Foodborne and Zoonotic Disease or One Health Coordinator at CARPHA underneath the Pandemic Fund Project. Today I'll be speaking about our innovative expansion of our foodborne and zoonotic disease program. So foodborne and zoonotic diseases remain a major global and regional public health challenge. Thank you for the audio. Globally, there are about 600 million cases and 420,000 deaths annually, and over 60% are emerging diseases are zoonotic. So in the Caribbean, foodborne diseases are significantly underreported, but they still affect a large proportion of our population. Given this, CARPHA is mandated and has supported regional surveillance and outbreak response since 2003 underneath CARIC, and since 2004 we've expanded underneath CARPHA to a fully integrated One Health program. So again, in the Caribbean, the burden is much higher than reported. So only about 10 to 15% of foodborne diseases are captured by our surveillance systems. And so approximately 1 in 49 persons experience foodborne illnesses annually, with nearly half being children under the age of 5. This results in an estimated economic burden of about $21 million per year. And some of the key pathogens that we surveil and test for notably include Noro, Salmonella, E. coli, Campylobacter, Giardia, and so on. So since the launch of CARPHA's Pandemic Fund project in 2024, CARPHA has significantly strengthened regional systems. So we've expanded integrated surveillance across over 15 member states. We've enhanced laboratory capacity and improved outbreak detection and response. We've also convened One Health workshops. We've developed regional action plans, updated national action plans, and introduced the region's first international and regional agency early warning system, which digitally coordinates platforms onto a SharePoint site. And additionally, we've deployed molecular diagnostics, supported emergency response, and advanced early warning systems to improve detection and response. So with the expansion of our program, we've expanded into that One Health approach. So before it was famously known as the One Health approach, we've had our integrated systems, but now we're more officially recognizing the link between human, animal, and environmental health. So this is critical for identifying sources of diseases and implementing effective prevention and control measures. So however, there comes challenges, of course. So that's fragmented systems, limited data sharing and interoperability, sectoral silos, and of course, underreporting. So for small tourism-dependent states, delayed detection and response can quickly lead to major public health and economic consequences. So it's extremely important that we're able to surveil from the source. So that farm-to-fork approach is extremely valuable. So to address these challenges, CARPHA has introduced several key innovations under our new suite of Caribbean tailored tools that we're launching underneath our regional integrated early warning surveillance system. We've developed a One Health DHIS2-based surveillance module to integrate multi-sectoral data with automated alerts and dashboards, which a few of my colleagues have already spoke to at length. And we've established a One Health multi-sectoral steering committee and created tools like a collaboration matrix and that SharePoint platform to improve coordination. We've also aligned national action plans across member states to standardize that implementation. So the objective of this work was to evaluate the early implementation of the expanded program, but more specifically, we assessed how well multi-sectoral surveillance systems, governance structures, and coordinated mechanisms are integrated and examine the early outputs and uptake across member states. We conducted a mixed method implementation evaluation with data collected from 2019 to 2025, including national action plans, regional workshops, stakeholder discussions and polling, digital surveillance outputs, and outbreak simulation exercise, also known as our TINGWA exercise. So this is a bit more on our SharePoint platform. So one of our key results was that development of this regional platform. It houses about 20 international and regional agencies right now. It serves as a centralized hub for collaboration, document sharing, coordination across agencies, a shared calendar, and it supports real-time information exchange and helps reduce duplication of efforts across the region. Here's a bit more on our One Health module that we developed in DHIS2. It enables standardized data collection across human, animal, environmental, and laboratory sectors, and it supports that integrated surveillance and feeds into the broader early warning system, improving real-time visibility of public health threats. Next is our next key result is our national action plan. So about 14 member states now have updated their national action plans to be aligned with our regional action plan. So these support standardized workflows, stronger national implementation. And so this has been critical for ensuring that sustainability and that country level ownership, as we had national epidemiologists, environmental health officers, chief veterinary officers, lab directors, all come together at one table to agree on a way forward for this newly popularized One Health approach. These results demonstrate that One Health can be operationalized through integrated digital systems and coordinated collaboration and communication. So we're linking governance structures and frameworks directly into surveillance systems and trainings. And so this enables earlier detection and faster coordinated responses. So overall, this strengthens regional health security and preparedness. So conclusions and next steps, my last slide. We've established an integrated foodborne disease and zoonoses One Health surveillance framework. And so this provides a scalable model for small island settings. And so some of our next steps include piloting our DHIS One Health module and implementing routine integrated reporting and strengthening national level implementation. And finally, I'd like to acknowledge CARPHA's Office of the Executive Director, Dr. Lisa Indar, Pandemic Fund Project, CARPHA and our member states, regional and international partners, and our funding support from the Pandemic Fund and IDB. Thank you.
Thank you very much, Tamara. We take questions, comments on the floor. Thank you so much, Tamara.
All right, our penultimate speaker, Dr. Gabriel Gonzalez Escobar, speaking on expanding laboratory capacity in the Caribbean, a hub and network model for One Health and AMR surveillance. He's the Assistant Director for Surveillance Disease Prevention and Control at CARPHA.
Thank you very much, Chair. Good afternoon, everyone. So we are going to speak about expanding laboratory capacity in the Caribbean. What is our hub and network model for One Health and antimicrobial resistance surveillance? So for those who are not aware of the context, CARPHA's context in terms of the laboratory, we operate 3 different laboratories in the region. One is our Central Clinical or Medical Microbiology Laboratory in Trinidad and Tobago, CMML, which is basically a clinical laboratory. The second one is the Environmental Health and Sustainable Development Department in St. Lucia, which is an environmental laboratory. And the third one is in Jamaica, our Medicine Quality Control and Surveillance Department in Kingston, Jamaica. So we do the surveillance of medicines in that laboratory. So far, these 3 different areas have been separated and have been working, serving the 26 member states. So this, of course, is not really out of many challenges, especially regarding infectious diseases and antimicrobial resistance and communicable diseases in general. So we have different challenges, and for that we plan to start the model of the 3 hubs and network system in the region. Sorry. So why laboratory innovation is critical for the Caribbean health security? First of all, we have different challenges in diagnostics in the region. The geographic dispersion, 26 member states, most of them small island development states. Then you have urgency to combat some different problems, some of them of a very serious characteristics right now, like the problem of antimicrobial resistance, which is now called the new pandemic or the hidden pandemic. Then we have the need for a more robust surveillance in terms of the One Health setting. And of course, we need to have the approach of our regional coordination. So for that, we, apart from our central laboratory in Trinidad, we developed this system for the other two laboratories, the one in St. Lucia and the other one in Jamaica, to have an extension or a branch of the CARPHA Medical Microbiology Laboratory located in Trinidad. So this laboratory is expanding, and in fact, the first of these branches, of these two branches, was inaugurated last month in March, which is in St. Lucia, and the other one is going to start servicing the northern Western Caribbean next month. So we have these three regional referral hubs. We are decentralizing not only the antimicrobial resistance diagnostics in Trinidad, from Trinidad to the other countries, but also we are going to have other platforms like closed PCR platforms, open PCR platforms, and perhaps in the future we could also offer other alternatives. So what is this advanced microbiology and MMR diagnostics across the network? So we are offering actually in these three hubs state-of-the-art technology like mass spectrometry, standardized antimicrobial testing in the three campuses, whole genome sequencing for now centralized in Trinidad, but we are able to receive samples from the 26 member states, and quality management integration. Of course, another very important point of this strategy is the integration of the human, animal, food, and environmental testing. For that, CARPHA has a lot of experience due to the fact that we had an environmental lab in St. Lucia, but we are trying to promote a more integrated approach using the One Health strategy, but also expanding to laboratory veterinary services. We are in conversations with both public and private sectors in the veterinary setting. And environmental and food testing, we want to start we will start our surveillance system for wastewater, including metagenomics and genomic sequencing, and antimicrobial resistance detection, or bacteriology and antimicrobial resistance detection in these samples. So we are transitioning from a centralized approach to a more dynamic and decentralized one, from fragmented reporting to a consolidated and harmonized reporting. So now we have our laboratory information management system across the three campuses in Trinidad, St. Lucia, and Jamaica. This Senate, which is the name of our LIMS, is not only available for antimicrobial resistance and infectious disease investigation, but also for environmental investigation and medicine quality and control investigations. So another very important point of this approach is how we fight against the barriers through the innovation related to transport pathways. And I have to say that since 2020, thanks to the regional security system, the RSS, we were able to receive more than 60,000 specimens at CARPHA. And apart from this, we are training more and more people related to IATA regulations. CARPHA just signed an agreement with Caribbean Airlines for the transportations at a very competitive price for Category B substances from the 10 different destinations in the Caribbean to Trinidad, St. Lucia, and also to Jamaica. And of course, we are always working in minimize the impact of other logistics and things related to customs and other issues across the region. So just to show you, and this figure was showed by Dr. Inda this morning, this is the decentralized model with the 3 campuses. And for instance, the campus in Jamaica will be offering services to Bahamas, Belize, Cayman Islands, Jamaica, and Turks and Caicos, and so on and so forth. You can see for the other 2 groups which countries will be served by each of the campuses. Also, Trinidad and Tobago will continue to be the reference lab, the central reference lab for all 26 CARPHA member states. So through this model, we are trying to ensure quality, consistency, and regional ownership through the improvement or the enhancement of the governance and coordination, the regional surveillance collaboration, and establishing strategic partnerships between CARPHA and other public and private institutions. We have expanded our testing capacity during the last 2 years. The CARPHA Medical Microbiology Laboratory has conducted more than 55,000 tests from all member states. We have improved our turnaround times, and the aim by the end of this year will be to have 80% of all our tests within our scope to be done within the first 72 hours. So it's no longer an alternative for CARPHA to have long turnaround times of 7, 10 days, 14 days. This is something that is now under review, and we will be pleased to announce that this fact is going to be a reality by the end of the year. But of course, we have enhanced our preparedness and readiness to different public health events in the region. So this is a model that we think is very scalable and is very suitable for small island states because it's based on a strategic regional cooperation, compliance with health security and international regulations, and also is sustainable and provides resilience to our 26 member states. So the key take-home messages and our future priorities will be to continue with this hub and network model, which has demonstrated, or from our point of view, is the model that we have to follow from now on. Advanced technologies integration, continue with the state of the art, and of course, with the support of our external partners like UKHSA, Pandemic Fund, et cetera, we have to establish future priorities in terms of what is going to be the services offered by our campus in Trinidad and the other 2 campuses in St. Lucia and Jamaica, and one is going to be transferred to member states. Of course, member states will also continue receiving the support from CMML and CARPHA. And this, of course, will have a very positive impact in the way on how CARPHA faces the regional health security within the region. And with that, muchas gracias. Thank you very much.
Questions?
Thank you. Thanks so much, Dr. Escobar. I'm happy that you're addressing the challenges with movement of samples across the region. But my specific question is on wastewater surveillance. What is its use? And I believe if the information gets into the wrong hands, it can cause panic with respect to public anxiety. So tell us the usefulness of wastewater surveillance from a public health perspective. Thank you.
Thank you very much, Dr. George. Very important questions. First of all, the approach will be always coordinated with the public health authorities of the region, of the countries. And the initial draft that we have plans to start doing surveillance in sanitary facilities like hospitals and so on and so forth. So it's nothing that is going to be out of the knowledge of the local public health authorities in countries.
Looking around for any more questions. Thank you very much.
Thank you.
All right, so this has been excellent. We've managed to gain some time in the session. We have one more presentations. So we'll wrap up with oral presentation 08, and this will be delivered by Mr. Mohammed El Shabidi, who is Senior Technical Advisor at the Caribbean Public Health Agency. Mohammed carries several portfolios, that's why. And he'll be speaking to establishing regional antimicrobial resistance surveillance in the Caribbean, supported by Caribbean Antimicrobial Resistance Alliance.
Thank you, Chair. Thanks, Dr. Cox. Can you hear? Yeah. Afternoon, everyone. I think the most humane way is to try to finish this as soon as possible, so everybody can get a break from this very hot room for some reason. But my name is Mohammed Shirbini. I'm a Senior Technical Advisor at the Office of the Executive Director. Sorry? Oh. Yeah, this is not my slides. I think we got the wrong slides there. Do you want to swap? Yeah, might as well.
Yeah. All right, so this is an icebreaker. Yeah. We'll just try to get some clarity in a few.
It's not 21. Session 21. Sure. Well, then I'll pass you to Natalie.
That was seamless, Mohammed.
Very seamless.
Yeah, I will also try to be brief in this presentation. So thank you very much for having me. My name is not Mohammed El Shabini, it's Natalie Wright, and I am head of the UK Overseas Territories Programme at the UK Health Security Agency. And I'm here to talk to you about establishing the CARPHA integrated AMR programme and the importance of regional partnership in making that a success. So I'm sure plenty of you in the room are familiar with the global burden of AMR and the importance of addressing it as a public health emergency worldwide. But what I wanted to do is start by just taking you through a few key findings from the GLASS report from 2025, because I think they're particularly pertinent to the region. Firstly, and the GLASS report, for those that you don't know, is the WHO's Global AMR Surveillance System report. So firstly, there is wide variation on AMR globally. Secondly, it found that settings with lower AMR surveillance coverage report higher levels of AMR. And thirdly, antibiotic resistance disproportionately affects low and middle income countries and countries with fragile health systems. And you can see, sorry, I should click on so quickly, from this figure is taken directly from the report itself, and it shows the inversely proportionate relationship between AMR and universal health coverage, which I think is used as a proxy for the strength of a health system. So those, as I said, those 3 points I think are particularly pertinent to the region. So the third one there was all about the kind of AMR being disproportionately problematic for low middle income countries and fragile health systems. And I think, you know, given the structural vulnerabilities within the Caribbean, I would put a lot of Caribbean nations firmly within that category. Lots of countries simply do not have the population size to have significant laboratory capacities to be able to test properly for, or as extensively as we would like for AMR. Poor purchasing power, again, just associated with size. Constrained in-country health system capacity with limited or absent tertiary care services, and constraints around the workforce. On surveillance, on the right-hand side of that slide, you can see a modelled estimate for the attributable deaths to AMR in the region. That's somewhere, it's a wide interval between 8 and 34,000 people. And the reason I've got a modelled estimate there is because there is just so little data actually out there in terms of prevalence. So we've got two of those factors already, fragile and health systems and a lack of surveillance. On top of that, which other presenters have talked about, the Caribbean is particularly interconnected, porous borders with high population mobility, and interconnected food, trade and healthcare systems. So I am not picking on the Cayman Islands for any particular reason. This is a health city in the Cayman Islands, which by all accounts, is an excellent hospital with high levels of care, both in terms of quality and the services that they offer. And it's got nice palm trees out the front, which is appealing. I think, but the reason I put it there is because publicly available on its website, the Health City has medical referrals from over 70 countries. It serves the Caribbean, North America, and Latin America. It has a major strategic partnership with the Bahamas to coordinate complex off-island medical cases. In TCI, patients are referred through the Treatment Abroad program. Referrals are regularly taken from Anguilla, BVI, Jamaica, and I'm sure plenty of others. So, so you can see how, what's happening in Health City, Cayman Islands, and I'm sure in terms of AMR, it's well managed, but whatever is going on there is really going to have the potential for spread across the region, which highlights the importance then of having a regional approach to tackling antimicrobial resistance. CARPHA is obviously the mandated agency to do that and is best placed to really take on that challenge. So CARPHA's integrated AMR program has 4 key objectives, which you can see down the right-hand side of the slide. So establishing a regional integrated human, environmental, and animal AMR surveillance system in coordination with partners, strengthening laboratory capacity, promoting responsible antimicrobial use and stewardship, and fostering a One Health collaboration and coordination approach. That program is strategically led and led in every sense by CARPHA, but funding and partnership are really critical for implementation, particularly having the resource required to kind of catalyze making meaningful steps forward in a short space of time. And important partners from that perspective are the Pandemic Fund, who I know have invested upwards of $300,000 in lots of capacity strengthening activities. And then the project that I'm here to talk to you about today and will do for the rest of the presentation, which is the CARPHA UKHSA Fleming-funded program to support AMR in the region. So just a little bit of background on the Fleming Fund. It actually doesn't exist anymore, but it was a large UK-based fund to support tackling AMR throughout the world, particularly in low and middle income countries. And over the last couple of years, it's had a program of work in the Caribbean, which comprises of 3 key projects. So first is the CARA project, which is the CARPHA UKHSA project, and that's all about kind of working at the regional level to tackle AMR. Secondly, a project led by PAHO, working at the member state level to strengthen national laboratory infrastructure and developing technical AMR capacity for diagnosis, surveillance, and response. And then thirdly, a research project essentially to improve understanding the existence of One Health landscape of AMR and to improve the evidence base for AMR research. And that is led by an organization called ICARS, which stands for the International Center for AMR Solutions. And you can see there on the right-hand side, the countries highlighted in red are those that are ODA eligible, and the Fleming Fund is restricted as it's an aid fund. So the CMSs that PAHO would be working in would be those ones there. So again, going back to that point about interconnectedness of health, it would be limited probably just to focus on those individual countries. You really need something at the regional level to pick up that interconnectedness, which is what the regional program is about. So CARA stands for Caribbean AMR Alliance. It's a technical collaboration between our 2 agencies. And we have 3 key objectives as part of this. The first is to strengthen the AMR reference laboratories at CARPHA and the laboratory in Montserrat, which is a UK overseas territory, which is ODA eligible. Second, to strengthen integrated AMR surveillance at CARPHA and in the Caribbean region. And thirdly, to support CARPHA in collaboration with regional partners to strengthen tackling AMR and improving AMS in member states. We've invested £5.7 million, so around $7.7 million US over 2.5 years, and the project's going to run until March 2027. And the photo here is taken from the launch in May in 2025, which had really good political buy-in and visibility throughout the region. So what did we do? Well, we started off with a rapid needs assessment. We did one on the laboratory side with site visits to understand testing capabilities, space, human resource requirements for AMR testing at CARPHA's laboratories in Trinidad, Jamaica, and St. Lucia. And on the surveillance side and workforce side, we undertook a learning needs assessment to identify training needs really and workforce needs in every other aspect and how best to do the capacity aspect of the project, the capacity building aspect of the project. The project kind of had two key work streams to it in that sense. So we had a capital investment tranche, which was phase one, and then secondly, some capacity building activities. So I'll kick off with the capital investment because that largely took the form of procuring equipment for laboratories to strengthen AMR, phenotypic detection and molecular detection. And it also kind of coincided with a fundamental strategic shift in CARPHA's approach to providing laboratory services, recognizing the fact that having a single laboratory in Trinidad for certain types of testing, because I'm aware that St. Lucia and Jamaica obviously already there is environmental and medicines quality. But actually there were significant challenges in terms of getting samples to Trinidad for some countries. So the idea was to use the sites in Jamaica and St. Lucia to really try to expand the options available and to improve access for certain countries. So you can see from the map there which laboratory certain regions of the Caribbean were targeted at. So we hoped setting up laboratories across all three would improve access. In terms of capacity building, this is really all about kind of UKHSA providing technical expertise into CARPHA, which is obviously leading its own service. So components of that were to increase the workforce itself, to conduct on-site training, to offer up exchanges to the UK regional and national reference labs at UKHSA in London and around the country. We supported in the design and development of surveillance outputs at the regional level, and really importantly, we collaborated with PAHO and other partners in the region in their constituent programs, which were part of the overarching project from the Fleming Fund. There's a lot going on with the slides down here. Okay, so in terms of results, well, it's been an extremely busy 18 months. So after just 18 months, the equipment is in situ. In all three of the laboratories, the staff are in position and trained. We've hired at least 4 full-time equivalent staff, and they have all undergone individualized kind of training to upskill where necessary or not where not necessary, because several of them have come with significant skills already. The lab is now launched in St. Lucia, and the laboratory is about to launch in Jamaica, which, as I said, will improve access and faster turnaround times for testing. We have an epidemiologist in post at CARPHA with initial surveillance outputs already under review. The field epidemiology and laboratory training program has delivered a healthcare associated infections and AMR module pilot to CARPHA member states. CARPHA delivered its first AMR molecular training workshops with reps from 17 CMS, CARPHA member states and 2 CARPHA campuses. The profile of AMR as a regional priority is elevated somewhat, although it was always important. And importantly, relationships have been strengthened, and that strengthening goes beyond just tackling AMR. But so what? Because all of that is really important and represents significant achievements, but at the end of the day, what does it really do to reduce the burden of AMR and the lives lost and the significant economic burden of it? Well, at least 2 outbreaks of multi-drug resistant organisms have been detected on ICUs in CMSs using the reference services, and hopefully those countries will write up their findings and share them in due course in forums such as these. And we've seen isolate referral to CARPHA improve from ad hoc submissions to regular contributions from 7 CARPHA member states, which is a significant improvement given the short time frame under which we're working. But I think it's really important not to lose sight of the fact that at the end of the day, we need to focus on improving health outcomes, improving patient treatment, improved clinical guidelines, and having action informed by good quality surveillance information. And, you know, and that's where those 3 projects come together to deliver collectively, because one by itself is just not gonna get us to that point. There have been challenges. The first, yeah, the slideshow itself. Getting back to that. So logistics and cost remain a barrier to sample transfer. The 3 laboratories makes a big difference, but it hasn't solved all of the issues, to be honest with you. And you can't underestimate the cost itself being a problem. Routine data sharing is still not established. And that's partly because the data itself isn't generated. So that is going to take a little bit more time, but hopefully we'll have gains that go beyond AMR in terms of having regional level surveillance data across the board. And obviously the geopolitical landscape and funding cuts to aid, you know, this comes at a really poor time in that sense. I mean, we've been able to deliver. Part of the reason we've been working so quickly is just to do as much as we can while the funding is still there. But I think we all know that down the line, the future looks like there'll be less cash to go around. In conclusion then, partnership was absolutely crucial to the rapid mobilization of CARPHA's integrated AMR program, and the outputs are demonstrable, both in terms of just the sheer volume of activity that we've done, but also, like I said, those outbreaks that have been detected. Critical components to success have been aligned global financing. So if those things hadn't come together under CARPHA's leadership, it would have been much harder to get where we have in such a short space of time. The strategic technical partnership that we have with clearly defined roles, CARPHA's leadership, and then importantly, trust between partners, because with that amount of work, there have obviously been times when things have been tricky, and having such a good relationship underpinning it has been really key to success. And then moving forward, we've got a delivery plan for 26-27, which is underway, and we need to keep sight of the fact that sustainability is really critical to long-term success and maintaining momentum. So I think that's it. I'd just like to acknowledge the people on this slide, because this has been a project that lots and lots of people have worked on. I won't go through them in the interest of time, but thank you for listening.
Thank you very much, Dr. Ray. We'd be happy to take 2 quick interventions from the floor, if any.
Hi, good afternoon. Thank you for your presentation. I see you mentioned that sustainability is key to long-term success. Is there a plan? I see that the project ends next year, and a lot of activities that you're pushing in the project. Do you have a plan so that to ensure those long-term successes? Because I think there's a trend in the Caribbean when funding ceases, there's always a scale down of activities over in time.
Yeah, it's a really good question. Clearly, there will be less money, and you can't dress that up in any way. The upfront investment has been made, so getting anything off the ground is going to require upfront investment and then a kind of steady state. So, that's there. Money will have to be found from other, funds and partners, I guess, to support, for example, the staff that are in post. But that's where things like the pandemic fund come in, and strategically having those parts of the jigsaw means there's less risk. I think in terms of sustainability, we have an enduring partnership with CARPHA, which, really kind of existed before this project set up, and was part of the key to success, actually, of taking it forward in the time. And that will continue beyond that. Those relationships are established. A lot of the work that we can do in terms of technical support can be done virtually. So it's partly just about really stripping back the actual kind of cash required. So I'm hopeful that there's sustainability in this. It's also important that this is a project that we did in the context of a program of work at CARPHA that was already underway. And so in that sense, the leadership is in the region. It's not coming from us at UKHSA.
Do we have another intervention? Yes, please, go ahead.
Yeah, I see you mentioned a lot about testing and so on. What about stewardship? That could be individualized based on, your country and so on. So I didn't see much about stewardship, responsible use of antibiotics.
Yeah, that absolutely critical, which is why I have that so what slide in there in the end. And that work has been undertaken primarily by partners at PAHO and ICARS, so the research centre. So the work has been done. I wouldn't want to speak to it in too much detail because we haven't fundamentally delivered it. But going into next year, we are looking at working with a couple of member states who are keen to collaborate closely on this, and that will be a sort of key component with it, but also really keen to collaborate with the partners that have been leading on this work, so namely PAHO and ICARS. But yeah, good point. Thank you.
Thank you, Dr. Wright. Okay, so that concludes our session on CARPHA's innovation. Yikes. Just a quick announcement. Oh, here is Professor. Now, I was going to share that in the interest of time, we will not be breaking, but I will yield to Prof. Dan.
Hi, thanks very much. So we're going to switch into the next session. If you want to go outside and get a coffee, that's great, but we're going to move directly into the next session. And then at the end of the next session, we will go directly to the opening ceremony, because I expect the next session to finish at 6. And they're expecting us at the opening ceremony. There's going to be a big gala. So From here, the buses are going to go directly to the opening ceremony at around just after 6. So I invited the chair. So the next session is a sponsored session. And Dr. Richard.
Yeah, Mohammed.
How would you bet you?
Okay, my apologies. Trying to multitask.
Yeah, man. Listen to
Just
Eduardo
quick
Farina.
and they may be
Your mic's up. Yeah, that might be top.
We should move.
Don't go to the bathroom.
Let's go.
You ever see that video?
So good afternoon, everyone. We are a little behind time, so we will get going. My name is Kenneth George, Chief Medical Officer from Barbados, and I have with me.
Good afternoon. I'm Dr. Rachel Freeman. I lead global health at the Mount Sinai Health System in New York and am the executive director for the Mount Sinai Guyana Health Initiative.
So it's a pleasure. First, let me let you know, 10 minutes presentations, 5 minutes questions. We need to try to keep to that schedule. So it's a pleasure for me to introduce the first presenter. Her name is Dr. Onika Scott, and her presentation is Innovating Access, Evaluating the Impact of Telemedicine on Healthcare Delivery in Hinterland Regions of Guyana. Welcome and thanks. I'm really eager to hear your presentation.
Thank you both. Good afternoon, colleagues. Testing, all right. So I'm happy to present to you what we in Guyana found